Good evening, everybody. Welcome to TNSCON 2021. On behalf of the Executive Committee of Telangana Neuroscience Society and the Organizing Committee of TNSCON 2021, I invite you all, I welcome you all to this two-day conference, the first of its kind, all virtual conference. We are
apart from guest lectures by national and international faculty, there is a special session this year where two of our senior-most teachers in neurology will be presenting cases where they were also clearly perplexed or clean bowled. And the organizing committee, especially the scientific committee, deserves a special mention for arranging the lectures, and they have left no stone unturned to churn up a good scientific program. And hope all of you enjoy and relish this academic feast, and hope to see all of you in person in the near future. Thank you very much.
Thank you, Dr. Murthy Garu. Now I invite Dr. Subhash Chaudhary Garu, the Scientific Committee Chairman of TNSCON 2021, to just introduce about the program. Dr. Subhash Chaudhary.
Good evening, one and all present here, and thank you for joining us today for the fifth TNS Conference 2021. It's our pleasure to have the esteemed guest in today's virtual conference. The concept and the theme of this TNSA conference, as already told by Dr. Murthy, is pandemic to vaccine, evolution, clinical neuroscience, learning and practice. Though the time period is less, we promise you the content with quality and practically useful. I would like to thank and acknowledge all the guests and supporting team and other members of organizing team who worked hard to make conference successful. I hope this will be a successful conference. I'm extremely happy to be a part of this fifth TNSA conference and a part of the organizing committee. I wish everyone to successful and truthful conference. Thank you. So now I would start the session. Now our first speaker is opening batsman, Dr. Rohit Bhatia. So he will be talking on gray areas in demyelination. So I think definitely you will have a lot of questions, and he will definitely answer all your and clear your doubts, because I have attended previous his lectures, which are very good. So I invite both the chairpersons, moderators, Dr. Buchi and Dr. Vekateshwarlu Garu, to chair the session and introduce the speaker. Thank you. Welcome, Dr. Buchi Garu, Vekateshwarlu Garu, and also Dr. Rohit Bhatia to start your session.
Good afternoon, everybody. At the outset, I thank the Organizing Committee of TNSCON 2020 for asking us to chair this session. And I'm quite happy to have Rohit Bhatia as to start today's conference, virtual conference. To start with, I'll ask our Emeritus Professor, Andhra Medical College, Dr.K.Vekateshwarlu Garu, to introduce the speaker.
Am I audible?
Yeah.
Can I have the first slide introducing Dr. Rohit Bhatia? Do you have that slide with you? Anyway, I have it with me. I'll read it out. Thank you, Dr. Rohit Bhatia, for accepting to invite this invitation to deliver a lecture on this very interesting topic. Dr. Rohit Bhatia needs no introduction. He is a very well-known figure in the field of neurology, both nationally and internationally. He is presently the professor of neurology at All India Institute of Medical Sciences in New Delhi. He has a fellowship on cerebrovascular disease from Calgary, Canada. He is a resident. He is the president of the Indian Stroke Association. He is also the convener of the Autoimmune Indian Academy of Neurology and ex-board member Multiple Sclerosis International Federation. His currently active research prospects include multiple sclerosis, neuromyelitis optica spectrum disorders, ischemic stroke, and intracranial hemorrhage. He has woven more than 200 publications to his career. He has written 2 textbooks, one in clinical practice of multiple sclerosis, another in emergencies in neurology, and then he has won Quality and Safety Award for stroke by American Academy of Neurology in 2016. He is the lead contributor to the CNS-TB guidelines for extrapulmonary tuberculosis, Government India Index TB 2016, and is also a member of the National Stroke Guidelines 2016-2008. I have great pleasure in handing over the mic to Dr. Rohit Bhatia. Please, sir, take it forwards.
Thank you very much. I sincerely thank Telangana Neurosciences Society for giving me an opportunity to speak on this topic. Thank you, Dr. Buddhi Raja and Dr. Venkatesh for introducing me. I'll just quickly now take to my slides. So, are my slides visible to all?
Yes, sir.
So I'm supposed to speak on the gray areas in CNS demyelination around the diagnosis and management. I will touch down this talk in a bit of pragmatic manner and how we see the cases routinely in practice and where we feel that there is still some lack of clarity or we are still learning from these cases. So I will bridge my talk with elements of diagnostic issues, acute treatment, and also long-term treatment issues in patients aligned to various CNS demyelinating diseases. So let's go to a scenario which is very common in practice. A 25 years old female comes to us with acute visual loss in one eye, preceded by mild pain. This evolves over about 5 to 7 days. There is no history of fever, vaccination, or drug intake, and she doesn't suffer from any pre-morbid significant medical illness. The past history is unremarkable. Her peak visual acuity at presentation is 6/60, which is extremely poor, and the color vision is also impaired. We find a normal fundus, but she has a relative apral pupillary defect. So when a person like this presents to the emergency scenario, what rings into your mind immediately is that she's a young female who has this 5 to 7 days history of uniocular visual loss. There is a mild pain. There is no preceding history of definitive medical issues. So what comes to your mind immediately is, am I dealing with the diagnostic possibility of optic neuritis? When you start with this diagnostic possibilities in mind, you always think about various other differential diagnoses parallel coming to your mind. Am I dealing with something behind the orbit, in the orbit? Am I dealing with something which is compressing the optic nerve? Am I missing on some vascular cause for the optic neuritis? Could it be some kind of an infection? Could I be missing on some drug history which the patient is not very clear about? So when all of this is excluded in your mind and you work on it parallel, you think, no, maybe she's a young female. It's a uniocular vision loss. So possibility of optic neuritis comes to your mind. When it comes to a possibility of optic neuritis, you tend to obviously examine these patients with a different frame of mind. You need to involve hemogram at the baseline. You will do a biochemistry at the baseline. You will look at a detailed immunological profile, which includes, of course, the routine immunological antibody workup, including NMO, including MOG, and the other profiles that you would routinely be doing. You would image the brain and the spinal cord with contrast, and you would do a CSF. Now, there is a possibility that in spite of doing all of this, you come to a dead end and you are uncertain as to what this patient has. And that is what typically happens in demyelinating diseases, that you may have a first event which could transition to one of the following. One, it could behave like an NMO spectrum disease, and you may have an isolated recurrent optic neuritis or a recurrent myelitis. Or you may investigate these patients and you find that, no, I couldn't find anything. Could it be just a monophasic demyelination? And you want to be comfortable with that because you don't want to give a diagnosis which has long-term implications both for prognostication and diagnosis and management. The first thing also comes to your mind at that moment is, am I dealing with a patient of MS who's just come up with me to the first attack, and maybe she will transition or she will develop MS in the near future. So you always like to look at different antibodies, and once you make a point that everything is negative, you again go back to a situation that makes you uncomfortable for both diagnosis and management. So when it comes to these various kind of overlapping disorders, in practice, out of which the MS is most common among them, you tend to think of many different parallel etiologies in mind, and as I've already alluded to, and you start thinking one by one as to how I evaluate. Now let's look at the whole gamut of this first case. This could have been an MS optic neuritis. You would have said maybe she is clinically isolated syndrome. Or is it a seronegative anemospectrum disease or a MOG antibody disease? Or is it a monophasic thing? Then you start thinking, am I going to wait for time to show me the diagnosis? Or am I going to do something more? Or should I look more into the whole available evidences to really pinpoint? And how should I now manage this patient? Should I wait? Should I open her the possibility of immunomodulation? So all of this is a gray area when it comes to managing such kind of patients in practice. Now let's look at a scenario of this patient in a different way. You have a patient who's come to you with optic neuritis, and you have an enhancing lesion in the optic nerve on the same side. You do an MRI brain and it doesn't show any lesions to support the diagnosis of MS. You did a cord MRI which doesn't show LETM or doesn't show any evidence of skip lesions. You're not comfortable now. But you did a CSF, you did all antibodies. The antibodies were all negative. You couldn't find really anything in the CSF. Routinely was absolutely okay. But then suddenly you get a report which says OCB positive. And you made sure that the OCB was done in a proper manner. You made sure you got a serum and a CSF done at the same time. So now you think, does my patient have dissemination in space? Does this patient have dissemination in time? And does this patient actually qualify for the diagnosis of MS? So if you look at and I will touch down on the criteria in the next two slides. So this is not an uncommon scenario that you may come up with. So if you have a patient who's got a a segment of optic neuritis, but no dissemination in space by the imaging or previous insult, your dissemination in space is out. You cannot tell this patient has dissemination in space. You didn't find evidence of enhancing lesion elsewhere, which you may or may not need, but your OCB is positive, which gives you a direction that it may be a dissemination in time. So would you now call this patient as MS? You didn't find anything on the brain MRI at all. And this optic nerve doesn't qualify for the diagnosis of dissemination in space alone by the McDonald's 2017 criteria. So this brings you to a crossroad as to how you want to actually now assess this patient and how best you would be able to prognosticate this patient. Now let's look at this scenario in a different manner. You image this patient and you found that this patient has got evidence of 2 to 3 to 4 or 5 typical discrete lesions in the brain. You had the optic nerve, which was enhancing, but there was nothing in the cord, and there was no enhancing lesion in both the spine and the brain MRI, and the OCB is negative. So you have evidence of dissemination in space, but by the criteria of McDonald's, the symptomatic side, if it is the optic nerve, should not take you to a qualifying point of making a dissemination in time, because they don't consider it as a very specific entity. So you're back to the scenario that my patient does have dissemination in space. She's got an optic neuritis and the OCB is negative. And many of us sitting here and now, listening to my talk would immediately say, there is clear-cut evidence on the brain MRI of discrete lesions. This is not like an ADAM. And this patient is a young female who's come to you with optic neuritis. Why should we unnecessarily wait for the criteria to really suffice? We inherently know that this patient is likely had subclinical disease, but we're not able to prove it because we don't have an enhancing lesion and we don't have an OCB positivity. So these are the usual scenarios that we face in practice because we need to label these patients with a specific entity and prognosticate them and counsel them regarding treatment. Now, if this was the other scenario, for example, this patient had come to you with a cord disease, and you had the cord disease which was showing evidence that there is a presence of a monofocal lesion, and this patient has got an enhancement of the same lesion. You did an MRI brain which shows you dissemination in space. So you had dissemination in space, and the focal cord lesion, which was symptomatic, was also enhancing. This favors dissemination in time by the criteria. You have dissemination in space. Even if your OCB is negative, it doesn't bother you, because you think now that I have a young female who's come to me, or a young male with a focal cord myelitis. There is clearly a discrete lesion. It is enhancing. The brain is showing evidence of dissemination in space, and I've ruled out most of the other things. I should be more or less comfortable in opening up the diagnosis that it is most likely relapsing remitting MS by the McDonald's criteria. So these are the scenarios which bring us back into the criteria. And these criteria sometimes do not always help us in practice. And that's where the gray area for the criteria lies. And I've already told you that in the new McDonald's 2017 criteria, the optic nerve is not really counted as one of the symptomatic sites which could be taken into the criteria, because they feel that it is not very specific and many conditions could involve the optic nerve. However, both the symptomatic and asymptomatic lesions could now contribute to dissemination in space and time, and OCBs are included as a criteria for dissemination in time, and both symptomatic and asymptomatic lesions can be used for both dissemination in space and time. So the third scenario, where the patient had a cord lesion and the brain showing silent lesions, would clearly categorize into the diagnosis of relapsing remitting MS, not the first two scenarios. But if you look at the Magnum's 2016 criteria, they actually include optic nerve as well. So if you're using a different criteria, you may still be able to say that I think my patient possibly has MS. But then these criteria are made sensitive, but at the same time, they want to make it more specific because of the implications to practice, implications to prognosis, and implications to long-term disease management. But whenever possible, we may have to use our clinical acumen and the utility of the investigations to help us reach a possible diagnosis. So what is this so much noise about oligoclonal bands, and why sometimes they can help us or they can confuse us? So there are 5 key things to intrathecally produced IgG. In normal CSF, all IgG comes from the blood by passive diffusion, and it is polyclonal, and we generally will see a pattern in the CSF. However, if it is an intrathecal synthesis, then the bands in the CSF are not visible in the serum. And that's why it's a sign of potential pathology within the CNS. And that's what students must learn, and residents must learn, that it is always important to send a paired sample and use the best method like immunofixation if you're really looking for oligoclonal bands in the CSF. This is one of the meta-analysis from this paper, which shows that if you use healthy controls population who have not really, healthy means controls which don't have CNS inflammatory disease, the specificity of the oligoclonal bands is very high for making a CNS inflammatory disease like demyelinating disease as a strong possibility. However, if you see on the right side, if you use all forms of CNS inflammatory disease, the specificity actually moves to the right, which means it falls. So that's where the problem of oligoclonal bands is, that you have to look at the clinical scenario in which you are actually using it. Doing it in a chronic meningitis or a pyogenic meningitis is of no use because it doesn't help us. It is important in scenarios where it is helping us in summarizing a possible diagnosis which we cannot offer completely from the available other informations. So it is also important that we look at the other CSF parameters like cell count, protein, and sugars, because it correlates well with inflammatory scenarios which are more likely to be more specific. For example, if you're thinking of an MS pathology or an MS diagnosis, we know that the CSF pleocytosis is minimal. And if we see a CSF which is 300 cells, it is very unlikely that it is MS. It could be more like an NMO or a Mach spectrum disease. And of course, method of estimating OCB. So there could be 4 potential scenarios. Clinical suspicion and imaging is not specific, where it may help or may not help actually. Clinical highly suggestive but no DIS or DIT it may be prognostic, like in our scenario of the first case, where it is possible that patient has DID and has a potentially now a higher risk that she or he may convert to MS in the future. And of course, clinically not specific, but others are present. And then again, the OCB may help us refute or include a diagnosis. But more important is that you have a doubtful clinical history and it doesn't really fit into a demyelinating disease or a specific demyelinating disease, the presence of OCB is highly doubtful as far as its specificity is concerned. So I think we need to look at oligoclonal bands with an all possible elements in our mind to really say whether they are helping us in reaching a diagnosis or not. So if you look at an MS patient or a NMO spectrum or a MOG antibody patient, most of the MS patients will tend to have OCBs. And of course, between the NMO and MOG antibody, it may slightly be higher in MOG and NMO, but maybe lesser frequent in MOG antibody. But it does not mean that in all these three scenarios, you cannot find oligoclonal bands. So you have to go back into the clinical scenario and then maybe adjust for the different parameters that the patient has, both clinical, radiological, and then maybe use OCB as an additive tool in the diagnosis. So if you look at the first scenario, and this slide is specifically I put for if there are residents on board, is that if you have a patient like ours who did not fulfill the dissemination in space criteria at all because she had normal MRI, but she had OCB positive, and she has a optic, and she has an optic neuritis. So if you fulfill the criteria for dissemination in space, then you look for this mnemonic called mimics. In this mimics, it is you look for meningeal, indistinct cloud-like lesions, microbleeds, infarct, cavities, and sparing of Ewell fibers or symmetrical lesions which favor a leukodystrophy. If you have seen all of this and it is excluded, and then you can say my mimics probably are absent in the MRI, and there is a possibility that my patient still has MS. So if you have a patient whose DIS criteria which is not fulfilled, then you look for infratentorial lesions, spinal cord lesions, and juxtacortical lesions, and you look for meningeal enhancement. Again, the mimics will come here, along with area postrema lesions, macrobleeds, infarct, enhancing patterns of different characters. So you want to rule out a cerebrovascular disease, you want to rule out a metabolic disease, NMO spectrum disease, you want to rule out infections and inherited disorders. So if you ruled out pretty much all of these on the mimics, then you can say that even though my patient does not have DIS criteria fulfilled, but the clinical scenario is strong, there is a possibility that my patient could still be having MS. So it brings you all into the same a focal kind of a thought process, but of course using imaging as an important tool in the first case. So another scenario which is not uncommon is when you find young people or middle-aged people coming to you with a rapidly progressive myelopathy of 5, 7, or 10 days duration, and you find that there is a long segment myelitis and there is a focal enhancing lesion in the cord. So in that scenario, you may have an IgG NMO negative, and then it makes you concerned that what this patient could be having. Is my patient a monophasic patient, or is this patient going to be a recurrent? Similarly, I will show you another case of a 19-year-old female with recurrent hiccups and vomiting in 2012. She had these brain lesions which were there in deep diencephalic region, but nothing in the brainstem or the cord. And then she later had, a year later, ataxia, and she was being seen outside, and they thought it is MS and was put on subcutaneous interferons. And this is the brain MRI at that time showing distinctive brainstem lesions. Now, she also had a normal MRI of the spinal cord, but in 2014, she was admitted with us with hiccups and vomiting of 2 weeks duration with no other neurological disturbances. And you can see an area postrema signal intensity lesion, normal MRI, normal cord, but she was NMO IgG positive. So for the initial 4-5 years or 2-3 years, this lady had this symptomatology, which was thought to be probably related to something in the brainstem, but was not potentially thought to be of NMO origin, because the symptoms are sometimes misleading and people visit gastroenterologists for hiccups and vomiting and so on and so forth. So like the first scenario which I showed of just an isolated LETM with NMO IgG negative. So the problem is when we look at the revised NMO criteria of 2015, if you are a seropositive, then there is no problem. You can have just one of these attacks typically in any of the parts of the brain. And if you are aquaporin 4 positive and you have the one core criteria positive, then you are clearly NMO spectrum disease. But what about the patient like I showed you with a long segment myelitis who's NMO negative? You either call him seronegative, or you wait for the other event, or you look for evidences of other core criteria. That patient had no other core criteria. He never had optic neuritis, he never had brainstem syndrome, he never had anything else. But he did have an MRI finding which was very strongly suggestive of a long segment myelitis. So in that scenario, you may have to use your wisdom and say that if this patient has a second attack, what am I going to do? Maybe this patient may have a worse attack. So in that scenario, it's a gray zone. That should we really put these people on immunosuppressive therapy? Should we still call them seronegative, NMO spectrum disease? Or these are just any forms of what we call sporadic myelitis, which we used to think of years ago when NMO antibody was not available. And many of these patients would be treated as any kind of so-called post-infectious myelitis. The other entity, which is like someone having recurrent isolated optic neuritis, and you do not have anything to offer in imaging, you have antibodies which are negative, and now you're confused whether I should call this MS or I should call it chronic relapsing inflammatory optic neuropathy, or whether should I label it MOG or I should label it NMO spectrum disease. This is the patient which is not uncommon in practice. 2, 3, 4, 5 episodes of recurrent optic neuritis. You did everything under the roof, but you couldn't find anything. And these are seronegative. They have normal MRI brain, they have normal MRI spine, and they have no other markers positive. So these are typically the patients which are labeled as chronic relapsing inflammatory optic neuropathy, or the CRION. And then we think whether these are MOG patients which are seronegative, or whether these were some form of an MS which has eluded you over the time. But we know more and more about them, that there is a strong relationship between CRION and MOG, rather than CRION and MS and NMOSD. So there is a strong relationship building between CRION and MOG antibody positive disease. And this is reported from a series of 122 cases of relapsing optic neuropathy, where the authors said that you should have optic neuritis with at least one relapse. There should be objective clinical dysfunction. You should be NMO seronegative. You should have inflamed optic nerve on imaging. And of course, a very, very, very strong response to immunomodulation. So they exquisitely respond to steroids. And the moment you withdraw them, they will have a relapse within the next few days. And sometimes even at the closer point of stopping steroid, they have a threshold, and you reduce that threshold and they will relapse. And they do very well on long-term immunomodulatory treatment. We also looked at our MOG data just a while ago in last year, and we found that within our patients, we had a group of just 20 patients we reported. Patients with recurrent optic neuritis, unilateral or bilateral, were extremely common. And bilateral ON and unilateral ON was quite common. So I think any patient who presents to you with isolated optic neuritis recurrent, without any evidence of imaging findings, you should seriously contemplate to look for MOG antibody, because these are patients generally of MOG positivity. I do not know whether that's an epiphenomena or truly a causative entity. That's something we can always debate upon. But yes, there is a strong relationship with CRION and MOG antibody positivity. So CRION is blurring towards MOG, and we don't know. But yes, we do have seronegative people who are still categorized as CRION-based disease. So that brings us to the entity of the MOG antibody, which has so many things to do. We know that there are children who present with Adam-like illnesses, and they are categorized now more and more as MOG antibody positivity. You could have encephalitis, but most common of it is optic neuritis and focal myelitis, especially at the conus region. So there are some recommendations on diagnosis and antibody testing. And what is more important, that you look for permanent simultaneous or usually high optic neuritis in these patients, patients with conus myelitis and who are left with sphincter and erectile dysfunction, and children who are diagnosed as ADAM, especially recurrent ADAM. And of course, you need to have clearly a neurological entity which is of myelitis or optic neuritis, a radiological feature which suggests that there is a possibility of MOG antibody disease. So for students here, I mean, if you have three basic categories where you are blurred for the diagnosis and we are uncertain many times, in the neuromyelitis optica spectrum disease, you need to have a large posterior-based lesions, generally bilateral. In MOG, it is again anterior, but there is a lot of perioptic nerve sheath enhancement. That is very, very important. And of course, MS, it could be a focal short segment, generally posterior, like a retrobulbar region. And of course, in the NMO, we have a long segment. In NMO, in MOG also long segment, but generally more caudal in the conus region. And of course, in the MS, you have skip lesions. And these are the central parts of the brain which are more frequently involved in NMO spectrum disease because of high IgG aquaporin 4 levels here. And you get these brain lesions also surrounding in these lesions. Whereas in MOG, antibody disease, there's a lot of gray matter involvement, especially in children. And you should be careful about that. And in MS, of course, it is very classic, as you all know. So look for these three things to help you slightly, clarify the gray zones when it comes to the diagnosis of these people. Another entity which sometimes can confuse you and has been recently over the years been dominated is an entity called Clipper syndrome. This is one of our patients who came to us with pancerebellar ataxia and had some fluctuating course, but lost to follow-up because of the lockdown, and then later came to us. Now, she also gave a history of optic neuritis at 14 years of age. We are not sure, and this was the MRI finding. You can see a very extremely enhancing lesion in around the fourth ventricle, and anyone could say that this could be even a lymphoma or anything else, but this is a long story. And of course, in the biopsy, she had features of immunopositivity and cytotoxic T cells, a lot of them, and there was a possibility of clippers on the biopsy in this patient or a cerebrolitis. So this is a very classic imaging of a Clipper syndrome. You may get sometimes misled as to what is this going on in the brainstem. There is so much of inflammation, and they have typically this pepper-like, dot-like enhancement, which is extremely aggressive in and around the pons and the brainstem. And this is another image from one of the papers which is published previously by another author. So in the Clippers diagnosis, which is called the chronic lymphocytic inflammation with pontine perivascular enhancement and responsive to steroids, there is a subacute pontocerebellar dysfunction, and it is very responsive to steroid therapy. And of course, you have this typical gadolinium enhancing nodules without ring enhancement and the T2 hyperintensity. So you should be, for a given patient, take a clinical history, demographics, imaging, biomarkers, evoke responses, exclusions, and disease behavior in response to treatment if you want to make a diagnosis and get out of the gray zone, because all of this will help you in making a diagnosis. So what happens as far as the acute treatment goes for such people? Now, we would always like to treat these patients, let's say the first scenario. I'll come to now the treatment-related gray zones a bit. We treat these patients with steroids for 5 days. At the end of the 10th day, the visual acuity is still 6/60. So are you going to sit on this patient? Let's say this was a patient of any form of relapse. Forget if it is NMO, forget if it is MOG, forget if it is MS. Let's say it is any form of acute optic neuritis and you're certain it is an optic neuritis. So you can't just sit on this patient because this is the right time that this patient is going to benefit. I don't have randomized controlled trials or a strong backing of evidence to say that. But this is by a general perception and a clinical equipoise, because we're treating aggressively NMO, we know that these patients may require. So in the acute therapy, there is a stabilization and we want a rapid and a complete recovery. So if we lose this opportunity, like treating between from MPS to Plex or to IVIG, there is an unclear zone here, and people are not certain. We see so many patients of optic neuritis which are presumed to be MS related. They are given steroids. They of course, we know that in MS, most of the patient will make a good recovery, but there could be patients of MS and NMO and MOG who will not make a good recovery with steroids alone. So they need to move up the ladder, and the next ladder is either Plex or IVIG. So is it that we want to give oral steroids or high-dose IV steroids? I think that there is very poor data to support that we will give oral versus IV. So what my strong suggestion from this meta-analysis previously published was they did not find any remarkable difference between the oral and the IV, and the oral doses have to be extremely, extremely large, like 500 or 1000 milligrams of oral. So I think we stay put with the management with IV high dose methylprednisolone for about 5 days. But if the patient is not improving, then you need to move up the ladder to plasmapheresis if that is available. And if it is not available, then you can potentially tend to consider the use of IVIG. And this is one of the previous evidence-based guideline from AN, which also says that it could be used as an adjunctive treatment for MS relapses. But unfortunately, patients are not offered that. And if there is a patient who's got a bad relapse and it doesn't get better, then we feel that what to do. If a patient is not a candidate for any other therapy, are we offering plasmapheresis in routine? I'm not certain that is being offered. But if it is a patient of NMO, we tend to offer this. So there is a clear gray zone when it comes to the management of relapses of MS versus relapses of NMO or a MOG antibody disease. And I think we should take a relapse as a relapse as a relapse and not really try to define it and differentiate it. And if your patient is not benefiting, we must go up the ladder and give the second level of benefit, because that's the most important phase. This is another paper of plasma exchange in CIS and acute worsening of thing. But what the problem in this paper is that you have time to TPE so variable that people have been given plasma exchange from the onset to up to 145 days. So I think this doesn't give us that kind of a clear-cut answer, and that's why the response after the the EDSS after the institution of plasmapheresis as given below is not very strongly different. But if you really see that in spite of the time difference, both CIS and RRMS patients did respond to plasma exchange by improvement in the EDSS score. But of course, among patients with secondary progressive MS and PPMS, there was hardly any major benefit. So there was a potential benefit, but it's a retrospective data, and the time to do TP is so variable that I don't think this will be able to give us a very strong evidence base. But on a personal note, I feel that if you have a bad relapse, you should potentially give the patients benefit of plasmapheresis. And as far as IVIG is concerned for MS, we are not very certain because these are mixed reports of retrospective data or a prospective small patient data. But, when it comes to a pragmatic scenario and we have a patient who cannot be given Plex and who's had a bad relapse and is not improving, we can always vouch or we can always debate on the cost effectiveness and the evidence behind use of IVIG. But I do not know whether it would be wrong for me to say that if you cannot offer plasmapheresis for a reason more than one, you should potentially consider the use of IVIG. We do not know which of this patient may respond, and for him, it may be a turning point as far as the deficit is concerned. And I think even though the data is small and data is not prospective, it is not randomized, I really do not know whether we should not give the benefit to patients when it comes to bad relapses to treat them. So from the perspective of acute therapy, I would like to show you this couple of slides about the response to treatment, especially in NMO as well as the MOG patients. So there is always the variation in acute therapy responses, both for the MOG and NMO compared to MS, so that the MOG and NMO tend to respond somewhat lesser compared to the MS patients. Some of them may be left with significant sequelae, and we all very well know about it. So I wanted to show you this particular paper, which talks about the initiation to plasma exchange delay. And if you look at this paper, as I told you about the time to plasmapheresis recently, if this is the baseline EDSS and goes acute and this is the delta change, you obviously want your patients to reach back to the baseline with a good recovery. And of course, you don't want patients to do a poor recovery. And this came from this paper very clearly that in patients, as the delay from the onset to Plex happened for the bad relapses of NMO or relapses of NMO, the patient's recovery was poorer. And it is obviously clearly showing you even the strata of improvement that the earlier you do it, the better is the patient's outcome. So do not think of start doing a plex only after 20, 30, 40 days of steroids. If your patient is not showing improvement in day 5 or day 7 and you want to go by a sweet spot of what is the best time window, I think 5 to 7 days should give you enough parameters. And if you think by day 2 or day 3 that the patient is too bad and too severe, relapse, you should even start parallel the plasmapheresis. So I think it is very, very critical for us to understand this time window of plex, especially in management of bad NMO and MOG-related relapses. So this is what was shown in this. Now I come to the last part of my talk is about the chronic management of the. Do I have about 5 minutes or?
Yes, you can proceed.
Okay. So I would now like to talk about, after talking about the acute treatments, I would now like to talk about the management on long term. And there are a few gray zones in the management, and we are strongly now learning progressively about these. Is the two strategies, let's take MS first. There are two strategies which can be incorporated, the escalation strategy and the induction strategy. If you look at what we do in practice, most of us, we are doing the escalation strategy. We go from treatment A to treatment X, and as we go up the ladder, the toxicity and the efficacy is higher and higher. And as we do inductions, is higher. And we start always with a baseline platform therapy where we think that patient is likely to be benefited, but patients is likely to be more safe. And I would go up the ladder as I need. But the induction strategy says the other way around. You start with a more stronger and aggressive therapy first, you hit the disease hard, and then you de-escalate over a period of time. I think most of our patients prefer the escalation strategy when we discuss about these options. And because we lack strong evidence to say that escalation therapy is the best way to go, and we cannot really predict the individual courses of patients, we still are somewhere between in that gray zone still, and we really don't understand what's the best option. But we know from a lot of data that most of the drugs that are available, which we're using for platform strategies, you look at this assessment of the meta-analysis of the probability of a patient doing well and for relapses and for disability. You will clearly see that most of the drugs that we're using in practice at the moment, like interferons or dimethyl fumarate or teriflunomide or glatimer or azathioprine, they generally have a relatively moderate to low evidence for relapse rate prevention, and similarly for disability worsening over 24 months. But for drugs which are up the ladder, like fingolimod, natalizumab, or alemtuzumab, they do have a moderate to high grade of relapse prevention, and the same way, probably disability worsening as well. But it is not that if you're using alemtuzumab that the likelihood of disability worsening will be extremely great. It is not necessary. The data doesn't always support that. So when we go up the ladder in the first line or the second line of treatment, we follow a path. And in this path, we sometimes meet uncertainties. And one of these uncertainties is that we want to treat these people aggressively. At the same time, we want to be safe. At the same time, we want the cost to be low. At the same time, we want the patient to be more satisfied and he has to not take the medications too frequently. So we are somewhere housed between these areas that as to what is the best way forward for my patient. Whether I should give a patient a more pulsed reconstitution therapy, which patient has to take intermittently, like there is a lot of progressively increasing use of rituximab for patients who are failing the initial therapies, or I should go with a moderate efficacy drug, which is oral, but the patient is more comfortable and is more safe. So if you look at managing a breakthrough disease, especially when you have started someone on a platform therapy, that's where the main gray zone is. Should I go to a lateral switch, which means if I'm giving a patient interferon, should I go to dimethyl fumarate or teriflunomide, or should I straight away escalate to natalizumab or off-label rituximab or other drugs, is something we want to make a switch on. And that switching is decided typically on the basis of patient disease course and a disease behavior. And one of these scores that we can use sometimes is called the modified Rio score for poor initiation or poor response to therapy. And that is based on relapses and presence of new MRI lesions. And that will help you sometime decide. And you can make a decision for the platform agent switch or a second line switch or a third line switch depending on what your patient is potentially scoring on this. But I don't say use this score as an absolute parameter. Please don't take me wrong. But these are the scores to help you get some expert guidance when some of them are validated for data sets, that yes, if you have this patient, then the likelihood of a patient who's got a high score with high relapse rate, new T2 lesions or new contrast enhancing lesion, obviously has a higher risk of disability worsening or disease worsening compared to someone whose MRI is normal and a relapse is 0. So that it is not very rocket science about that. And of course, I bring that to my last slide, talking about this kind of a management strategy in MS, is that when you started the initial choice of therapy, you looked at this patient's EDSS, relapse frequency, adherence, comorbidities, and you found that there is a suboptimal effect. Now, in that, as I told you, you can use a modified Rio score, or you can use the Cantor Canadian guidelines, or use your best wisdom and acumen to decide that I want to make a lateral switch or I want to make a high switch. If I see a patient who's relapsed severely in the first 1 year, and the patient has got extremely increasing lesion load in the MRI, or has relapsed more than once in the ensuing 1 year, there is no question that patient doesn't move up the ladder. Giving platform therapy is probably a no-no, because you are wasting time and increasing disability. Similarly, if you've started someone on a high therapy, you go back after 2 or 3 years in a de-escalation mode, and then you look at the preceding activity and make a choice based on many factors. So if you see a patient of a first episode of non-MS or an unclear demyelination, like the first case which I showed, and you have this patient aquaporin 4 positive, you have treated acutely, the chances of relapses are very high, then you need to treat these patients on long-term immunosuppression. That's very, very clear. Don't keep these patients just on steroids. Please start immunosuppressive therapy and slowly taper off steroids over the next 4 to 6 months. If you have a MOG antibody patient and there is an acute treatment, there is a potential thought that patients may have a lesser chance of relapse, which I totally disagree with. In pediatric ADEM, yes, you may not have a relapse, but in adults, there is a potential whose rate of relapse is high, because long-term studies have shown that if you longer follow up these patients, they have a high risk of relapse. So I would strongly urge that if you have a patient who's got an optic neuritis, myelitis, and you found a MOG antibody positive, you should treat these patients on long-term immunosuppression with whatever choice you want to make. I'm not discussing on the choices of therapies. If you have no antibody, like the first case, like I showed, and you have a chance of relapse which is grossly uncertain, we need to individualize decision. Let's say you had a long segment myelitis with a seronegative NMO, seronegative MOG, and you don't think it's MS, of course. How can you be certain that if this guy has a bad myelitis, he's going to revert back to the normalcy? So I would discuss this with the patient. I will explain him the uncertainty. And I would ask if he's willing to be put on immunosuppressive therapy if I've ruled out most of the other possibilities. And then open up the diagnosis and tell him. And if he agrees, then maybe consider for long-term immunosuppression. Of course, if a patient has on follow-up an MRI supportive of MS, you change the treatment. If you have MRI abnormal but not supportive of MS and antibodies remain negative, you treat these patients with immunosuppressive therapy. But if you have no MRI changes and antibody remains negative, you may still consider, if a patient has a relapse, to be treated with immunosuppressive therapy. The same story of CRIO and the same story of isolated recurrent myelitis. So there is no change if a patient relapses and you've been clearly be able to demarcate it's MS or no MS. So I think as we stand on the crossroad, there is a lot which lies behind the tip of the iceberg. And there are these kind of gray zones will be pragmatically always in practice. But as we are learning more and as imaging and biomarkers are teaching us more, we are getting more and more confident and patients are able to understand better why we are making the correct choices for them. So thank you, sir. That's my last slide. And I thank you all for the patient hearing. Sorry if I took about 5 minutes extra.
Thanks, Dr. Rohit, for your exponential presentation on both diagnosis and management in the gray areas of CNS demyelinating disorders. Any questions? Any questions from the audience or from the chat box? Because I didn't see any questions from chat. Doctor, Yeah, Dr. Venkateshwarlu.
Am I audible?
Yeah, maybe you should.
Actually, Dr. Bhatia, previously, in a monophasic MOG event, whether it is optic neuritis or myelitis, in a MOG positive illness, there was a consensus that you treat them in acute phase with steroids and then repeat the test emoji test after 6 months. And only if the test is positive again, you put them on a long-term immunosuppression. Is there a change in the strategy?
Sir, as I just showed in my slide, is that if you look at the long-term data of patients of MOG, and there are only few studies published with long-term follow-up, it clearly shows that if you longer you follow up these patients, the more apparent it becomes that they relapse very frequently. And if you have a MOG antibody disease at the baseline and patient has an optic neuritis or a myelitis, I'm not bringing in the pediatric ADEM because it may actually behave differently and it may be monophasic. But we cannot say in the beginning that, and we cannot be 100% certain that MOG is a monophasic disease. I think in adults, it behaves much lesser as a monophasic disease than in pediatric population. My personal, clinical, you can say, suggestion or my expert opinion says that in patients who have presence of optic neuritis and MOG is positive at baseline, and you believe that assay quality and it has been done from a good lab and it correlates and you've ruled out MS and the presentation is very typical on the MRI, I would strongly suggest that these patients should be immunosuppressed for a long time. I think waiting is not a good thing because sometimes these MOG people recover slowly in the first event. And if a second event happens, we cannot be certain that the recoveries will be same. And I think in adult onset MOG is probably very different from the pediatric onset MOG. And I think adult onset MOG relapses quite frequent.
Okay, Rohit,
Thank you.
There is a couple of questions from the chat box.
Yes,
one is, what factors influence length of lesion in NMOSD?
Sir, as far as the factors for length of NMOSD concerned, there is probably no clear data on that. When we talk about longitudinal extensive transverse myelitis, it's a phenotype of the MRI. And within this phenotype, neuromyelitis optica as an aquaporin IgG disease is one type of long segment myelitis, causative or etiological classification. We do not really know whether within the NMOSD there are features which will influence the length of the lesion. I think wherever aquaporin 4 is high, especially the cord and the ependymal, periependymal structures, the implication could be related to the presence of or the depth of or the interaction of these aquaporin 4 channels to the aquaporin 4 antibody. So I don't think that there is a very strong factor which could influence the length of the lesion in NMOSD.
Actually, in our ward now we have one young girl who presented with 2 episodes of only spinal cord, like myelitis, at 2 levels. So MRI showing 2 levels, but the brain MRI is normal. 2 times CSF was done, which was normal. Only thing red herring is she had febrile episodes previously. Our algorithm bands were negative or visual acuity is normal. So I don't know whether we can label them as MS or we need to.
Sir, you will probably, if the lesion lengths are clearly longer and patient has recurrent inflammatory pathology, which is suspected of recurrent only isolated myelitis, like a recurrent optic neuritis, and patient you have worked up diligently and you have not been able to give another possible diagnosis, MR brain remains normal, unless you are really looking at very discrete skip lesions and you think it may be a preferential cord-like presentation of MS, this patient probably qualifies for immunosuppressive therapy, not for MS therapy.
Actually, still we are working up. Her collagen profile is normal. Her other aspects are normal. Aquaporin report has to be is still waiting. So following that, we'll plan the further.
Aquaporin 4 is also negative. MRI is not suggestive of MS. MOG is negative. and you've seen everything else is negative, then she'll be treated as anyone who has a relapse from a monophasic illness, but is not been able to categorize into a specific seropositive disease or an MS, so qualifies for the treatment with immunosuppression.
There's one more question. How frequently should we do MRI brain or spine in follow-up to know for treatment response?
That's a good question, sir. And honestly speaking, we don't have the right answers. But I can tell you pragmatically is that what eventually a patient wants. A patient wants and a doctor wants is that are two things. My patient does not relapse clinically, and my patient preserves the stability of her or the ability of her ambulation, her ability to do things. So, which means we want them to preserve in the best EDSS possible. Similarly, if both the patient and we are in agreement in the outpatient clinic that she's doing or he's doing great, everything looks great. I think when you first start treatment, it makes possible sense to image at the interval of 1 year just to see for safety as well as to see if MRI remains stable, because we are uncertain in the first year how the patient behaves. A lot of people in the past have been debating on annual MRIs of these patients, but none of the diagnostic criteria, none of the switching criteria, whether it is Cantor criteria or it is a Rio score, really talks alone about MRI as a justifiable point to switch treatment. And there is still a big debate that if you find a new lesion, 1 or 2 new lesions on the MRI and follow-up, and patient is doing extremely great, will they qualify for switching to a treatment? I personally don't switch if I find 1 or 2 small tiny spots coming up on follow-up. If the patient is doing very well, yes, if the patient has got multiple new lesions and enhancing lesions, it obviously makes me concerned and I need to discuss with the patient. So I would say the first MRI should be at the year 1, but chasing and giving contrast every year to a patient is not a great thing to do. Maybe you should repeat the other MRI at the interval of 2 years, and maybe not every time contrast may be justified. So I think annual first and then 2 years is a kind of a mediocrity.
I think pragmatic approach with clinical response, look at the patient, may be better.
Yes.
Any more questions? Anybody from the organizing committee? Oh, if there are no more questions, we thank Dr. Rohit Bhatia for his exponential lecture on the gray areas in demyelinating disorders. And I once again thank the organizing committee, Dr. Day-1, for giving us this opportunity to chair the session for the guest lecture on demyelinating disorders. Thank you, one and all.
Thank you.
I hand over the mic to the organizing committee.
Thank you so much.
Committee members.
Thank you, Dr. Rohit, and the chairperson. I think everybody will agree with this for having such a wonderful session. Now, we invite for the platform presentations. I asked Dr. Sudhir Kumar from Apollo Hospitals and Dr. Syed Ameerbhasha to chair this session. Over to Dr. Syed Ameerbhasha and Sudhir Kumar.
Yeah, am I audible?
Yes.
Yeah.
Yes.
Welcome, Sudhir.
Hi, Syed, Dr. Syed. Yeah. Welcome. Yeah.
So we'll take over the next session. I think we have 3 platform presentations in this session, and each presentation is for about 10 minutes. I think the presenters are ready with their presentations.
Dr. Ameer?
Yeah.
Yes, neurology and neurosurgery alternate, and I think it was given as 6 minutes and 3 minutes. So,
just 6 minutes is the presentation and 3 minutes is for discussion.
Yeah, try to finish it up by 8 or 9 minutes.
Okay. Alternatively, we have to do 1 neurology and
1 neurology and 1 neurosurgery.
Okay, right.
There are actually 3 neurology and 3 neurosurgery papers.
Yeah.
3 neurology, 3 neurosurgery papers, and total session time is 1 hour.
Yes.
And 6 minutes is the presentation time, and 3 minutes is for the question and answers.
Yes.
And I think all the presenters are ready with their presentations. And let us start with the first presentation.
Dr. Amir, if somebody finds it difficult to ask the next presenter to be ready. So that
Yeah. The first presenter is Dr. Pawan from Nizams. Is he ready? Dr. Pawan?
Hello, sir.
Are you online?
Hello, sir.
Yeah.
I'm sharing my screen, sir.
Yeah. So Dr. Pawan's presentation is on computer tomography, morphometric analysis of cervical pedicle in Indian population. Pawan, your presentation time is for 6 minutes, and we'll have time 3 minutes for question and answers.
Yes, sir.
I think we can go ahead with the presentation.
Are you able to see the screen, sir?
Yeah, we are able to see your screen. You can start your presentation.
Good evening, everyone. This is about the study of the morphometric analysis of the cervical spine pedicle in Indian population using computer tomography. This is for the use of transpedicular fixation, which can be used instead of lateral mass fixation. We study about each cervical spine pedicle. And so why we use the transpedicular spine fixation is because it shares the load and sharing forces of all the three columns, which are one of the best forms of fixation techniques. And this transpedicular fixation was first told by the Abumi, and he described it in 2 decades ago. But this was not followed by everyone because of the close proximity of the neurovascular structures, and also there is an inherent variability in pedicles at each level of cervical spine. And there is also the lack of consistent suitable landmarks for the pedicle screw placement, which adds to the technical challenge. And this lateral mass fixation was introduced by Roy and Kemily in 1980. This was the choice for stabilizing the cervical spine when posterior elements were compromised or were absent. And this lateral mass fixation offers only the 2-column stability for cervical spine. So the difference between the transpedicular and lateral mass is the lateral mass gives the eye fusion rates, but as it is a 2-column fixation, and also it causes the kyphosis of spine. And in transpedicular, as I said, it gives a 3-column fixation and it has a good construct. And main disadvantage is the narrow width of the subaxial cervical pedicles. So because of the narrow width, if there is any small breach in the pedicle, this leads to catastrophic damage due to the vertebral artery or spinal cord injury. So in this study, we study about the anatomy of the cervical pedicles on CT guided in Indian population, which is utilized for the proper planning, preoperative managing for the treatment. So this is a study. It is a prospective and observation study, which is studied in NIMS from August 2015 to August 2019. In this, helical CT was done for 1 mm cuts with 0 spacing, and 3D this reconstruction was produced for the better depiction of vertebral body for the pre-operative planning. So in this, more than 20 years of age patients were included, and the patients who underwent cervical spine were included in the study. And patient with the previous cervical spine injury, and the patient with destroyed pedicle and body due to trauma, and the congenital anomaly were excluded from the study. So 6 parameters were studied, mainly the pedicle and the axial length. This is the pedicle length, and this is the axial length. And the height and width of the pedicle is determined. This is done at the isthmus of the pedicle. And the sagittal angle and transverse angulation was done. Here, sagittal angle is taken through the angle between the axis of the pedicle with the inferior end plate of the body. And the transverse angle is the pedicle axial with the vertebral body axial. The angle between these two is taken as a transverse angulation. Coming to the results, there were total 150 patients were included in the study. In that, 750 vertebrae were studied. The male to female ratio was 5:1, and all the parameters were found to be greater in men compared to the women at each spinal level, except for the transverse angulation, in which in the male patient had an acute angulation compared to the female at all levels. And there was no significant difference between the left and right-sided parameters at any cervical spinal level. Coming to each parameters, the axial length, it's a mean between the 28 mm to 34 mm across C3 to C7. The longest axial length was noted at the C7 level. And the mean axial length of the pedicles was significantly greater in males compared to the females, and this was significant. And the pedicle length also, the mean pedicle length was 5.8 to 6.4 mm. The longest pedicle length was seen at the C7, and the shortest at C5 in the females. longest in the C5 at the females. This angle, axial length and the pedicle length help in the screw length selection. Coming to the width and height, the mean width of the pedicle was greater in males as compared to the females at all levels in either side. And height, the mean height was around 5.8 to 5.9 mm, which was greater in males compared to females. And this width and height determines the diameter of the screws which should be used in the surgery. And the transverse angulation, that is the angle which is more acute in males compared to females. And there was decreased angulation from cranial to caudally, which was almost similar to the and this transverse angulation is establishing an ideal entry point and trajectory for a safe pedicle screw insertion. This the last part is the sagittal angle. This range from -7.9 degree to 9 degree. Only the C3 pedicle was directed cranially, whereas all others were directed caudally. And the males had a more angulation at each compared to females. This sagittal angle determines the trajectory sagittal plane to avoid damage to the traversing nerve roots. Going to the discussion, this has the transpedicular fixation has all the columns fixed, which causes axial bending and torsional stability. Fixation and also there is a higher pull-out strength without the need for ventral stabilization. So thorough understanding of political anatomy is mandatory to avoid the injury to the vertebral artery and neuroscience. Here the cervical nerve root passes from the disc. Hello.
Pawan, there is a lot of resound.
Hello.
Hello.
Some of you presenters are moderated.
Can I request the next microphones, please? Pawan.
Hello, sir.
Yeah, carry on.
This cranial nerve root, it passes near the disc region, and when you compare it in the coronal section, it passes through the 45-degree angulation, and also it is present below the located near the inferior half of the neural foramen. So if there is any breach in the medial part of the pedicle or the inferior part of the pedicle, these are relatively safer for the to avoid the injury to the spinal cord and also the nerve root. So when you come to the pedicle width and the height was it was more than 5.9 to 7 mm, but the pedicle width was here the smallest cervical pedicle screws available is 3.5 mm. So the cutoff for the safe pedicle to be taken is 4.5 mm or more in the width. So when you see the width of the pedicle in our study, most of the in the C3, C4, C5, C6, C7 level, the male patient had more than 70% of the patient with more than 4.5 mm of width. But in the patient with the female in the right side and also the left side, only 48% to 40% had a width of more than 4.5 mm in C4 level. So in this, we inference that if the patient in the female patient using the 3.5 mm screws, we should be very cautious in the C4 level. So this is about the other studies which are done. This is the second study which involves all the 7 parameters involved. This is the second study. In other studies, they have included few parameters only. In these also, as you go on from the cranial to caudal, there is an increase in axial length in the male and female patients. Only the transverse angulation decreases as we go down. And also in sagittal angulation also, the patient in the C3 and C4 had a cranial angulation. Below the C4 level, they had a caudal angulation. In our study, only the C3 had a cranial angulation, and below the C4, it has a caudal angulation. So what are the inferences? Like the 30 mm axial screws can be used for in our study, and as the more is the length, and the better will be the constraint. In the lateral mass, only the 14 mm length are used. The 3.5 mm screws can be used in all cervical spine in both sides. We should be more precautions to be taken in C4 vertebra of the female. And proper pre-op cervical morphometry should be done for successful pedicle fixation because each level has a different cervical morphometry. And adequate precision helps to maintain stability as effective as we do in the lumbar spine. So conclusion is about the length, that is the axial and pedicle length, width, height increases craniocaudally in the either gender, and the transverse angle is almost constant in all levels. The sagittal angle is directed caudally in all vertebrae except in the C3, which is directed cranially. The individual variations occur at each level and require individualization for safe instrumentation in cervical spine. From this inference, the screw length of 28 mm and 3.5 mm thickness can be used with good precision for successful surgery. Thank you, sir.
Yeah. Can I invite any questions from the audience? Even in the chat box, there are no questions. Pawan, I would like to ask few questions. Like, what is the aim of your study?
Sir, we can use the transpedicular screw fixation as it is a 3-column fixation. We can use it for the benefit of the patient, sir. Because lateral mass fixation, we come across the complications like kyphosis of the patient and all. So we can, as there is a 3-column fixation in the transpedicular fixation, we can use in the normal patient with the proper preoperative analysis of the each cervical vertebra to determine the pedicle length and all.
Is there any real technical advantage with transpedicular screw in comparison with lateral mass screw placement?
That's what it provides the anterior, medial, and posterior column fixation, sir. So it is better compared to the 2-column fixation as done in the lateral mass fixation, sir.
And if you look at the rate of complications?
Complications are less in the this one, sir, lateral mass fixation. But as I said, the pedicle, the width is very narrow, sir. So we should, if there is any breach or little carelessness in doing the surgery, there may be catastrophic damage to the vertebral artery or spinal cord. So it should be used properly, sir.
So what do you feel in this era where even the laminar screws have come into picture?
Yes, sir.
Where simple laminar screw is said to be having almost equal rate of fusion and rate of stability in compare with other placements.
Yes,
Do you really advise transpedicular placement is a good option?
With proper technique, I think the transpedicular can use it, sir.
Yeah. Okay. Thank you, Pawan. Any more questions from the audience? I'm not seeing any questions on the chat box. If there are no more questions on this paper, can I request Sudhir to invite the next speaker of neurology presentation? Sudhir, over to you.
Yeah, I think I don't have the right now the list with me, so I think the next person.
Yeah, okay. I have the list with me.
Okay.
First presentation in the neurology platform presentations is comparison of CSF and salivary biomarkers in neurodegenerative disorders by Dr. M.V. Sangamesh from Osmania General Hospital. I would like to invite him to share his screen.
Yes, sir.
Yeah, Sangamesh, you are ready?
Yes, sir. Yes, sir. I'm ready, sir. Mine is visible, sir.
Yeah.
Screen is visible, sir.
No, not yet. Can you share
now,
it?
Sir?
No, I'm not seeing your screen.
Now, sir?
Yeah.
Yes. We can see now, yes.
Yeah.
Yes, sir.
Amir?
Yes, sir. Yes, sir.
Amir.
Hello?
Amir?
Yeah.
Yeah, please stick to the time. Second thing is ask the presenters not to log in two devices. So that is the reason echo sound is coming.
Okay, right.
Please announce it before every presentation. Thank you.
They should log in through their laptop or
only one device, not two devices. Some of them they are logging through both the laptop and iPhone also, or mobile. That's the reason we are getting.
Okay, sir.
Thank you.
Your time is for 6 minutes.
Yes, sir.
I have questions for 3 minutes.
Yes, sir. So the study is the comparison of CSF and salivary biomarkers in neurodegenerative disorders. So introduction. Neurodegenerative disorders of central nervous system are characterized by loss of specific population of neurons, the pattern and distribution of which shape the clinical presentation of the patient. Most patients are diagnosed using clinical criteria which predict pathology and therapeutic approach. The two main physiological fluids that were used for the detection of biomarkers in neurodegenerative disorders are CSF and blood. So acquiring samples of these two fluids has proven to positive a certain level of discomfort and pain to the patient. So simple non-invasive tests for early detection of degenerative dementia by use of biomarkers are urgently required. So saliva has emerged as a good source of samples for detection of disease biomarkers. Obtaining a sample of saliva offers multiple advantages over the currently tested biological fluids, as it is a non-invasive, painless, and simple procedure that does not require expert training or harbor undesirable side effects for the patients. So here we compared CSF biomarkers with salivary biomarkers and examined their validity in diagnosing neurodegenerative disorders. This study was done in collaboration with Indian Institute of Chemical Technology, where the CSF and saliva samples were stored and analyzed by Western blot technique. So the aim is to compare salivary and CSF biomarkers in neurodegenerative diseases. The objectives are to study the levels of individual CSF and saliva biomarkers in patients and to identify the variability of each biomarker in individual conditions. The study period is for 1 year. It's a cross-sectional case control study. The inclusion criteria are the patients with Alzheimer's disease, frontotemporal dementia, Parkinson's disease, DLB, and PD plus syndrome who were attending the outpatient or admitted in Usmania General Hospital are included in the study. Exclusion criteria followed are presence of another major comorbid psychiatric disorder, major depression, schizophrenia, learning disability, previous history of high consumption of alcohol, another medical illness that is causing the dementia, head injury, and presence of vascular dementia. So patient selection, patient with a suspicion of neurodegenerative disorder included above who present to dementia or movement disorder were screened. A comprehensive clinical assessment was done, which include history taking for alcohol intake, nutritional deficiency, drug and toxin exposure, history suggestive of infections, associated endocrine disorders, followed by clinical examination, including MOCA and higher mental functions. So following this, a neuroimaging technique, CT or MRI was done to support our clinical diagnosis and to rule out treatable causes like vascular etiology, malignant etiology, or other reversible cause of dementia were done. Blood investigation to support these were complete blood picture, ESR, CRP, biochemistry panel, serology panel, B12 and thyroid profile were undertaken. So CSF was collected at 9 a.m. with 22 gauge LP needle from both cases and controls. CSF was sent for routine analysis, including cytology for malignant cells, as per the protocol for following up a dementia case. Saliva was collected at the same time. 5 minutes after rinsing their mouth with 100 ml of mineral water, the subjects provided a salivary sample of approximately 1 ml in a sterile container, and these were centrifuged at 15,000 rpm for 3 minutes to precipitate any particulate material. Thiocyanate S was added to salivary samples to prevent contamination. Both CSF and salivary samples were stored in polypropylene tubes at -20 degrees Celsius and transported to IICT. At IICT, samples, both saliva and CSF, were frozen and then when thawed were immediately analyzed. Coming to the results, a total of 20 cases and 20 controls were included in the study, from whom saliva and CSF was collected. MOCA was calculated for all the patients. The average MOCA score was 20. And this is the distribution of cases. Among this, PD cases were 12, PSP, FTD, AD, and MSA were 2 each. And Hen and Yahr stage was seen for PD cases. It was average around 1.5. So the results were, when we compared the biomarkers between cases and controls, in CSF, alpha-synuclein was significantly lower in PD compared to healthy controls. DJ1 was significantly elevated in all tauopathies and PD patients also when compared to controls. 3R tau was significantly elevated in all the tauopathies compared to controls. In saliva, no biomarker was found to be different between the cases and controls. And comparison between individual neurodegenerative conditions. In CSF, alpha-synuclein was significantly lower in PD compared to all tauopathies. DJ1 was elevated in all patients, that is PD as well as tauopathies. 3R tau was elevated in PD and tauopathies. No difference in PD patients and tauopathies with respect to 4R-tau and neurogranin. So while in saliva, no biomarkers were found to be different between neurodegenerative conditions. So this is the DJ1, which is elevated in cases when compared to control, showing statistical significance. And 3R-tau was also elevated in tauopathies when compared to controls, which showing statistical significance. Alpha-synuclein was low in patient CSF when compared to controls, and it has a statistical significance. Whereas 4R-tau neurogranin was not elevated when compared to controls, or not decreased when compared to controls. In saliva also, all biomarkers were on par, comparable with that of controls. There is no elevation or no decrease. Coming to discussion, this cross-sectional observational study examined the level of alpha-synuclein, DJ1, 3R-tau, 4R-tau, Parkin, neurogranin in CSF and saliva in multiple neurodegenerative diseases and matched healthy controls participant. So alpha-synuclein was significantly lower in CSF with patients with PD, including both tremor predominant and PIGD variant, as compared to healthy control. This is consistent with the results which were given by studies of Hong et al. And Mondello et al. And this definitely highlights the significance of alpha-synuclein in the pathogenesis of synucleinopathies. CSF DJ levels were found in patients with PD when compared to controls. This finding correlates with the study done by Hong et al., but the pathogenesis why the elevated CSF DJ levels needs further research. So these are the various studies which evaluated biomarkers in CSF in PD patients and other neurodegenerative disorders. And Hong et al. And Mondello et al. Have consistent results with our studies. Compared to healthy controls, we found significant raised TR-tau levels in patients with AD, PSP and FTD, that are tauopathies, PDs, compared to healthy controls. 4R levels were not consistently different between tauopathies and healthy control. These results are inconsistent with previous study by Remschner et al. In studies by Lee et al. And Bermejo-Pareja et al., A-beta 42 levels were elevated in saliva of patients with AD, and they were not useful for differentiating patients from healthy controls. But in our study, we could not find any difference in differentiating patients from neurodegenerative disorder and healthy controls. And the largest study, BioFind study, they compared the plasma saliva with that of CSF biomarkers. They also not able to found any difference between the patients and the controls. So the conclusion from my study is, by these results, it can be concluded that alpha-synuclein remains a useful biomarker in identifying patients with PD and distinguishing them from healthy controls. Further studies with DJ1, 3R-tau, 4R-tau are needed, as results to date have been inconsistent in previous records. We did not find a significant correlation of biomarkers in saliva with CSF in our cohort because the small sample size, difference in biofluid methodologies or sample characteristics. Thus, CSF has greater diagnostic utility in biomarkers in neurodegenerative disorders than saliva, despite its more invasive nature for obtaining samples. The results obtained from this study cannot be extrapolated at large considering the limited number of patients. Further studies focusing on this result in biomarkers with both diagnostic and prognostic values are needed. Thank you.
Yeah, Sudhir.
I think it's a good study, but in which conditions would you recommend this test? Like, normally when a patient comes with Parkinson's disease or other degenerative disorders, normally we don't have to do this. So are there any specific group of patients where you would suggest doing this test?
In Parkinson's disease, so we may not require, sir. In patients with PD complicated by dementias, like if the patient developing associated dementias in further course of the disease, maybe it is more useful. The characteristic pattern of markers may be helpful, whether it is really a PD complicated by dementia or really a FTD or AD kind of dementia. Maybe it is useful for differentiating these kinds, not for straightforward Parkinson's disease with only motor manifestations.
I think in the chat box, I can't see any other message. Any Dr. Syed, do you have any questions?
Yeah, there is one question in the chat box.
Yes.
It's from room 2015. In PD, is it oligomeric alpha-synuclein or total synuclein?
So what we have tested is total synuclein, sir.
Okay.
There are no more questions in the chat box. Yeah. Okay, Sangamesh, it's a good study. I think we'll go ahead with the next
Thank you,
presentation.
sir. Thank you, sir.
Yeah. The next presentation is from the neurosurgery group. I would like to invite Dr. Raghuram Teja. Are you ready with your presentation, Raghuram?
Yes, sir. Yes, sir. I'm ready.
Yeah. Can you share your screen?
Sure.
This is about the institutional experience of Osmania General Hospital with endoscopic third ventriculostomy in aqueductal stenosis. Go ahead, Raghuram.
Sure. Sir. Good evening to all my panelists and my fellow members. I'm presenting about our institutional experience regarding endoscopic third ventriculostomy in aqueductal stenosis. Introduction, endoscopic third ventriculostomy as a procedure has seen a tremendous improvement scientifically, both in sophistication, procedural involvement, and in patient outcomes since the start of this century. Though it was advocated, or rather say as proposed treatment for many conditions by many, robust clinical trials lack to support their claims. The only validation till now accepted across all neurosurgeons is the ETV success score and the ETV as a therapeutic treatment in selected cases of aqueductal stenosis. Its role in shunt failure cases with aqueductal stenosis is still debatable. Coming to our objective of the study, it's a review of 27 cases of aqueductal stenosis who presented with the symptoms of raised ICP or increasing head circumference, and also failure of a previously placed shunt systems. And these people who underwent endoscopic third ventriculostomy as a therapeutic surgical procedure. It's an institutional-based observational study done in the period 2015 to till date, the Department of Neurosurgery, Osmania. Coming to the materials, the study included pediatric patients with aqueductal stenosis who presented with raised ICP, a symptomatic increase in head circumference, failure of previously placed shunt systems. And exclusion criteria include infants less than 4 months of age and obstructive hydrocephalus secondary to post-meningitic, traumatic, or space-occupying lesions in the brain and their sequelae. The outcome was measured a symptom-free period up to 6 months. Coming to the gender, in our study, there were 16 males and 11 females. Age distribution, the least age was of 4 months and the highest age of 13 years, approximately average age of 23.74 months. Coming to the clinical presentation, increased head circumference was the most common clinical presentation, followed by vomitings, then followed by excess cry and seizures. The indications for this ETV was in almost 14 patients, it was purely an aqueductal stenosis, whereas in case of 13 cases, it is due to a shunt complication. And the cause for shunt malfunction or shunt complication was most common was the shunt malfunction, followed by peritubal leak was noted, and followed by peritonitis or intra-abdominal cyst formation, and then shunt extrusion. The protocol what we followed in patients with the shunt-related problems in whom we have done ETV is that initially, any patient who present with a shunt-related problem, we did a CT and found out whether it's a single obstruction or a multiple compartment shunt. And if it's a single point of obstruction, we removed the shunt and placed an EVD. And we initially monitored the patient. If there is no change in the ventricular size or in case of raised ICP features over 48 hours, then we consider him as a non-shunt. He's not depending on the shunt, and we clinically followed up the patient. But in case there was increase in a ventricular size and also increased in ICP, then we shifted him for an ETV procedure. If there is no change in the ventricular size, but there is an increase in ICP, then we consider him to be shunt dependent and we replace the shunt. So it is only the persons or it's only the children who had increase in the ventricular size or increased in the ICP have been further taken for the ETV procedure. The periprocedural complications that we most commonly encounter is the tract bleeding, CSF leak, and meningitis. The imaging parameters that we have taken into consideration during this study was that the width of the third ventricle, frontal horn by biparietal ratio, frontal horn by internal diameter ratio, average temporal horn, periventricular lucency. If we go through the statistics, it is in the periventricular lucency, which was seen at the time of admission, was very much decreased later on. I mean, in the initial weeks itself, it was almost disappearing. Whereas the other parameters, it took time, almost in the 6 months, to return to the normal ranges. Coming to the ETV success scoring, we have done the ETV. We have applied the ETV success score to all the patients, and almost all the patients have been in the score bracket between 50 and 80. If we consider this, the blue parameter is for the shunt malfunction patients, and whereas the orange parameter is regarding the aqueductal stenosis, pure aqueductal stenosis. We had 3 ETV failure cases, 2 in the aqueductal stenosis and 1 in the shunt failure cases. In this chart, we were able to see that if the ETV success score is more than 40, whether it is due to aqueductal stenosis or whether it is due to shunt malfunction, there is no significant difference in the outcome of both the groups. In our study, patients with shunt failure fared equally well with that of aqueductal stenosis group. And coming to the success rate, almost 14 patients with pure aqueductal stenosis in whom we operated, 12 patients, only 2 failure cases were noted with a success rate of 85%, and who came with a shunt complication with aqueductal stenosis, one failure case was noted with a percentage of 93% success rate. So overall success rate was around 88%. Coming to the conclusion, in our study, we could able to say that the endoscopic third ventriculostomy as a therapeutic procedure is proving to be more effective in tackling obstructive hydrocephalus secondary to aqueductals, and also as an alternative procedure in shunt failure cases with aqueductal stenosis. Thank you, sir.
Yeah, I'm not seeing any questions in the audience, and I would like to ask few questions. Why did you choose 4 months as the time, the age limit?
Sir, previously, all the articles that were in the previous literature, when we went through, majority of the articles were of the opinion that the infants, especially less than 4 months of age, haven't been fared well with the ETV procedure, or the complication or morbidity was more. So we choose the age as 4 months for us to start with the procedure, and then till the pediatric age group we have taken that.
Yeah, in fact, most of the literature says 12 months is the cutoff period. But
yes, sir.
Most of the ETVs below 12 months, they say the failure rate is more.
Yes, sir. Yes, sir. The thing is, we have taken 6 months, but only one case of 4 months we have done. Rest all are about 6 months of each.
Okay. Then I have another question. Like, what was the initial indication for shunt failure cases?
Sir, initial indication was a hydrocephalus with the aqueductal stenosis itself. The initial indication we have taken.
Yeah,
it was done either in our hospital or elsewhere in the center. But when they presented with shunt failure, then we considered them for the surgery.
So there also it was aqueductal stenosis.
Yes, sir, aqueductal. It was purely an aqueductal stenosis.
Yeah. Another thing is like when you saw the shunt complication cases, why did you choose to go for ETV over shunt revision?
Actually, shunt complication, once a shunt complication occurs, it is a repeated procedure most of the times. So ETV as a procedure can, if become successful, the patient can be devoid of shunt complications. That's what we wanted to emphasize.
Yeah, that may not be the case when you come across one shunt complication, but if there are repeated complications, yes, you are right about it.
Yes, sir. When there are some cases where we backed out also, wherein we had to abort the surgery, wherein almost 2 to 3 times of shunt placement was done. That is because of the thickened membrane altered anatomy was noted, where we had to back out, and these cases we not included in this study, sir, since we have backed out of the procedure.
Yeah, one suggestion is you should have put up some video in your presentation.
Definitely.
Okay. I have a few questions on the chat box. This is from Dr. Rajesh Reddy. Failure rate of ETV in your series and in literature. Difficulties in ETV, especially in shunt failure cases needing backout.
Yeah, that's what I have previously said. We have backed out because definitely when particular patients who had more than 2 or more shunt procedures were done, we had experienced thickened membrane subcations were noted, and also altered anatomy was noted where we couldn't identify the floor of the third ventricle. There was an issue, so we backed out. And when it comes to the literature, the success rate in the literature is almost saying from almost ranging from 60 to 90%, sir. It is alternate 60 to 90% anywhere between. In our till now whatever cases we have done, we have fortunately we were able to show at least 88% of success.
Yeah. Okay. That's fine. I think we don't have any more questions in the chat box. It was a nice presentation, Raghuram.
Thank you, sir.
I think next, we'll go to the next presentation. Next is a neurology platform presentation by Dr. N. Sandesh. Are you ready, Dr. Sandesh? From NIMS.
Yes, sir.
And his topic is mimics and rare presentations of spinal cord demyelination, a case series. So you can start sharing your screen and start your presentation.
Is my screen visible, sir?
Not yet.
Now, sir?
Yeah, now it's visible. You can make it full screen.
Yes, sir.
Yes, go ahead.
Yes, sir. Good afternoon, everyone. The topic is on mimics and rare presentations of spinal cord demyelination. This is a case series. Coming to the background, various infectious, inflammatory, and vascular diseases of the spinal cord can mimic demyelination, both clinically and radiologically, thus posing a challenge to the clinician. Besides these conditions have different prognosis and treatment strategies. Hence, it is necessary to differentiate them from spinal cord demyelination. So, coming to the first case, it is a 35-year-old male who presented with pain in the neck and in the left CA T1 radicular pain of 10 days duration. On examination, he had quadriparesis with sensory loss in the left upper limb. So, there's an imaging of the spine, the sagittal section T2. It was showing hyperintensities in the cervical spine from extending from the C2 to C6 with mild cord enlargement, which was also enhancing on post contrast study, and concurrent brain imaging done at the time was normal. And routine investigations done like serum biochemistry, hematological profile, including ESR, CD4 counts, complement levels were normal, and viral markers were negative. And CSF analysis showed albino-cytological dissociation. And others like CSF AC and oligoclonal bands and aquaporin 4 were negative. So patient was started on IV methylprednisolone, and on the second day of IV MP, he developed high-grade fever without any localizing signs. So the steroids were stopped immediately and antibiotics were started. However, there was a gradual drop in the sensorium, which prompted a repeat imaging of the brain and spine. So this repeat brain imaging, it is showing there is a T2 and the flare. It was showing heterogeneous enhancing lesion involving the pons, midbrain, and it was also showing a mass effect. This was enhancing on contrast. So concurrent MRI spine did not show any changes. So gradually, but the patient deteriorated and he expired. We have taken a consent and postmortem was done, and this is a gross specimen which was showing large areas of necrosis involving the right basal ganglia. It was also extending into the periventricular white matter, and we can also see the completely necrotic midbrain. And this is HPE slides of where we can see a necrosis with the collection of neutrophils, and we can also see bradyzoids of toxoplasmosis, and even toxoplasma cysts can also be seen. So this was a case of CNS toxoplasmosis. And next is coming to second case is a 14-year-old male. He presented with complaints of weakness of all four limbs since 5 days, and he also had urinary retention, and he had difficulty in breathing, so he was intubated outside. He also had tingling sensation over body up to nipples and left upper limb. On examination, he had flaccid quadriplegia with a neurogenic shock, and sensory, there was reduced touch and pain sensation below clavicle on the right side and below level of nipple on the left side. So there is also MRI of the spine. It was showing hyperintensities, long segment linear hyperintensities involving the center of the cord from cervicomedullary junction to up to C7, and which was also enhancing on the contrast. And here we can see it is involving the gray matter more. So, and investigations we have done, the routine investigations were normal, and serum NMO-MOG was negative, and CSF analysis was also normal. And we sent for pan-viral DNA PCR, which was negative. And during the hospital course, patient developed herpes zoster in the T1 segment and T1 dermatome. And then we sent for even varicella zoster antibodies, which came to be positive. So we treated him with antivirals. So final diagnosis was varicella zoster virus myelitis. So coming to the next case, there's a 32-year-old female with no prior comorbidities. She presented with complaints of burning sensation in back, trunk, and both lower limbs since 3 months. And she also had weakness of all 4 limbs since 3 months. So on examination, she had spasticity of all 4 limbs and power on the both upper limbs of 4/5. And right side it was, and lower limb it was asymmetric. And right side it was 1/5, and left lower limb it was 2/5. And was brisk reflexes and bilateral extensor plantars. And sensory, it was reduced touch and pain sensation below T1. So here we can see there's a spine imaging. This is also showing a long segment hyperintensities involving mainly the center of the cord extending from the C3 to D5 with the cord enlargement, and which can also be and we can also see enhancement on a contrast study. So this patient was initially admitted under neurosurgery, and because of the MRI report was reported cervical astrocytoma, and lesion from the biopsy from the lesion was done, and but histopathology was suggestive of demyelination. And they have started on 5 doses of 5-methylprednisolone, but it worsened in terms of weakness and burning sensation. So she was transferred to neurology for further evaluation. Then serum NMO-MOG was negative, but she was thinking of seronegative NMOSD. We started on a plasma exchange, and we started on azathioprine. After this, her weakness improved, and patient during discharge she walked independently with minimal spasticity. And there's a follow-up scan where we can see there is only patchy non-enhancing T2 central hyperintensities in the spinal cord from C7 to D5 levels. So this case was of tumor factor spinal cord demyelination. So next is 34-year-old male presented with numbness of both lower limbs since 5 months, and weakness of all 4 limbs since 5 months, and backache of back in the dorsal region. He was treated outside with ATT, and later referred to NIMS for the management because there was no further improvement. So on examination, there was a spasticity of all 4 limbs, and power in both upper limbs was 2/5 and lower limbs were 1/5 with brisk reflexes and bilateral extensor plantars. And sensory, there was reduced touch and pain sensation below nipple. So here we can see here also we can see the hyperintensities in the mainly in the cervical dorsal spine extending from the C5 to D5 with and there is only mild cord enlargement, and we can also see this lesion is enhancing on the contrast, which is located centrally, and and HRCT of the patient was showing subcarinal lymphadenopathy. So we have worked up for this case, and vasculitis profile was negative, serum NMO-MOG was negative, CSF analysis showed 12 cells with mild protein elevation and glucose elevation, but serum AC was elevated 124, and biopsy from the lesion was done. And we started on pulse IV methylprednisolone. There's a biopsy which was showing fragments of granulation tissue infiltrated by granulomas containing epithelioid cells, Langerhans type giant cells, and lymphocytes. And the surrounding tissue showed perivascular lymphocytic infiltration, but there was no evidence of any caseous necrosis. So the diagnosis of it was sarcoidosis, and the patient, but he was lost to follow up. Then next case is a 62-year-old male. Is a known diabetic and hypertensive, and he presented with complaints of weakness of both lower limbs since 1 year, with recent worsening since last 1 month. And he also had tingling sensation of both lower limbs from hip to ankle. And on examination, the power in both upper limbs was 5/5, and he had asymmetrical weakness. Right lower limb proximal power was 1/5 and distal 2/5. Left lower limb proximal power was 2/5 and distal 3/5, with absent reflexes and bilateral extensor plantars. And sensory examination showed circumferential sensory loss below right and left mid leg. So, on routine investigation showed when all except elevated blood glucose, his HbA1c was 9.3, and CSF analysis showed 10 cells with mild protein and glucose elevation. Serum NMR was negative, vasculitis profile was negative, and other infective workup was also negative. So this is the MRI spine, which was showing long extensive transverse myelitis from D3 to up to conus. And this is also here we can see involving the center of the cord, in central intramedullary region of the cord. So possibility of we considered seronegative NMOST and plasma exchange IV methylprednisolone was given. But the patient worsened and he developed numbness below T2 segment with involvement of ball and bladder after 4th dose of IVMP. Then MRI was again reviewed. Then we found some flow voids, and then we thought of possibility of spinal dural AV fistula was considered, and DSA was done. So this is a DSA image which was showing low flow spinal dural AV fistula here, the arrow, which was supplied by left D10 intercostal artery draining into perimedullary venous plexus. So this was a case of spinal dural AV fistula. Coming to the last case, this is a 48-year-old male. He presented with complaints of weakness of all 4 limbs in 6 hours, and he also had urinary retention and tingling paresthesias below neck. On examination, there was a quadriparesis with absent DTR and extensive plantars. Sensory, there was reduced touch and pinprick below neck with intact joint position and vibration sense. So here there's a diffusion weighted imaging which was showing areas of diffusion restriction around the C6 level and with corresponding ADC reversal. But the concurrent MRI brain was normal, and next day MRI spine was done. So this MRI spine was showing hyperintensities in the anterior cord extending from the C5 to C7 with no contrast enhancement. This is nothing but this is the owl eye sign which we can see wherein it is seen in the anterior part of the cord. So investigations were normal, and this final diagnosis was spinal cord infarction. So coming to the conclusion, mimics of spinal cord demyelination can be differentiated based on clinical presentation, progression of the disease, response to steroids, rescue therapies like plasma exchange and antimicrobials, and repeat imaging studies during disease course add further information to the available data. So precise analysis of clinical presentation coupled with the radiological features can help clinicians to reach the correct diagnosis.
It was a good collection of cases, and I think what you showed is that we should not shut our eyes if we see hyperintense lesion in spinal cord. There are large differential diagnoses like from tumors to infections and even vascular conditions. So I think from the audience, as of now in the chat box, there is no question. Dr. Ameerbhasha, you have any questions on this?
No, I don't have any questions.
So I think it was very good presentation. I think nobody has any doubts. It looks nicely demonstrated. So we can go for the next presentation from neurosurgery.
Thank you, sir.
Yeah. The next presentation, neurosurgery, is from again Nizam's. Dr. Swapnil, are you ready with your presentation? Swapnil?
Yes, sir. Yes, sir.
Yeah. Can you share your screen?
Yes, sir. Sharing.
Yeah, Dr. Swapnil's presentation is on functional improvement in advanced Parkinson's disease following bilateral ST and DBS.
So is it visible, sir? Full screen?
Yeah, it's visible. Go ahead.
Good evening, everyone. So I'm going to present our study on the functional improvement in advanced Parkinson's disease following bilateral subthalamic nucleus deep brain stimulation. So this was approved by our institutional ethics committee for a submission as a thesis paper. So as we all know that Parkinson's disease, it can be associated with a significant amount of tremor, rigidity, and bradykinesia, and along with that, a micrographia component as well. So this can have a significant impact on the handwriting, which can make the handwriting to be illegible, which can lead to hindrances in the professional work of the affected individual. So recently, the DBS has evolved as a safe and cost-effective therapy with different advantages of reversibility and adjustments. So although in past, the features of the dysgraphia have been studied in Parkinson's disease, but the information which are related to these changes in this skilled motor features like handwriting after the DBS has been lacking. So considering all these factors, we wanted to study the dysgraphia in cases of advanced Parkinson's disease and how this dysgraphia changes after the patient is subjected to ST and DBS. So we started our study, we started including our cases from the January 2019. We mainly included cases of idiopathic Parkinson's disease who were in the advanced stages of disease, having severe motor manifestations. So preoperatively before the study, we evaluated the patient for all the motor symptoms. And after surgery, the final follow-up was done at 6 months again when we evaluated the patient for the the motor outcomes and change in LEDD. So for the evaluation of gross motor symptoms, we mainly used a unified Parkinson's disease rating scale, which we measured in the off phase. For the fine motor symptoms and for the analysis of the dysgraphia, we analyzed the handwriting of the patient in the off phase. And for the treatment quantification, we used a levodopa equivalent daily dose score. In dysgraphia, we wanted to study for all the components of the dysgraphia. First, what we included was the micrographia. We mainly looked if the handwriting is having any component of a vertical or a horizontal micrographia, or in case if the handwriting is reducing in size with progress, then we called it as a progressive micrographia. So also to look for the legibility of the handwriting, we used a Fan-Tolosa scale, which ranges from the 0 to 4, where the 0 stands for a normal handwriting, and 4 stands for a severely abnormal handwriting, where the patient is unable to keep pen on a paper. So some of the salient features of the procedure and our study was, we did a prospective analysis. The cases were operated by a single neurosurgeon, and all the imaging acquisition protocol, the implants were uniform in all cases. And we did a main left-sided targeting first. And to avoid the surgical error placement, we mainly did a rigid tube guide for placing the final electrode. So coming to the results, we had total of 51 patients. There were almost 36 males and 15 females. The mean age was almost 58 years. Mean age of onset was almost near to the 50 years. And average duration disease in the present cohort was 8 years. And among all our 51 patients, only 2 were left-handed and 49 were right-handed. And what we noticed was most of the patients were within the age range of 60 to 70 years. So when we look for the results at the 6 months after surgery, we noticed that there was a significant reduction in the post-operative motor outcomes in the form of the overall UPDRS3 reduction and the hemicorporal UPDRS3 reduction. And also from the treatment dosage, levodopa equivalent daily dose also, there was a significant reduction on the dosage that was taken by the patient at the 6 months. And when we look for the evaluation of the fine motor symptoms, we compared the handwriting both preoperatively and the postoperatively. And what we noticed was the handwriting grades, there was a significant improvement at 6 months. So here are some of the examples from our case series. This was one of the case where the previous handwriting was totally illegible. It was a Fan-Tolosa grade 3, and postoperatively it improved and it became only mildly abnormal. Here again, where the patient's preoperative handwriting was legible, but it was associated, what we can see here was a considered tremor component. And postoperatively, there was a handwriting almost became normal and there wasn't any tremor component. And this was again seen in few more cases where preoperatively handwriting was associated with a significant, it was though legible, but tremor component was there, and postoperatively, it became only mildly abnormal or near normal. And the other components, what we noticed was the micrographia component. Here preoperatively, what we can notice is here the patient is having a horizontal and vertical micrographia, and as the handwriting is progressing, it is reducing in size. And postoperatively, what we noticed that this patient didn't have any of the components of micrographia in postoperative period. So comparing overall, what we noticed that almost 67% of the patient had improvement in the handwriting scores in the post-operative period, but there were some 8% of the patient who had a deterioration in handwriting scores. So as to look for how much so as to quantify the micrographia component, what we asked the patient to write their place of stay, which a bare minimum a formally educated person can write. We measured the vertical length and horizontal width of the words that were written by the patients in preoperative and the post-operative period. And considering the results, what we noticed was the mean post-operative vertical length and mean post-operative, the horizontal width of the words that were written by the patient, they were more as compared to the preoperative dimensions of the words written. But however, we couldn't get a statistical significance. And also when we look for the prevalence of the micrographia in the preoperative to post-operative period, the prevalence had reduced in the post-operative period, but also we didn't get a significance here. So as to look for what were the correlation the findings to look for the correlations of outcome, what we noticed that among the preoperative findings, the patient who had an age more than 65 years, they had a less improvement in handwriting. And also what we noticed that a mediolateral deviation of mainly the left X Cartesian coordinate, it was noticed that more the deviation, there was less improvement in handwriting, and there was seen a moderately negative correlation. So when we looked into the literature, we found out that the similar findings that subthalamic nucleus can lead to significant changes in handwriting, and it has been seen that patients who are near to the 70 years of age, the DBS outcomes will be suboptimal. And recent studies, it has been seen that the Fan-Tolosa scale has a better ability to predict changes after the treatment, and subjective analysis can also have an equal specificity in distribution micrography as compared to the objective analysis. So considering all our results and everything, we concluded that subthalamic nucleus deep brain stimulation results in substantial improvement in handwriting skills of the patient, particularly in cases with age less than 65 years. And this overall improvement can be beneficial to the patient and can lead to an increase in involvement in social and occupational activities.
Yeah, Swapnil.
Yes, sir.
Hello? Yeah,
yes, sir.
I was not able to see your screen on my computer, but I was able to hear you clearly. Is there any problem to the others also? Okay.
No.
Hello? Yeah. Sudhir, you were able to see the screen all along?
Yeah, yes, Samir, we were able to see the screen. We were able to see all the slides.
Okay, now I got back the screen. Okay, right. It's a nice presentation, Swapnil.
Thank you, sir.
Yeah, see the improvement in the handwriting and the intellectual functions is associated with deep brain stimulation. But especially it is meant for improvement in the refractory motor symptoms. Yeah, it's a nice study. Are there any questions from the audience? I'm not seeing any questions to Swapnil. Sudhir? Hello? Yeah. Do you have any questions for him? Sudhir, we are not able to hear you. Yeah, Sudhir? We are not able to hear you, Sudhir. Can you unmute yourself, Sudhir? We are not getting your audio. We are able to see you.
I think there is some problem in Sudhir's laptop because we are able, all of us are able to hear.
Okay.
Probably,
right.
I think we can move on to the next one. Already we are behind schedule.
Yeah, behind schedule. I think we'll go for the next presentation from Neurology Group. This is by Dr. Bhavana from Care Hospital. This is about profile of carpal tunnel syndrome with special reference to severity assessment using second lumbrical potentials. Dr. Bhavana, are you ready with your presentation? Yeah, I'm seeing your screen. Can you make it full screen? Bhavana? Dr. Bhavana, we are not able to hear you. We are able to see your screen.
Can you see me? Can you hear me, sir?
Yeah, please. We are able to hear you. Now go ahead with your presentation. Bhavana.
Yes. Good evening, sir. Good evening, one and all. So, topic presentation for today is profile of carpal tunnel syndrome, especially with special reference severity assessment using second potentials. So, as we know, CTS is most commonly encountered entrapment neuropathy, and symptoms are due to compression of the median nerve along the carpal tunnel. Classical symptoms are numbness and paresthesias in the first 3 fingers of the hand, which is commonly exacerbated at night, known as nocturnal paresthesias. Diagnostic signs include sensory loss, motor weakness, and wasting of abductor pollicis brevis, and eliciting Tinel's and Fallon's sign at the wrist. So the nerve conduction studies, NCS is the definitive diagnostic test for CTS with high degree of sensitivity and specificity. And the second lumbrical is relatively less affected in severe CTS, as the motor fibers in the lumbricals are centrally located in the median nerve and the compression is from periphery. So in this, the difference between distal median motor latency, the second lumbrical, and the ulnar motor latency from the underlying intraossei is to be compared and used in the diagnosing and assessing the severity of CTS. So aims and objectives: to correlate the clinical and electrophysiological findings in CTS and to study the diagnostic value of second lumbrical and intraossei distal motor latency difference in evaluation of mild, moderate, and severe CTS, to identify the frequency of subclinical impairment on the unaffected side. So this study is a prospective observational study for a duration of 1.5 years at Care Hospitals, Nampally, and case selection is patients with clinical symptoms suggestive of carpal tunnel syndrome of both genders and 18 years. Exclusion criteria is only patients less than 8 years. Sampling techniques is the connection studies were performed using Nicolette Synergy EMG. A total of 40 hands were studied to obtain normal values for comparison, and 220 hands, 110 patients were enrolled into the study. All controls and patients underwent relevant clinical, laboratory, and electrophysiological testing. So, if a small note on second lumbrical intraossei distal motor latency difference recording technique. So, this was first described by Preston et al. The motor point for second lumbrical and intraossei is slightly lateral to the midpoint of the third metacarpal. As you can see here, this is the active electrode placed at the motor point. This is the middle, metacarpal, and this is from the midpoint of the metacarpal. The electrode is placed just laterally. And the median ulnar nerves were stimulated at the wrist at an equal distance from the active electrode, and the CMAPs are obtained. The sweep speed used in this study was 5 milliseconds per division, and gain was 5 millivolts. 1 centimeter silver discs were used for active and reference electrodes. Limb temperature is maintained above 31 degrees, and in case of very cold extremities, the limb was warmed. Okay, as you can see here, the recording electrode is at the wrist, and the reference electrode is at the proximal interphalangeal joint at the. So this is the median nerve stimulation and the ulnar nerve stimulation. Control population, as already said, there are 40 hands, 20 healthy controlled subjects from the hospital staff and volunteers who are screened negative for CTS, and the values we obtained from these controls, especially the second lumbrical intraossei distal motor latency difference was less than 0.5 milliseconds. So these are the electrophysiological parameters used in this study to confirm CTS. Median distal motor latency more than 4.4 and sensory distal latency more than 3.5 milliseconds. Terminal latency index of less than 0.33, and the difference between median ulnar ratios, especially the second lumbrical intraossei ratio, distal motor latency difference is more than 0.5. So these are the neurophysiological classification we used to assess the severity of the disease in this study. One is Edua et al. And one from the Bland et al. Both considering both sensory and motor NCS, with negative wherein motor and sensory NCS were normal, and extreme where they both are absent. Statistical analysis by the both quantitative data and qualitative data are assessed with mean and by chi-square test respectively. P-value of less than 0.05 is taken as level of significance. Coming to the result, mean age of the patients was 54.71 years. 86 males, 80 hands of male and 119 hands of female were enrolled. The ratio of 1:1.4. Comorbidities, the most commonly encountered comorbidity is diabetes mellitus, seen in about 44.9%, followed by hypothyroidism and rheumatoid arthritis. Right hand prevalence was seen in this study compared to the left. And duration of symptoms, actually patients who presented with symptom duration less than 6 months had milder degrees of disease in compared to patients who presented with duration of symptoms more than 2 years who had severe or extreme disease. Most common presenting symptom was paresthesia, seen in about 37.2%. And the second most is asymptomatic, that is in the contralateral subclinical CTS. Signs, most of them had no objective clinical signs on examination, and only 19% had sensory loss or motor. The median motor and distal motor latency from APB is 4.93 milliseconds. So the second lumbrical intraosseous distal latency, which is normal in about 20.9%, but it is abnormal in 77.1% with a p-value of 0.006, which is significant. So comparison between median, one is second lumbrical intraosseous distal motor latency difference with mean is 1. Cutoff is 0.5, and palm wrist distal sensory latency difference of 0.86, cutoff is 0.3, and digit 2 versus digit 5 sensory latency difference 1.25. All three have significant p-value. Coming to the severity of CTS, in this study, most of the patients present, that is in the milder stages of CTS, 25.9%, whereas only 6.9 presented in extreme stages. So this is the most important, that is the aim of the study, to compare the second lumbrical intraosseous distal motor latency difference with severity of CTS. So in patients with the negative CTS on NCS, the motor latency difference is only 0.42, whereas in extreme cases 4.79. So we have a p-value of 0.00001, which is highly significant. So coming to discussion, it is one of the most common diseases requiring evaluation in neurophysiological laboratories. So in this study, I've seen a female and right hand preponderance. In this study, the second lumbrical intraosseous distal motor latency difference was found to be as sensitive as palm wrist distal sensory later difference, mild and moderate grades of disease, while it is more sensitive than any other study in severe CTS. The mean lumbrical intraosseous latencies and all other results were to the values obtained by the study conducted by Dr. Meena et al. And the upper limit of second lumbrical intraosseous difference ranged from 0.4 to 1 milliseconds in different studies, but in this we have taken the cutoff as 0.5 milliseconds. So the second lumbrical intraosseous distal motor latency difference comparison proved to be a valuable electrodiagnostic technique in localizing median mononeuropathy at the wrist and to assess the severity in CTS patients, especially when the median sensory and motor responses are absent on routine conduction studies. One example is, this is a 39-year-old female patient who presented with symptoms of suggestive of CTS. And on routine nerve conduction studies, the motor potentials are not recordable from the right hand, and the sensory potentials are also not recordable, whereas the lumbrical potentials are still preserved with the lumbrical intraosseous difference of more than 6, which is highly significant. So to conclude, duration of symptoms with carpal tunnel syndrome correlated well in this study, the severity. Electrophysiological studies identified subclinical CTS in asymptomatic hands in about 3/4 of the patients. And it is advisable to include second lumbrical intraosseous distal motor latency difference testing as a part of routine NCS in all patients with symptoms suggestive of CTS, especially those with severe CTS with absent sensory and motor potentials. Thank you.
Yeah, Sudhir, will you be able to?
Yeah, can you hear my voice now? Am I audible?
Yeah.
Okay, fine. So I think it was a good study, something new and interesting. But so by this, when you did this test, does it take extra time, or I think in the same time it can be finished?
Yeah, it is the same time, sir. Only thing the correct placement of the electrodes is required to get them.
So that requires some training, or it's easy to train?
Easy, sir. Actually, we can measure. Yes.
Sure. And I think so. I think it's a very good finding. Definitely, it can be useful addition to our routine nerve conductions.
Yes.
And so I think it's a good data. Any other questions are there in the chat box? Because I think we are shooting time also.
Yeah.
I think there are no questions I can see. So I think
there are no more questions in the chat box.
Okay. Thank you.
I think we will close the session. I congratulate all the speakers for sticking to the time. We just crossed the time by, I think, 10 minutes. Yeah, I would like to hand over the sessions to the organizers. Chaudhary?
Yeah. Thank you, Sudhir, and thank you, Sudhir. Thank you all thank you all the participants.
Thank you.
Now we start the next session. It's a neurosurgery guest lecture, defining hybrid vascular surgery, a neurosurgeon perspective by Professor Anita Jageshia. And I request both the moderators, Dr. Alok Ranjan from Apollo Hospitals and Dr. Ramesh Chandra from SIMS Tirupati to chair the session. Over to the chairperson.
Good afternoon or good evening, what should I say? We invite everyone for this lecture by Dr. Bhatia and a hybrid neurosurgery, neurosurgeon's perspective. She's a professor of neurosurgery and, must I say, endovascular surgery as well in G.B. Pant Hospital. And G.B. Pant is one of the pioneers which has started this hybrid program. Prior to that, there were crossover neurologists or neurosurgeon who used to go full-time in endovascular, but same specialty doing both, which was badly needed in this country. One of the premier center was G.B. Pant Hospital. As said, apart from her endovascular and the surgical work, she's also very proficient in minimally invasive spine surgery. And I welcome Dr. Anita. Please take us forward and impress the young people so that more and more people join this. I have a special interest because in my department in Apollo Hospital also, about 7 years back, I took over this hybrid program, and we have a gentleman who devoted time in endovascular. And then finally, he's a very full-time active member of neurosurgery. And definitely it made a tremendous difference to, who's this little girl? Hi, how are you? So this has really made a lot of difference. It has taken us some time to gain the trust of our other colleagues, especially in neurology, because, you know, traditionally the endovascular work used to be done by a neuroradiologist, but now time has changed because now we have a clinician who's very much interested, who looks after the complication. So why not do the procedure itself? And I think Dr. Anita will give us enough idea so that more and more people take it forward. Dr. Ramesh, you want to say something?
No, sir. Thank you, sir.
Dr. Anita, for you. Please go ahead. You are not audible. Yes, she can do it. She will be really good in that. I think you are still mute.
Yeah.
Just check whether you are mute or what.
Dinesh from support, are you available, Dinesh? Support, Dinesh?
Can unmute only.
Dinesh, can you help Dr. Anita in unmuting herself?
No,
because
sir.
we are getting the mute symbol on her.
You're on unmute only, man. No. He is muted or unmuted.
When she's doing this, how many people we have joining us, Dr. Murthy?
In the participants, I think we have more than 160 participants right now. And in the
that's great,
speakers
because I
one,
think they will benefit from this much more than the,
yeah, in the speakers link, we have around 20 people now. But at a stage when the presentations and all that, we are almost 32 in the speakers group.
Okay. Ramesh, you can say a few things.
Yeah, now, am I audible?
Yes, Ramesh,
yes,
you are audible.
Yeah.
Audible.
Now, I think the youngsters, now the need of the hour is training both endovascular and cerebrovascular. And as the case loads are increasing now, so we will be able to treat both endovascularly and open vascular surgery. And there is now tendency for the youngsters to get into fellowships into endovascular also. So I think the need of the hour is be hybrid or dual trained in both the endovascular and cerebrovascular. Very few centers in India are doing both work, as sir has told already. And GV had a endovascular training right very early on, where the neurosurgeons were being trained. And we see many people doing independently, those who are trained from GV Pant with good results. So I think we look forward to the
Dr. Anita, are you ready? I think what I noticed with this hybrid thing now that my department is doing for the last 6-7 years, there was an inherent bias. And that inherent bias was either due to expertise, due to confidence in each other, time of the day. Time of the day was very also important. You know, at wrong time, people will just chicken out. So it has changed completely. And the one thing which has really changed is how we discuss a condition's complications and outcome with the patient. And the way a clinician explains this to the patient is very, very different from a neuroradiologist, believe me. And every now and then we used to face problem because what they understood and what we needed to convey were totally different. Now this situation never comes to us. And we are with ease able to give them both options for a case which may have both options. And then we leave the decision to the patient or relatives. And it has made a tremendous difference. I think every department should have this because it is not that difficult. It takes 3-4 years to develop, and the department will support. Neurology neurosurgery can support, and then everything becomes so good. Should be the need of our. We are still not there.
Hello, Alex sir, you are able to hear me?
Yeah, I can hear you.
Sorry for the late. There is some local problem with the Anita's laptop, I think.
No problem.
No problem. Time to connect. Meanwhile, I think I'll take this opportunity because I also work with you there at Apollo. So I'll also like to ask you specifically, sir, what challenges did you face initially to resist the cath lab availability? I know it has been really difficult with one cath lab, and now we have more cath labs also. But what were the initial challenges? Just to continue discussion till the Anita.
Yes, I think you have asked a very, very important practical question. See, training can be done if the candidate wants to train, and we in our department, Rajesh was trained, and we supported financially. He went for training in Switzerland, he went to California, and so we had to financially support him. But once he came, the biggest hindrance was the cath lab. Because, suddenly the cardiologists who were also an important part and the intervention radiologists with whom they had already approximated their relationship, they were just not willing to give us the timing. And of course, it required a bulldozer like me with the support of my neurology department that, I could be a bulldozer in most of the situation. We were able to get the timing. And today, 7 years down the line, I can tell you that nobody questions. Am I right, Rajesh? Everyone has accepted it.
Correct.
So this was the biggest challenge. You raised the right point. How to get the cath lab. Not easy, and we don't have so much of volume to have our own cath lab. It's a huge investment. So you have to borrow the timing. Still, we face some problem, but now, we can always say that the patient is very sick, deterioration is on you, so they all panic and they give us a time.
Yeah, I think it is rightly said so, because I personally went through this hybrid vascular neurosurgeon concept. And initially, they really face challenges with financially, because the income generating is mainly neurosurgery, and suddenly you start doing endovascular, you create more time, only for 3 to 4 years, and then you really require strong support from the department.
Yeah, am I audible, sir, now?
Yeah.
Yes, welcome.
Yeah, sorry, I'm really sorry for this trouble.
No. Go ahead.
Yeah. Yeah, is it visible? Yeah. Thank you, Dr. Ranjan, for such a nice introduction and all about the hybrid neurosurgery, and of course about the GB Pant, which is a leading center in making the hybrid neurosurgeons, and all across India. In fact, KM is also another center which is creating hybrid neurosurgeons. Yeah, and I'm thankful to the Telangana Neurosciences Society also for inviting me to give the talk, and very grateful to Dr. Pratap, Dr. Krishna here, Dr. Reddy, and of course Mr. Venkatraman, I think, Chandrasekhar also, that he helped me a lot in doing this all. So without wasting time, I just go on to the next slide. So what is the need to define the hybrid vascular surgeon? And that too in the era when endovascular surgery is actually a way forward in the treatment of vascular pathologies. And you see, in the way, like long way back in 2003, the neurosurgeons actually predicted that the surgical experience, they noticed that the surgical experience is leveling off, even for the senior neurosurgeons, as the coiling was very much in the vogue. In 2007, Dr. Vaklu, a very famous neurointerventionist, and they also said that because of the advancements in the technology, because of the better coils, third generation, fourth generation coils, different kinds of microwires, microcatheters, which could access very distally located vessels for the AVM, new copolymers and for the AVM embolization. And this led to the improvement in the endovascular approaches and the outcome for AVM treatments. So what we see now, we are seeing more of the endovascular papers, publications on the endovascular surgeries, where we used to be very worried that children should not be treated, at least with the FD, where they would be requiring the long-term antiplatelets, but still there are papers coming which say that the children are being treated with the flow diverters, and that too in the territory of the ACA. That too in the ACA territory. And for the cavernous sinus aneurysms, of course, the flow diverter is a very good treatment modalities and well-established modalities. So what we see over the years, these are the gadgets which are used for the axovascular surgery, that is clips. There has been not very big advancements in the clips, of course, over the years, and the anastomosis is still very much required in very select cases where endovascular procedures also fail. But we see in the endovascular gadgets, we have variety and very rapid advancements in the endovascular gadgets available, like starting from the various types of coils to the simple stents, and then to the flow diverters, and of course now the web. But you see, with the more and more of the endovascular procedures happening and the publications happening, we wouldn't be surprised that surgical results would definitely be affected, because less of the skills would be there, technical skills, the surgical skills would be there in the next generation of the neurosurgeons. As we see, there was an editorial by Dr. Mehta, Dr. V.S. Mehta. He also pointed out that because of the recent advances in the endovascular procedures, endovascular techniques, and the availability of the flow diverters, there would be an increase in the endovascular treatment of the aneurysms. And there is a need for the young neurosurgeons to learn both the techniques, exovascular, endovascular, but at the same time, the bypass techniques has to be mastered. So what is hybrid neurosurgeon? Endovascular treatments has been established as first-line therapy for the treatment of cerebral aneurysms in US and Europe. And majority of the procedures are being done by the neurosurgeons than the radiologists. And what is a concern? But what is a concern actually? The aneurysms can be easily coiled. It requires comparatively lesser of the learning. Surgical skills, if more and more aneurysms would be coiled, surgical skills would be affected. Future neurosurgeons would only get cases which are not amenable for endovascular procedures. At the same time, there is less of the open surgical skills available to them. Lesions other than the vascular surgery, but where the vascular surgery plays a very big role in removing those lesions like skull-based surgery. Surgeons' inept handling of lesions of the skull base, and every trauma surgery nowadays that requires there's a trend of opening of all basal cisterns in the trauma surgeries, which is a prerequisite for all vascular surgery. So what is the need of revisiting the word hybrid? Many WhatsApp groups, they ask for opinions, and majority talk of coiling, even in a case looking very simple by clipping, which is economic, more lasting treatment. There have been more number of publications on endovascular management than open surgical management, perhaps because surgery is a proven modality, whereas endovascular surgery is in the phase of proving itself. And we know that both treatments are complementary to each other. They are not competitive. You see, there are articles which are publishing by the hybrid surgeons. And this was one of the paper, which says about unruptured anti-communicating aneurysms and which were treated by both the modalities. And they say there was 0% recurrence and retreatment rate in the clipping group. But at the same time, we can see an article by the same, again, hybrid neurosurgeon, which says there was 10% of the retreatment requirement in the clipping group, and it is lesser in the coiling group. So it is just contrast. So what we are seeing, the surgical skills are decreasing compared to the endovascular skills. So to make it balanced, a surgeon, which surgeon would be labeled a hybrid? Only doing exovascular work, only doing endovascular work, or a person who is doing endovascular work and exovascular work based on their comfort or the skill, and exovascular or endovascular work based on the best short-term and long-term outcome in terms of completeness of the treatment, no additional neurological deficit, economy, and generating future hybrid surgeons. So if we see this case, this was a referred case from somewhere, and this young lady, she had left-sided bleed, a big bleed. And of course, this bleed is looking in the Sylvian Fisher bleed. But this patient was treated at the periphery with a decompressive craniotomy with such a big flap and such a big opening of the dura. And luckily, since this was just decompressive craniotomy, they didn't, the basal area was virgin. And on CT angiography, this patient had IC bifurcation and MCA aneurysm, which was treated by simple means. This is IC bifurcation aneurysm, clipped, and this is MCA aneurysm, and the distal flow is quite good in both the case, in both the after both the clipping of the both the aneurysms. So what does it require? It requires the skills to open the skull base. That's it. It is not that endovascular procedures are easy. You can have this complete dissection of the abdominal aorta just after the iliac artery. You may find this kind of cases where you have to rely on either the other puncture sites or open surgeries. You may have the intraoperative ruptures of the aneurysm. So, and what we see nowadays, the anti-circulation aneurysms, mainly the ACOM, which is the most commonest aneurysm, they are being coiled. maybe because they are easy to coil and they require less skill. But at what cost? Coil cost, other hardware cost, radiation check angiography is required, and of course at the cost of the losing the microsurgical skills. But if one is hardcore microsurgeon, neurosurgeon, then again we are losing the microsurgical skills. So we need to make the balance between the two. We all know there are different categories of cerebrovascular diseases which require the both the modality treatment, aneurysms, AVM, fistula, vascular tumors, and carotid stenosis, and of course arterial venous thrombosis or dissections. So what are the issues? One is we need to see the location of the vascular pathology, complexity of the pathology, age of the patient, pregnancy, neurological deficit, skills, and adoption of both the modality treatment at the same time. So these are the cases like anti-communicating artery aneurysms or MC aneurysm, very easy to coil. But if we keep coiling the easy cases, which appear easy to coil, we won't be able to clip these difficult cases because we are not acquiring the skills by operating on these simple looking cases. If we are not doing these cases by open methods, like these are the skull-based tumors. This is the skull-based tumor. Again, this is craniopharyngioma, and this is planum sphenoidal meningioma. So both these this kind of tumors, they require exactly the same exploration and the microsurgical skills which are required to operate upon the anti-communicating artery aneurysms. So if we see this, the opening of the carotid and optic cistern or intraoptic cistern or liliquous membrane, they all are the basic of the microsurgery, dissection in the aneurysm skull-based surgery, and ideally they should be provided to the third-year residents so that they imbibe the interest and skills so that the fear of clipping the aneurysm is not there. And of course, we know that all dissection is exactly the same what is required for the clipping of the anterior circulation aneurysms. So you see, this kind of anatomy we can see only under the microscope. So there are different modalities which will show you best anatomy in different modality of treatment. Like in aneurysms, this is there are many perforators which are seen. This can be seen only under microscope, not during the endovascular treatment. This kind of dissection, reconstruction, avoiding the need of endovascular treatment, making it economical, and keeping the microsurgical skills alive of the young neurosurgeons. And that should be the priority. Now, these are the cases where we routinely see atherosclerosis in the vessel. So bad atherosclerosis. And we can see that this is not filling up during the IC angiography, this part of the IC, which is atherosclerosis. When we are taking the catheter in, when we are coiling the basilar top aneurysm, which is a norm nowadays, very few centers are getting 2 or 3 aneurysms a year for clipping of the posterior circulation. Even in our center, we are not clipping the posterior circulation. Majority are being done by the endovascular procedures. So this is going to be the future that if we keep continuing coiling all the cases of aneurysms, then we may land up getting the cases of anterior circulation also to clip. And we are not seeing this when we are introducing the microcatheters. We are not aware about the atherosclerosis which we are seeing outside, and this may cause. And our routine investigations like the CT angio DSA, they are not showing us where is the atheroma. Actually, all the cases. So that is one of the drawback of doing endovascular in all the cases. This is an aneurysm which is multi-lobed aneurysm. If we just clip one aneurysm dome, then we can miss the other aneurysm, and that could have been the cause of more of recurrences in the clipping group in recently published papers, and that could be the reason. So skills, to keep the skills alive, we need to do balance between the coiling and the clipping. Another case, similar kind of case, the superiorly projecting sac, and one is the posterior projecting sac. After applying a clip on the superiorly projecting sac in a ECOM aneurysm, we can still see the filling of the posterior projecting sac, and this can be this can only be avoided. Like this residual sacs happening can only be avoided by keep working and dissecting these kind of aneurysms. Again, radiation. Suppose a pregnant lady comes like this. She was a pregnant lady and she presented with the visual deficit on the ipsilateral side. And at the same time, if the patient has deranged renal profile, again, that is a limitation for using the endovascular procedures. But to keep these but to be able to clip these aneurysms, we need to keep updating our surgical skills. Again, a child, 3-year-old child with such a big hematoma, and there's DACA aneurysm, which is best clipped then coil, because in a 3-year-old child, we are giving the radiation, and again, of course, DACA is relatively difficult to coil also. These are the aneurysms, difficult ones for clipping. We'll get better neurological outcome in these kind of aneurysms, but of course, they require the follow-up. Again, 4-year-old child came with the dissecting aneurysms after giving incision, thinking that this is an abscess in the neck, and they are best treated by the endovascular work, because endovascular embolization, because this is the end artery. So you're not going to establish the flow. So better to block it, and this will be minimally invasive. Now, this is the patient who was referred with this kind of infarct. And if you have this kind of infarct with a deranged renal profile, again, this is not good for the endovascular procedure. So, and you see, there's a pica aneurysm. This is the open surgery which was performed. Vertebral artery, this is aneurysm, this is distal. After clipping the aneurysm, we can see that this is clipped, and this is vertebral proximal, this is vertebral distal artery. So, suppose an aneurysm is dissecting. So dissecting aneurysm where there is no distal flow, they are best treated by the endovascular means, and that again, the terminal basilar artery, they are also good. They are also will get good results by the endovascular means. It is not that endovascular is the minimal invasive. That what is the normal norm? In open surgery we go exovascular, and in closed surgeries we go endovascular, starting from the femoral. Right from the femoral puncture to the iliac, to the abdominal aorta, going to the arch, cannulating the different vessels, exchanging different catheters, adding different catheters, wires, taking the coils, taking the stents, and reaching right up to there. It's not minimal invasive. It is as invasive as the open surgeries. Multiple aneurysms in the posterior circulation, of course, they are better to coil. And the another advantages of posterior circulation territory is the anatomy is very easy. This course of the artery is very straight compared to the ICA or cannulating MCA or ACA. Again, one more lady with a medial hypophyseal artery aneurysm. So this kind of aneurysm clipping with the ACP drilling and all, they all require surgical skill. So surgical skill doesn't mean starting the surgery from the complex aneurysms. Keep operating, keep showing residents the easier cases also, so that they can perform these kind of complex cases, and they get chance to do the basal dissections. Another one more, this kind of case. So blister aneurysms, of course, we all agree that blister aneurysms are best treated by the FD. This is one of the case which is showing this appearance, but if a neurosurgeon performing the cases of by endovascular means, they can better follow their cases. This is a case of the medially directed IC aneurysm. 2.5 months ago, the FD was placed, and we can see that there is no complete occlusion of the aneurysm. So we just should not just go on doing the cases based on the literature. This our experience also adds on what modality is best for which kind of aneurysm. Now coming on to the other malformations like AVMs, we all are very much aware about the grading of the YASAR, of the valve, Spaessler-Martin grading, and There's grading which is given by the Yasargil and Balvanis. They are the actual hybrid combination of the people, surgeon and the neuroradiologist. So according to this classification, there are different grading of the AVMs, and that depends on the MRI as well as on the DSAs, the angiography. So they can be convexity superficial, they can be subcortical, convexity can be sulcal, gyral, sulcogyral, they can be subcortical AVMs, then they can be deep-seated AVMs as well. Based on the type of the feeders, they can be different niduses like monoterminal, multi-terminal, pseudoterminal, then indirect types of the feeding arteries can be there. They can be feeding arteries from the leptomeningeal, they can be subependymal, or which can be supplementary arteries, or they can be dominant arteries. So we are a hybrid person who is doing both endovascular and extravascular. They can fuse the images of both extravascular and endovascular, and they can create a 3D picture in their mind. They can understand the AVM better than a person who is doing only exo or person who is doing only endo. So these are the different kind of feeders. Like this is terminal feeder, which is not supplying any part of the brain. This is the feeder, which is indirect feeder, which is supplying the AVM as well as the terminal part, and some part of the brain is also being supplied by the feeder. So this all needs to be understood by a hybrid surgeon. This is the preoperative DSA of a child who bled. It is always good to excise the AVM and free the child with completely free, with a disease free. But when we are well versed with the angiographic anatomy, when we are doing the DSAs, and we see that there are AVMs which are terminal AVMs, terminal feeders, thalamic parts, central type, and draining into the deep venous system, we would know what to do with this kind of cases. And super selective angiogram, of course, definitely adds to knowledge of our understanding of our AVM. They can be diffuse AVMs. And they can be AVMs which are not diffuse, but their drainage is into the deep venous system. Then, of course, embolization can be with the onyx cast, and the excision, when we are excising the AVM, these are the veins which appear on the surface of the AVM, but they can be excised, keeping the anatomy of both the DSA and the CT angio, and what you see intraoperatively. This is the AVM which can be excised using the ICG. This is the ICG showing residual AVM, and after excision you can see the good feed. You see, this is the way. There's a big difference between the endovascular and extravascular procedures in terms of the vessel to first, which should be attacked first. Like in excision, we need to attack the arteries first. Whereas in endovascular, we take our catheter right up to the venous side rather than keeping towards the arterial side. So your cast starts, you start delivering your cast from the venous side rather than the arterial side. And in excision, we deal with the vein in the last, then compared to the endovascular. So these are the cases which were occluded using the NBCA. And you can see this is the supplementary feeder from the MCA with an aneurysm in the nidus. This is a main feeder, dominant feeder from the ACA, and this is a selective shoot. And after embolizing this aneurysm and all, and we can see that there is some remodeling of the circulation which is happening. What this remodeling is, you understand once you do the endovascular procedures, because you don't get to see remodeling immediately during surgery, but during excision. But of course, with ICG, we can appreciate that. This is the area of the anterior frontal lobe. This is the nidus, and this is the area where we keep operating. Even during trauma, we keep doing lobectomy and all this. We are very familiar to do, and very good for the excision. These are cases. When we keep doing the cases, like the way we get the problem in, sometimes we don't have the appropriate clip which we want during the clipping. Similarly, we may find the same problem when we are coiling the aneurysm. So, and we know that when we are when we open the case and we see the sac is very quite ballooned up, and this can accommodate good amount of tissue or whatever foreign body. So taking two catheter is a norm nowadays in endovascular procedures. One catheter carries the coil, other catheter either balloon or the stent. But neurosurgeons, the surgeons always, they work like little economic, in economic ways also. If we do not have the adequate sizes coils in our bag, then instead of taking one catheter, we can take two catheters inside the sac, and we can coil the aneurysm with the limited sizes of the coil. Like these are the cases where we had the constraints of coil size or comorbidities or stent was a constraint. Then these were the cases where two catheters were taken and they were coiled, and these are the cases where two dual catheters were taken inside the sac and they were coiled. And we could achieve good Raymond scale also post-operative. Of course, these cases need to be followed up for a longer period of time. Basilatop, again, this was also coiled using the two catheters. The CCF also can also be coiled in the same way. And we are very familiar. It's not that we are not familiar with the angiography. Actually, the direct puncture and all, they were the domains of the neurosurgeons only. The only need is to practice the DFA and handling of the hardware. That is the need of the time. And practicing microdissection and anastomosis is required to keep our surgical skills alive. Dural AV fistulas can be neatly done with endovascular procedures just by 1 or 2 drops of the NB3A. CCF, very good results just by embolization. Again, we can use coil, we can use the embolizing agents also. Another case of CCA, good outcome. You see, with time, the fistula's communications stay close. And these are the best examples of showing the flow diversion. When we waited for some time after deploying coil, just say around 2 minutes or 3 minutes time, when the intranidal pressure decreases, intra-sac pressure decreases, we can see that the ophthalmic is occluded here. So there is complete occlusion of the fistula. So this coil's mass or any foreign body that gives the flow diversion and hence helps in the occlusion of the fistula. Another case, trauma, very good endovascular results. This is traumatic aneurysm, best by the stent, which helps in endothelization of the artery. And CCF with the traumatic aneurysm of the cervical ICA. Best treated by the endovascular means both the CCF as well as the aneurysm, subaneurysm. This is pre-op and this is post-op of the same patient. Spinal AV fistula can be treated by both means, the endovascular means or by the open. This is pre-operative and this is post-operative. You see, it is a very good modality for the stroke patients, whether it is a ICA stenosis or it is thrombectomy. This was the case where this patient had fat embolism, and this shows very little fluid in the ophthalmic artery. After recanalization using the RioPro and the heparinase saline, we can see the blush. And this is pre-operative fundus and this is post-operative fundus. So it is very good modality for the stroke patients. And so there was an article which was written by Dr. Abrar, and these are the people who actually got trained. They were the consultants who actually got trained in endovascular surgery when they were not exposed to the endovascular procedures during their residency period. And they started doing the hybrid surgery in their institutions. And incorporation of basic skills it is a need of the time. Incorporation of the basic endovascular skills in the curriculum of the trainees is a need of the time. And American Board of Neurological Surgery has already started this, and this is mandatory there. So to conclude, dual training program in the curriculum of neurosurgical residency has proven to be beneficial in Western countries. And as Dr. Ranjan said, Dr. G.V. Pant is an example. Every case has to be well understood. Keep the microsurgical skills alive in future neurosurgeons to do other cases, making them do the skull base dissection, opening of cisterns to remove the fear, In the learning path of endovascular modality, hybrid neurosurgeons are inept at anastomotic skills, which needs to be worked a lot. Exovascular treatment will continue as the affordability is a concern in our country, whereas the middle growing class, they are more demanding for the endovascular intervention. So we need to be expert in that also. We need to create proficient hybrid neurosurgeons who has extensive exovascular and endovascular exposure. So these are our mentors, and actually because of them, GV Pante is able to do the hybrid neurosurgery, Dr. A.K. Singh, Dr. Ajay Sharma, Dr. Sinha, Dr. A.K. Srivastava, and the game changer, Dr. Daljit Singh. So we need to understand which mask to use, so which procedure to use, and when to use and where to use. Thank you very much. Thank you for patience listening.
Thank you, Dr. Anita. It was a very lucid presentation. May I ask you a few questions?
Yeah, sure, sir.
You are a public hospital, and you have brought out some very, very interesting points, because you must be having a good case load. So what is the total number of endovascular procedure you do in a year, and how many exovascular in a year for all combined? How many exovascular and how many endovascular procedure you do in a year?
Sir, you're not very much audible. Can you? Yeah, just a minute.
Can you hear me?
Yeah, it's better now.
Yeah. So how many endovascular procedure is done in GV Pant Hospital every year, and how many exovascular procedure done in GV Pant every year? Roughly. I am not looking for a ballpoint.
Yeah, sir. We have more than 150 cases a year of the aneurysms, and around 50 cases of AVMs, including fistula, CCF, and other kind of fistulas communication, sir. And in our setup, of course, and in fact, in my training also, I didn't see many of the cases of posterior circulation being coiled. So majority of posterior circulation are being, clipped. Majority of posterior circulation are being coiled only. And anterior circulation, of course, ACOM, MCA, still there is a trend of clipping than coiling. Okay. And then it's a ratio of 30-70, you can say. 30% is endovascular procedure and 70% is 30% is endovascular and 70% is exovascular procedures.
You're approximately, if I'm not wrong, you're doing about 20 to 30 cases every month for all combined. Yeah, am I right? Which is a very good load, and obviously you can talk with a lot of experience.
Yeah, almost every day we are doing 1 or 2 cases, sir. So sometimes every around 30 cases a month.
No, that's I think of course GV Pant is now well-known center, and being a public hospital, it has its own strength as well, not the weaknesses. People think there are weaknesses in public hospital, but there's a lot of strength in public hospital.
Yeah, you're right.
The volume makes you much better. But are you the master of your own kingdom? Do you have your own cath lab, or you have to share with other people?
No. That is the beauty of our, that way we are fortunate actually, sir, that we have our own DSA machine in our OT only, and we don't share. We don't need to share with anybody.
Great. Dr. Ramesh, you have anything?
Yeah. Good evening, madam. That was a very comprehensive talk covering all the aspects of endovascular. My question was regarding the training. So it's very fortunate to have both the endovascular and exovascular training during your residency. But what advice do you give for youngsters who pass out from a place where they don't have endovascular exposure, whether to go for a fellowship immediately or spend some time in open cerebrovascular, doing neurosurgeries and then shift to fellowship? So what is your take on that?
Yes, very good question actually. If you see, there are 2 aspects. One is resident and one is faculty, where there are no training of endovascular at the places the faculty should go for the training, so that the residents do not miss the chance of getting the exposure. Number 1. Number 2, about residents. Many residents are coming to GV Pant during their residency period also. To see the cases, and in fact many of them, they learn to do the DSA at least the puncture of the arteries, taking the catheter, understanding. So we are getting many residents from across India, from many places, to learn this. And even after doing MCH also they are coming. Then about fellowship, if you do the fellowship from outside India, then they don't allow you to touch the patient. You're just a spectator there. But one way is best is that they can be circulated, they can be rotated, where the centers are providing training in both the specialties, and if and they should have certain amount of confidence, or they should have come across certain number of cases when they feel like, okay, they're finding difficulties or problems in understanding these kind of cases, then only they should go for the fellowships, not from the very beginning. Otherwise, they'll not get hands-on. And secondly, now there are companies, they are giving the simulators, and they can do practice on those simulators, where they can have the feeling of their cases are loaded in the computers. They can do those cases, even they can practice angiography, they can practice taking the catheters, making the hand-eye coordination of the seeing the monitor, working down, seeing the monitor, seeing 1, 2, 3 monitors at the same time. So all those things are required. Actually, neurosurgeons are used to of doing this, because they are working under the microscope. They are doing all those things. And nowadays, this generation is very smart, because whatever we are doing with the car, driving the car, seeing so many mirrors, it's just like that. You need to apply that during your surgical training. That's it.
I see my long lost brother, Dr. L.T. Kishore, a very great neuroradiologist after a long time. Sir, do you have any comments?
Actually, I just joined. I'm not sure whether Dr. Anita is a radiologist or not.
She's a neurosurgeon, sir.
She's a neurosurgeon.
And a radiologist.
Okay. Yeah. In my experience, I have seen that interventional procedures are nicely done by neurosurgeons, because they have that feel with the surgery and using the hands and fingers and all those things. They are very good quality interventional interventionist. There is absolutely no problem. And there will always be a sort of turf fight, whether the radiologist should be doing these things or the neurosurgeons will be doing these things. But I think at the end of the day, whoever is doing a good job eventually will take it over.
Absolutely. Well said. It is the patient who will decide. Dr. Vijay Sardi, good evening.
Sir, good evening, sir.
Give us anything you would like to.
Hello.
Hello, Dr. Vijay.
Yeah, hello, sir. Hello, ma'am. How are you?
Well, it's all good.
I was, yeah, nice to meet you, ma'am. It was very nice talk.
Anyone else would like to add anything? I think your talk was quite complete, so that's why the questions are not coming, because you have already answered them before they can be raised.
Yeah, thank you, sir.
Yeah, I think it was quite complete. You have covered the whole topic, whole gamut of things where surgery and endovascular both cross each other.
This is the need of time, actually, sir. That is what we feel every day.
Very, very nicely done. Organizing committee, any comments?
Yes, sir. Thank you. Thank you. Shall we conclude the session, sir?
Absolutely. Thank you, Dr. Anita.
Thank you, sir. Thank you all. Thanks.
And thank you, Professor Anita. Thank you to both the chairpersons. Next session, we have Puzzles in Neuroimaging by Dr. Ravi Verma. He is a consultant neuroradiologist in City Neuro Center. And I request Dr. L.T. Kishore and Dr. Vijay Sardi to chair this session. Sir, Dr. Kishore.
Yeah. I think,
welcome, sir.
Thank you.
Right.
Dr. Vijay Sarthi, why don't you start?
Sure, sir. Sure.
Go ahead.
Thank you, Chaudhary and Dr. Ramakrishna, for asking me to chair this last program of today's session. I think we have Dr. Ravi Verma, who is a good friend of mine, who will be talking to us on the puzzles in neuroradiology, which is very interesting. Rather, instead of gala dinner, in a COVID times, we are having the puzzles of Dr. Ravi Verma. Ravi Verma was a good academician. He was junior to me in Gandhi Medical College. After that, he has pursued his DM Neuroradiology from Chitra. and currently is working in City Neuro Center after moving out from KIMS. I welcome Dr. Ravi Verma. Let us see how puzzles and pitfalls in neuroimaging. Over to you, Dr. Ravi Verma. Thank you.
Thank you, Vijay Salvi. Thank you, Dr. L.T. Kishore. And I should also thank the Telangana Neuroscientists Society and especially Dr. GVS Chaudhary for inviting me to this presentation. I should say this is not a formatted presentation. It's more like a collection of clinical scenarios, imaging scenarios that we come across in our day-to-day practice, and where we actually think, what do we do next? And we also, in our day-to-day practice, we face situations where we don't understand the limitations of imaging technology, and thereby we tend to make mistakes in ordering for an investigation or interpreting an investigation. So this 45 minutes, what I'll be discussing is some common scenarios that we see in our practice. Both neurologists, neurosurgeons, and radiologists are interested in most of these conditions. And I'll give you small tips as to how we can approach each of these and how imaging, we can look at small clues, and that can help us in coming to a diagnosis, or at least a differential diagnosis. I should also say that these are general principles. These are not golden rules. Definitely, patient to patient, you would have a different set of investigations. For example, in a patient with renal failure, your protocol has to be different as compared to somebody who's pregnant, who's completely different from somebody who's requiring sedation, who is not likely to cooperate for an MRI. So these are general principles, not golden rules. And in this 45 minutes, I'll be discussing only the imaging features and how to approach the imaging findings. Obviously, you have the data of clinical information. You'll have some amount of laboratory data, other investigations. All these actually help in making diagnosis. But for this presentation, in interest of time, I'll limit myself to only imaging clues. And definitely, these are you'll have some amount of influence of my practice, my patient load, my colleagues who send me cases, and what equipment I work on. Obviously, some of these will be influenced. What I'm going to say is going to be influenced by some of that also. So you need to take into consideration what equipment you have, what your radiology department has, what sort of experience your radiologists have, and a lot of other factors before you need to take all those into consideration before interpreting these things. Starting first with ring enhancing lesions. These are quite common. And most problems in interpretation of ring enhancing lesion comes because we don't look for the correct investigations. We do a plane study, a contrast study, and we do a T1 and T2 and flare. And if lucky, we do MR spectroscopy. For a practical interpretation and for getting maximum information about a ring enhancing lesion, we need to have the entire set of investigations, because each investigation tells us one unique bit of information regarding the pathophysiology. So we need the T1, T2 conventional images, post-contrast T1 weighted images. You need to look at both diffusion weighted images and ADC maps. And susceptibility weighted imaging is very important. Perfusion is very, very important. When you do contrast, almost all machines in the city now or in the state now have ability to do perfusion imaging. And we should make use of this modality, get your radiologist use this modality more often, and spectroscopy should be given adequate information. And all these should be done in a single setting rather than calling the patient back for a contrast study later and spectroscopy done later and all, because the morphology also changes, the pathophysiology we will not be able to get a correct picture of what is happening. Starting the discussion with this case of metastasis, a ring enhancing lesion. You can see the T2 weighted images. The wall of the lesion is hypointense on T2 weighted images. It is isointense on T1 weighted image, and it is showing enhancement and post-contrast study. The hypointensity in this lesion indicates a cellularity in the wall. The central necrotic component is hyper on T2, hypo on T1, and is not enhancing on contrast. This is indicating of necrosis. The perilesional edema does not enhance. And if you look at the diffusion, the peripheral solid component is showing restricted diffusion. And then you can see patchy hemorrhages in the wall. There's no uniform ring, but patchy hemorrhages along the solid components. This indicates hypervascularity in this area with altered blood-brain barrier. And if you look at the ASL perfusion imaging, you see increased blood supply to this lesion. Spectroscopy shows a large choline peak as well as large lipid peaks. This is a characteristic signature of a metastasis. Glioblastomas, morphologically, they look similar to metastasis. The difference our signal intensity wise, the signal intensity is virtually the same. The difference is these are generally single lesions. They are predominantly in the white matter, whereas metastasis in the gray matter. They can reach the gray white matter junction. Metastases are predominantly at the gray white matter junction, whereas glioblastoma, high-grade tumors are predominantly in the white matter. They can reach up to the gray matter. And if you look at the perfusion images, again, you can see increased perfusion and spectroscopy. Apart from having a elevated choline peak and the central necrosis showing the lipid peaks, you can also have small amounts of NAA peaks, suggesting that the tumor is an infiltrative lesion. And apart from the location, the second thing that can actually differentiate between a glioblastoma and metastasis is actually doing spectroscopy surrounding the mass. We don't do it clinically, but definitely we can come to a conclusion that it's a neoplastic lesion with a possibility of it being either a metastasis or a glioblastoma based on the perfusion as well as the MR spectroscopic findings. In contrast, infective lesions are characterized by smooth, thin rings. You can see on the T2 and T1 weighted images, the ring, the margin of the lesion is quite thin. It is the central necrotic core that is showing restricted diffusion. The margin, the inner layer of the margin over here is showing restricted diffusion, but then the actual margin of the lesion does not show restricted diffusion, just like in tumor, as what happens in tumors. It shows a thin rim of T2 hypointensity with blooming on SWI. This complete ring of blooming on SWI is a feature that is typically seen in abscesses. So these are pyogenic abscess. Why do you say pyogenic abscess? We have some spectroscopic features that are typical of pyogenic abscesses. You have, apart from the necrotic components giving off lactate peaks, there's a low T and there's a high T spectrum, intermediate T spectrum showing the lactate peaks. Apart from that, we do have amino acids at 0.9 ppm. We do have succinate and acetate. These are indicative of an abscess and specifically an anaerobic abscess. This information can be brought out very well with the MR spectroscopy. We should be aware that this spectrum has been taken from the center of the lesion. In the center of the lesion, we don't get an N-class aspartate. The machine is interpreting this as an N-class aspartate peak, but in reality, there's an acetate peak that comes at 1.9 ppm, very close to the N-class aspartate peak. So thereby, sometimes the machines misinterpret it as an N-class aspartate peak. Perfusion shows reduced perfusion within the lesion. Differentiation between pyogenic and tubercular abscesses sometimes is possible, not always. In the presence of additional lesions that are typical of tuberculomas and a single lesion that has a thick wall with central necrosis, the necrotic component showing restricted diffusion like all abscesses do, the wall being showing a thin T2 hypointense rim with blooming on SWI. These are features of abscesses. And when your spectroscopy shows extremely large lipid peaks without amino acids, you have a case to say that it is more likely to be a tubercular etiology rather than a pyogenic etiology. Fungal abscesses, the morphology gives you clues. Right, rest of the ring enhancing lesions, these are thick wall ring enhancing lesions. The wall is quite irregular, and typically inside the enhancing wall, you see areas of T2 hypointensity that show restricted diffusion. These are thought to be fungal hyphae that extend from the wall of the lesion into the center. They don't enhance on contrast, they show restricted diffusion. This is a typical feature that you see, fungal lesions. Of course, the periphery can show blooming because of accumulation of minerals. MR spectroscopy, the typical imaging feature that is supposed to be seen is a trihalose peak, but we rarely see it. All we see is the lipid and lactate peaks that we see in any other abscesses. Toxoplasmosis, leaving alone the clinical setting, imaging-wise, we can make a diagnosis of toxoplasmosis looking at the size and location of the lesions. Predominantly the lesions are in the basal ganglia and at the gray white matter junction. As compared to the rest of the infective lesions, the basal ganglia has basal ganglia lesions are quite very commonly seen with toxoplasmosis. The wall shows restricted diffusion. The core of the lesion does not show restricted diffusion. And then the typical concentric target sign on T2 weighted images and the eccentric target sign on the T1 weighted images, where you have layered appearance of an outer layer of enhancement, an intermediate non-enhancing zone, and an inner layer of enhancement. This pattern is typical. If it is seen, it is quite typical of toxoplasmosis. Obviously, your clinical clues will always be there. Close differential diagnosis for infective as neoplastic lesions is tumefactive demyelination. In tumefactive demyelination, again, the lesion is in the subcortical white matter. and it is hypointense on T1 weighted images, hyperintense on T2, and you have an incomplete ring of enhancement, and this sign is quite typical of tube factor demyelination. We have to see it in multiple planes in order to identify this incomplete ring. The point of the area of the ring, the area of the lesion that is pointing medially would show enhancement, whereas the outer aspect of the lesion would not show enhancement. Diffusion weighted imaging can show restricted diffusion along the periphery. This is because of myelin edema, not because of ischemia or hypercellularity. And spectroscopy is very non-specific. You can have lipid peaks, you can have lactate peaks. Most often you don't have very high elevation of choline peaks. And time will tell. That's the best way of identifying a tube factor demyelination. Obviously, computer resolution of the lesion after a course of steroids is the best way of documenting that it's a tube factor demyelination. Ring enhancing lesions, it is easy to talk about a lot of things, but practically speaking, we always have problems in identifying what exactly the pathogenesis of ring enhancing lesion is, whether it's a tuberculoma, TB versus cyst sarcosis, it becomes very difficult, especially when you have a calcified lesion. Even though the lesion shows a little bit of enhancement in the periphery, it's very difficult to pinpoint saying that is it tubercular etiology or cysticercal etiology when it is at this stage. When it is in a degenerating stage of cysticercosis, we can make a reasonable diagnosis. Most often the lesions show a peripheral hypointense wall. They are small, less than 2 centimeters or 1.5 centimeters according to different groups. The lesions are small, the wall is hypointense, they are irregular. There is a nodule, mural nodule that is seen in the center of the lesion. The lesion, if on CT, the mural nodule shows calcification and it can show enhancement. The wall shows regular enhancement in post-contrast study. You have mild perilesional edema. And if the content shows suppression on flare sequence, that is one major pointer towards cysticercosis. Spectroscopy does not show you the elevated lipid peaks that are typically found in tuberculomas. In contrast, tuberculomas, caseating tuberculomas are iso or hypointense on T2 weighted images, isointense on T1 weighted images. They show garland-like enhancement or the so-called coalescing lesions you see on in tuberculomas. They don't show restricted diffusion. They can show some amount of calcifications in the periphery, and then the MR spectroscopic signature is extremely high lipid peaks seen at 0.9 and 1.4 ppm. Cysticercosis. The characteristic feature of cysticercosis is the mural nodule. If you're able to identify a calcified mural nodule on CT, you further don't require any other investigation. On MR, the best sequence to document this mural nodules is a Fiesta or a CIS3D or BFFE, depending on which vendor's machine you're working on. They can be seen also on diffusion-weighted sequences as well as on SWI sequences or gradient echo sequences. And the second thing that makes a positive diagnosis of cysticercosis, though it is not commonly seen, is that the cysts, the viable cysts, are bright on T2 weighted images, somewhat similar to CSF, and they show complete suppression on flare sequence. This is a finding that is not seen in any other infective or non-infective ring-enhancing lesion. This is a feature that is typically seen with cysticercosis. Coming to multiple white matter lesions, these are quite common. The etiology can range from uveos in normal individuals down to multiple sclerosis, down to more ominous diseases like vasculitis, etc. So, imaging approach to multifocal white matter lesions, the commonest doubt that we all have is that, is this multiple sclerosis or something else? It is easier to exclude multiple sclerosis than to identify what exactly the pathology is. In my practice, at least, that's what I found. Multiple sclerosis has got a typical pattern that's been described well in textbooks. You see that most lesions are in the periventricular white matter, that is around 1 to 1.5 centimeters from the ventricular margin. They radiate out from the ventricular margin, and they are hyperintense on T2 weighted images and flare sequences. Flare is the best sequence to document these. You have juxtacortical white matter lesions, that are lesions in the subcortical white matter that are touching the cortex. This is quite typical of demyelinating etiology. You have significant number of posterior fossa lesions that are very uncommon in other white matter diseases that I talk about. You have a diffuse white matter involvement beyond these plaque-like lesions. There's this so-called dirty appearing white matter that is typically seen in multiple sclerosis. You have corpus callosal lesions. You have lesions in the deep grammatic nuclei, especially the thalami. On T1 weighted images, you have hypointense areas that are called black holes. You can have hypointense lesions as well as black holes, and that increases the specificity of making a diagnosis of multiple sclerosis. And enhancement is a feature that is typically seen, that helps you make a diagnosis of multiple sclerosis. When you see any of the other features that I'm going to enumerate below, you should think twice whether this is multiple sclerosis or not. The patterns atypical for multiple sclerosis are having all the lesions in the supratentorial white matter and not having any lesions in the infratentorial white matter. That is, no lesions in the pons, no lesions in the cerebellum, you need no lesions in the cord. You need to think about other pathologies rather than multiple sclerosis. If you have lesions only in the deep white matter, in the frontal and parietal lobes, and no lesions in the temporal lobes and occipital lobes, again, you need to think about other pathologies because temporal lobe lesions are also quite common in multiple sclerosis. Lesions only in the deep white matter, no periventricular white matter lesions, no juxtacortical white matter lesions anywhere near the cortex. Again, we need to look at some other pathologies. No corpus callosal lesions, no capsular white matter lesions, no cord lesions, no optic nerve involvement. These are things that are odd for multiple sclerosis. When you have extensive white matter lesions with very few focal lesions, again, you should think in terms of other pathologies. When you have cortical pathologies, when you have microhemorrhages or leptomeningeal enhancement, nodular enhancement along the leptomeninges, these are red flags, and that should make you think about other differential diagnoses beyond multiple sclerosis. What are the differential diagnoses? UBOs are quite common. For a lack of better terminology, we label them as unidentified bright objects. These are small, punctate, less than 5 millimeter T2 hyperintense, flare hyperintense lesions that are predominantly in the periventricular and deep white matter. They have a predominant frontal and parietal lobe predominance. They usually don't occur in the temporal and occipital lobes. Definitely not in the posterior fossa. And this to show that there are virtually no lesions in the white matter. These are benign lesions, most very commonly seen. Almost some studies have quoted up to 50% of individuals showing these lesions. But with an advancing age and with other vascular risk factors, these have been shown to increase in number as well as size. And the border between ischemic lesions and UBOs blurs down as the age advances. In contrast, aging is also associated with multiple white matter lesions. They, beyond these small punctate lesions, you also have confluent areas of hyperintensity that are predominantly in the parietal white matter. These have a higher correlation with the vascular risk factors, and these can be associated with prominent Werkorobin spaces. These are other things that can appear like punctate or small T2 hyperintense lesions in the brain. Again, just like with any small vessel vascular disease, you have lesions that are predominantly in the supratentorial white matter with less lesions in the posterior fossa. Also, you have lesions predominantly in the frontal and parietal white matter with very little pathology in the temporal lobes. These are more indicative of a ischemic pathology rather than a demyelinating pathology. Migraine patients have white matter lesions. These are ill-defined amorphous lesions that are located in the deep white matter, no periventricular white matter lesions, no subcortical white matter, juxtacortical white matter lesions, multiple lesions, not hypointense on T1 weighted images, and no corpus callosal, no brainstem lesions, no temporal white matter lesions. These could be because of migraine in the correct setting. Watershed zone infarcts, these are typically seen in a characteristic location that are in the watershed zones. You know that this is the anterior cerebral artery territory, this is the middle cerebral artery territory. And when you have a critical stenosis in one of the supraclavicular ICA, what you have is infarct in these locations. The locations are typically along these lines between the ACA territory and the middle cerebral artery territory. And you should extend the study to include an MR angiogram that will make your diagnosis accurate. Other demyelinating lesions, ADEM. ADEM is a monophasic disease. Imaging in ADEM also shows you a monophasic disease. Virtually all the lesions are of the same imaging pattern. They're all hyperintense on T2 weighted images, slightly hypointense on T1, and they show open ring of enhancement. And virtually all lesions show the same phase of enhancement. You don't have non-enhancing lesions and enhancing lesions in the same setting. And you never have T1 black holes. These are a typical feature that you see acute disseminated encephalomyelitis. Sarcoidosis sometimes can have re-enhancing lesions in the brain and multiple white matter lesions. Typical lesions in sarcoidosis are extraaxial. They are predominantly seen in the leptomeninges. You see nodular enhancing areas in the leptomeninges. You can have enhancement along the cranial nerves. And the white matter lesions usually don't enhance. These represent actually the ischemic changes because of the microvascular changes caused by the subarachnoid granulomas. Vasculitis has got a non-specific imaging appearance. You can have subcortical or deep white matter involvement. Again, most of the lesions are supratentorial. Sometimes you do have cortical involvement, you have microhemorrhages, but then in a given patient, most often we don't see these signs. So making an imaging diagnosis of vasculitis is very difficult. The common mistake that we do in imaging of vasculitis is to look at MR angiogram and say the vessels are normal, it is not vasculitis. Definitely MR angiogram and mostly CT angiogram, the resolution is not adequate to pick up the changes that we see in small vessel vasculitis. Maybe you can pick up Takayasu, maybe you can pick up medium vessel vasculitis sometimes, but most of the lesions that multiple white matter lesions are caused by small vessel vasculitis. These are out of the range of either MR angiography or CT angiography, and MR angio and CT angio are going to be normal in these individuals. Coming next to parenchymal hematomas. The common question that we have when we look at a case of parenchymal hematoma is to see whether it is actually a hypertensive hematoma or is there any underlying other pathology that is to be treated. So remembering the time course of the hematoma on CT and MR is quite important. I'll not go into this. And location of hematoma is also very important. The most important indicators for hypertensive hematomas, the locations that are commonly seen, hypertensive hematoma is commonly seen, are the basal ganglia, the putamen and the caudate nuclei, the thalamus, the pons, and the cerebellar dentate nuclei. These are the locations that are typically seen with hypertensive hemorrhages. Locations that are beyond this, lobar hematomas, cerebellar hemispheric hematoma, not close to the dentate nucleus, multiple hematomas, or hematomas that are fairly large, dissecting out from a subarachnoid space. You need to think in terms that though this could be in the capsuloganglionic region, when it is very close to subarachnoid space and there's an apparent continuity to the subarachnoid space, you need to think beyond a hypertensive hematoma and look out for underlying pathologies. Also, if you look at the pattern of the bleed, that also can give you clues. The location of the bleed in areas close to the skull base, anterior skull base, or the middle cranial fossa, multiple locations, bilateral locations. These are typical of traumatic contusions, hemorrhagic contusions. Location along the lateral aspect with central hemorrhages and large area of hypodensity surrounding this, you should always think in terms of whether it's a venous infarct, and bleeds with multiple fluid levels, you should think in terms of coagulopathy as being the cause. Beyond this, MR sometimes shows you if there is an underlying pathology. This is an example of an arteriovenous malformation. All modalities during the acute phase of the hematoma, it is very difficult to actually interpret the investigative modality because the hematoma interferes with your appreciation of blood vessels. This is a subacute hematoma with a T2 hyperintense, T1 hyperintense hematoma. You can see that there is a small area of altered signal intensity along the posterolateral aspect, showing enhancement on post-contrast study, blooming in SWI, nothing on MR venography, nothing on MR angiography. This was initially interpreted as a cavernoma elsewhere. And the odd point was cavernomas are never in the subcortical white matter. And the pattern of enhancement, it doesn't show the sort of homogeneous enhancement that you see with cavernomas. So somebody else asked for a CT angiogram. CT angiogram showed some abnormality over here. Again, it was a doubt whether it was a cavernoma or whether it's the calcifications of a cavernoma or a small vascular malformation, because there's no early draining. And this is one thing that tells you regarding the pitfalls of MR angiography and CT angiography during an acute phase of a hematoma. During acute subacute phase, the T1 hyperintensity interferes with the enhancement. The mass effect caused by the hematoma compresses on the veins, and you will not be able to get the true arteriovenous shunting on CT angiography or MR angiography. TSA is the modality of choice. If you want to image the subacute hematoma with a intention of picking up a AVM underlying it, you need to go for a DSA always. And this is the same patient. He actually had a small subcortical white matter AV malformation with a draining vein there. The draining vein is not seen either on CT angiogram or MR angiogram. So DSA is the modality of choice during the acute phase. This is another cavernoma. In contrast to the previous case, you can see that the lesion is actually heterogeneous hypointense. I'm sorry, I should have put a contrast enhanced study. It was showing heterogeneous enhancement. The whole lesion was showing a typical cavernoma-like enhancement. I think the image got missed over here. So this was a typical cavernoma. Hemorrhagic metastasis, imaging-wise, differentiation between hemorrhagic metastasis and a non-enhancing lesion, a cavernoma, would be difficult. Imaging clues, during the acute phase, you have good amount of perilesional edema. This patient was scanned within a couple of days after the onset of the hemorrhage. You have a blood fluid level, which is odd for a hematoma with a cavernoma. You have perilesional edema, that is acute. In the acute phase, it is very, very odd. And you have enhancement along the wall of the hematoma in the acute phase itself. This is very, very odd. So this made us think in terms beyond cavernoma as a cause. And then this turned out to be hemorrhagic metastasis from a CA breast. Also, we should always remember that hematomas can be caused by isolated cortical venous thrombosis, especially when you have a cortical subcortical white matter hematoma. Always look out for the veins. We can see the cortical veins on T2-weighted images as flow voids. This is a normal parietal cortical vein. On this side, you can see that the cortical vein is quite large, thickened. You may see T2 hypointensity over there. You may not pick up the thrombus there on T2-weighted images. If you do SW, you'll pick it up. On sagittal, you can see the normal cortical vein, the enlarged cortical vein. MR venogram may be completely normal. But if you do a post-contrast study, you can see a filling defect inside the vein over there, the cortical vein that is supposed to be over here. And this makes you make a diagnosis of a cortical venous thrombosis. Isolated cortical venous thrombosis is very difficult to diagnose. And then your correct protocol needs to be done. MR has to be done with the correct protocol in order to pick it up. Arterial narrowing, very commonly we see arterial narrowing because we do a lot of imaging for strokes. And MR angiograms, CT angiograms are done left and right. And then when we have a case of arterial narrowing, we need to look at whether it's really there, and we need to understand the pitfalls of each imaging modality. We should understand that CT angiography is a lumen-based imaging modality. We inject contrast into the vein, and as the contrast is passing through the lumen of the artery, we are doing an angiogram, we are doing a CT scan. So thereby, wherever you have a lumen, wherever the blood goes into the lumen, you have depiction of the vessel there. In contrast, MR angiography is based on flow. We don't give a contrast. Most often, 95% of MR angiography done in the country are non-contrast MR angiograms, and this is based on just the flow. And anywhere where the flow is altered, for example, if you have slow flow, MR angio may not pick it up. If you have fast flow, MR angio may show flow voids. All these problems can be there with MR angiography that we should understand when we are interpreting MR angiograms. CT angiography, DSA is a modality where we are injecting contrast. It's an invisible modality, but it is the best imaging modality when it comes to depiction of small blood vessels. When it comes to depiction of whether the pathology is there or not, it is very, very clear. It is the gold standard even today. Coming to pitfalls of MR angiography, these are a collection of cases, a normal individual, another normal individual. But then you can see that the appearance of areas where the blood vessel is passing through a horizontal plane differs. When you have this somewhere around 50 or 60-year-old individual, this is a slightly older individual with more tortuous blood vessels. When you have tortuous blood vessels, when the blood spends a lot of time in the axial plane, in which the MR angiogram has been acquired, the blood tends to get saturated, and you may have signal drops in these particular locations, and you may have artifactual stenosis in these locations. So typical locations where it occurs, the cavernous segments of the internal carotid arteries and the horizontal segments of the middle cerebral arteries. These areas, before jumping to a conclusion that there is a stenosis there, remember that artifactual stenosis quite commonly occurs at these locations. And you should remember you should think whether it's really there or not. Again, at the petrous apex, very commonly we see this artifact. There's a junction where your vertical segment of the petrous ICA joins the horizontal segment of the petrous ICA. This area is where your petrous bone and the aerated cells occur at this location. This flow change that occurs from the vertical to horizontal segment, as well as the air cells in this particular location, all these cause this sort of complex artifact. If you notice, it is an ill-defined band of hypointensity within the lumen of the blood vessel. You don't have a sharp appearance over here. This is a more severe case, and this to show how it looks on source images. Another area where this sort of artifact happens is the cavernous ICA. Because of pneumatization of the sphenoid sinus and the anticlinal process, you can have signal drops. Again, you can see that it's not a sharp area of signal drop. It is an ill-defined area of signal drop in this particular location. In contrast, this is another example of susceptibility artifacts. The sphenoid sinus is very close to the anterocerebral artery over here, and this causes a signal drop at the origin of the anterocerebral artery. And this, sometimes if you're not careful, can be mistaken for artifactual stenosis. In contrast to this artifactual stenosis, true narrowing is quite sharp. You can see the right internal carotid artery. This is the left internal carotid artery in the same location, the Petrus ICA junction. We have a sharply marginated band of signal drop. On source images of the MR angiography, if you do a multiplayer reconstruction, not only you see narrowing over here, you see this plaque over here, extending all the way up to here and increasing in the extent of narrowing over here. And then we have not done a vessel wall imaging in this patient, but then the flare sequence itself shows the atherosclerotic changes in the vessel at this particular location. So going back to your source images on MR angiography, looking at 3D flare sequence, and then if you are able to do it, doing a vessel wall imaging can help you clarify these situations. Another example, in the cavernous segment of the internal carotid artery, sharply marginated narrowing in the cavernous segment of the ICA with a plaque documented on MR angiography. You see the sharp boundaries over here. On the source images, you can make it out. This is a typical feature of atherosclerotic plaques. Another pitfall of MR angiography is that it overestimates stenosis. Both the degree of stenosis as well as the extent of stenosis is overestimated in MR angiography. This is a patient with MCA bifurcation, MCA territory infarcts, and there was a true stenosis, but then it looks as if like there's a pre-occlusive stenosis on the coronal as well as the axial images. In reality, there's maybe a 50% stenosis of the middle cerebral artery because of the flow phenomena and slow flow in this particular location and saturation of the blood flow here, something called eddy currents. You have signal loss in this particular area, and the stenosis looks much more prominent than what it really is. So another example of that, it looks as if there's no flow in the basilar artery. These are the internal carotid arteries. Virtually no flow in the basilar arteries documented. There's some flow from the posterior communicating arteries into the terminal basilar artery. This is a lateral view of the same thing. No flow in the basilar artery over here. The posterior cerebral arteries are being filled from the posterior communicating arteries. But then CT angiogram shows that the right vertebral artery is normal, left vertebral artery is there. It's a stenotic lesion over here. And there's a critical stenosis in the basilar artery over here. Sluggish flow in this vertebral arteries and the proximal segment of the basilar artery created, he also had a stenotic lesion in the vertebral artery proximal origin over here. This plus this sluggish flow, no flow in the base on MR angiography. So one thing to remember is MR angiography, when it comes to documenting the stenosis, it's a good screening modality. But if you want to take your treatment decisions based on MR angiography, you are more likely to make mistakes. Both the degree of stenosis and the extent of stenosis is overestimated in MR angiography. CT angiography is the modality of choice. Of course, DSA is the gold standard. It's not that CT angiography does not have problems. CT angiography suffers from the same streak artifacts that CT has. We know that streak artifacts happen when there are two dense areas of the bone, and when the bone beam passes through these dense areas, you have a band of hypodensity between the two. When you inject contrast into the subclavian vein, the density of the contrast in the subclavian vein throws artifacts, and origins of the major arteries are not very well seen in this situation, in this particular location, when you have dense contrast over here. Also, areas near the skull base, you have dense bone, the Petrus bone. Sometimes we have artifacts from the skull base that interfere with imaging of the arteries that are passing through the skull base on CT angiography. Also, if you're looking at volume rendering imaging like this, you have calcifications as well as the contrast in the artery, both showing up as the same appearance over here. It looks as if there's a bubbled appearance on the top of the internal carotid artery. In reality, these bubbles are actually the plaques, the calcified plaques. The true appearance is seen on these multiplanar reconstructions. One of the most important confusions that we always have is venous sinus thrombosis. Sinus thrombosis, no sinus thrombosis. We are all aware that the classic locations of having lesions in the periphery near the sagital sinus or near the transverse sinus or in the deep venous territory, we should suspect about CSVT, and we should go for an MR venogram. But also we should remember that there are some atypical areas where we should go beyond the conventional areas, and we should ask for MR venography and suspect CSVT. This is a typical vein of Lavi territory. This comes between the sylvian veins and between the transverse sinus venous drainage. This is a typical superficial middle cerebral venous territory. There's a good paper from Nizam's that has documented this, a series. You have thrombosis of the superficial middle cerebral vein that drains the perisylvian area. You have venous infarct in this particular location. And very uncommonly, you have posterior fossa venous infarcts with sinus thrombosis. So this atypical imaging patterns also you have to keep in mind and suspect cerebral venous sinus thrombosis. We should remember the normal appearance of veins. These are slightly hyperdense on plain CT. They show intense enhancement post-contrast study. They show up as flow voids on T2-weighted images. They show up an enhancement on post-contrast study, and in MR venogram, you should have this nice depiction of the veins. And thrombus typically is hyperdense on plain CT. We have an empty delta on contrast enhanced CT. You have blooming on GRE or SWI sequence. And if you do a contrast enhanced T1-weighted images, it should show up as a filling defect. And on MR venogram, you should have an absence of flow in these sinuses. This is an ideal world scenario. In reality, we have a lot of mimics. On plain CT, you can have a mimic of hyperdense CT, hyperdense sinus when you have a hypodense brain parenchyma. Infants have hypodense brain parenchyma because of unmyelinated brain. And in contrast to this, the sinuses can appear hyperdense. In adults, when you have diffuse cerebral edema, the sinuses can appear hyperdense. In children or adults where you have increased hematocrit, even there the sinus can appear hyperdense, and all these appearances can give a hyperdense MCS, hyperdense sinus, the delta sign, and that can give you an appearance of a suspicion of a cerebral venous sinus thrombosis. If you have subdural hematomas on either side of the sagittal sinus, it can give an appearance of an empty delta sign. In contrast, you can have CSVT as documented in this case where the transverse and sigmoid sinus are thrombosed with a normal sinus on CT. If the patient has got anemia, virtually all blood vessels the density is less. The internal carotid arteries are not very dense. The sinuses are not very dense. So you can have an occluded sinus even without having a dense, dense sinus that is a delta sign. Also, on contrast enhanced CT, you may not have an empty delta sign. This is a contrast enhanced CT. If you look at it, the anterior sagittal sinus, the posterior sagittal sinus, both seem to be enhancing well. If you look back at the plain CT, the anterior sagittal sinus is dense, but the posterior sagittal sinus is very, very dense. In reality, there is a patient with a sagittal sinus thrombosis where the posterior sagittal sinus is thrombosed. And this hyperdensity of the sagittal sinus over here is appearing as if there is enhancement on post-contrast study. It's very difficult to differentiate these two on the film. If you look at it on the console, if you go for a wider window over here, you can depict an empty delta sign in these cases. So cases like a hyperdense clot, and when you have a subacute clot with partial recanalization, it can enhance very, very well, and you can miss a diagnosis of CSVT in these two situations. On MRI, the classic sign of an occluded sinus is loss of flow void. We all know that. And flow voids are better seen on T2-weighted images. You should remember that. T2-weighted images that are perpendicular to the blood vessel of interest is the best location to look for, best sequence to look out for a flow void. For example, if you're looking at the posterior sagittal sinus, the posterior sagittal sinus is actually perpendicular to, the axial slice is perpendicular to this segment of the sinus. And this is the best sequence to look for. The mid-third of the sagittal sinus is best seen on coronal images. The transverse sinuses are best seen on sagittal T2-weighted images. And T1-weighted images, don't look at the T1-weighted images because even normally, this is a normal individual. You have normal flow void on T2 and you have something hyperdense in the sinus. There's something called entry slice phenomenon that can be seen in most individuals. This is a normal finding. So don't mistake this for CSVT. Always look at T2-weighted images when you're diagnosing CSVT. If you think that like post-contrast CT, on post-contrast MR also, you'll have filling defects in the sinuses. Yes, you're partly true. This is a sagittal sinus thrombosis. You have filling defects inside the sagittal sinus sagittal sinus on post-contrast study. But you also have a flow void in the straight sinus. This is the MR venogram of the same patient showing a normal flow in the sinus. You have a flow void in this particular location. Flow voids can happen on post-contrast T1-weighted images and can mimic a filling defect inside the sinus, giving a misdiagnosis of a CSVT inside the deep venous system also. Also, not all patients will have loss of flow voids. We should remember that thrombus is hypointense on T2-weighted images during the subacute phase. Or if you just look at the T2-weighted images for looking at the flow void, this looks very much like a flow void. It's only that the sinus appears a bit bulky. It looks large. it looks enlarged, as in it looks convex in its outline in the zoom picture over here. So when you have a clinical suspicion of a CSVT and you have a sinus that looks as if it is patent, have a closer look. If it is bulging, then always suspect CSVT, and then you should go for an MR venogram to confirm. Also, you can have slow flow appearing like this, where you have a hypointense center and a peripheral laminated appearance with a peripheral zone of T2 hyperintensity. Hypoplastic sinuses are small. If you look at T2-weighted sequences, T2-weighted sagittal image, you can see that the sinus itself is quite small. That helps you in differentiating between a slow flow and thrombosis and thrombosis and hypoplastic sinus. So summarizing, when you have a hypoplastic transverse sigmoid sinus appearing, whether it's thrombosis or hypoplastic, you need to look at sagittal T2-weighted images because this is a plane that is perpendicular to this particular segment of the sinus. A hypoplastic sinus would appear very, very small. A hypoplastic sinus with slow flow would show some amount of flow void inside with a laminated sort of hyperintensity in the periphery. Acute thrombus will appear hypointense. It will appear as if the sinus is bulging, and subacute thrombus will be seen as an absence of flow void. When you have doubt, what you need to do is, without giving contrast also, you can go for a time-of-flight MR venogram in your sagittal plane. If you ask your radiologist, he'll do this for you. You should do this perpendicular to the plane, to the sinus in question. Here we are doubtful about the sagittal transverse sinus. If you do a sagittal MR venogram time-of-flight sequence, you can pick up the flow in this particular segment very, very well. So hypoplastic sinus, this time-of-flight sequence without giving contrast itself shows you nicely that the sinus is patent. And also you can give contrast. That's a sure short way of documenting it. Hypoplastic sinus. On giving contrast, you can see that the sinus enhances very well. And if you're able to review the images after giving contrast, you can pick up the thrombus inside the lumen of the occluded sinus also. Sometimes when you have partial recanalization of the sinus, you can have apparent normal flow in the sinus. You can see that there is a chronic CSVT case with partial recanalization over here and collaterals over here and partial recanalization over here. It looks as if the sinus is recanalized completely, but in reality, this is status. Always look at the sinuses on the T1 and T2 weighted images also, despite what you find on MR venogram. Subacute CSVT sometimes can appear hyperintense on T1 weighted images, and in this stage it can appear hyperintense on the MR venogram also. And you can miss a diagnosis of CSVT on MR venogram if you're not careful in this particular stage. Summarizing, in CSVT, we need to look at all sequences. You need to look at MR venogram. If required, you need to go for contrast study. You need to use techniques such as time-of-flight MR venogram and look at the conventional sequence also in order to come to a correct diagnosis. Subarachnoid hemorrhage, important diagnosis to make. CT, it is hyperdense. MR, FLAIR and SWI are the two sequences to look out for. You can have artifactual appearance of subarachnoid hemorrhage when you have CSF hypotension, and in case of cerebral edema where the leptomeningeal blood vessels appear hyperdense. MR in subarachnoid hemorrhage is seen as hyperintense signal on FLAIR sequence. It may not appear as hypointense signal on SWI. We are tuned to seeing bleeds as hypointense on SWI, but remember that subarachnoid hemorrhage, because of high oxygen tension during the acute phase, may not be seen as hypointense signal on SWI sequence. This is a patient with subarachnoid hemorrhage. You can see the cisternal bleed, the suprasellar cistern bleed, interventricular bleed, and virtually nothing on SWI. So don't go for only SWI. The FLAIR is a more sensitive sequence during the acute phase. But FLAIR also has problems. You have other pathologies that have hyperintensities in the subarachnoid spaces, meningitis, leptomeningeal metastasis. When you have high protein content because of either propofol or leptomeningeal metastasis, or when you have when the patient is intubated and your high oxygen tension is being given, even there you can have hyperintensities. And certainly patients, you can have flow artifacts on FLAIR. If you're not careful, you can misdiagnose these things as subarachnoid hemorrhage. Whether it's bleed versus whether it's aneurysmal versus non-aneurysmal, the location of the bleed is important. We know about the patterns of bleed, a typical ACOM bleed, typical PCOM bleed, Sylvian fissure bleed, MC aneurysm, small MCA, isolated Sylvian fissure bleeds, basilar top aneurysm with third ventricular bleed, and a CP angle cistern bleed with a pica aneurysm. Convexity bleeds look beyond aneurysms. There's a flare hyperintensities in the sulcal spaces. This is because of cerebral venous sinus thrombosis. There's a cortical venous thrombosis. We can see the large cortical vein with peripheral enhancement and post-contrast study. There's a cortical venous thrombosis. Apart from this, we also have to look at things like RCVS or pathologies like reversible cerebral leukoencephalopathy and so on. Evaluation of aneurysms, DSA is good. CT angiogram is also very good currently. The advantage of CT angiogram is it is non-invasive. It shows the surgeons a good perspective of what anatomy is with regards to the bony landmarks and so on. But then we should remember that DSA always scores when it comes to documentation of perforators and documentation of cross-flow, which are important in treating certain aneurysms. Using MR angiography for diagnosis of aneurysms, for screening of aneurysms, it is quite good. But in a patient with a subarachnoid hemorrhage, if you are trying to use MR angiography, you are likely to make mistakes. These are 3 patients which look like PCOM aneurysms. But if you notice, all 3, they look convincing like PCOM aneurysms. But in reality, case 1 was a posticommunicating infundibulum. You can see the posticommunicating artery originating from the top of the infundibulum. Case number 2 was fat in the anteroclinoid process, posticlinoid process, close to the internal carotid artery. When the technician removed this fat, he forgot to remove this area, and this gave an appearance of a posticommunicating aneurysm. This is a thrombosed posticommunicating aneurysm. Because thrombosis is also hyperintense on T1, it can appear as hyperintense on MR angiography, and it can be seen as a patent aneurysm, flow in an aneurysm. When you have subarachnoid hemorrhage, the bleed in the subarachnoid spaces will appear hyperintense on T1, and that can interfere with the picking up of this aneurysm, this small tiny aneurysm that is so well seen on DSA. It's very difficult to pick it up on MR angiogram. What about negative angiogram? Whatever technique you use, you can have a negative angiogram. Negative angiogram can be because of non-aneurysm perimesencephalic hemorrhage. If your imaging study shows that the bleed is located only in the suprasellar cistern and the perimesencephalic area, not significantly going into the ciliary fissures or without a big clot in the suprasellar cistern, as in this case, you can think in terms of a non-aneurysmal perimesencephalic hemorrhage. These are benign entities, whereas aneurysmal bleed like this requires more diligent efforts to identify the aneurysm. More commonly, if your study is inadequate, if you don't recognize the pitfalls of the modality, if there are small aneurysms or blister aneurysms, sometimes dissections, or sometimes you do an evaluation of the brain and forget about the spine, you can still have subarachnoid hemorrhage and have a normal study. Regarding which aneurysm ruptured, which to treat, an aneurysm that has irregular wall or with a pseudosac, localization of the bleed, these are the 2 most important indicators of which aneurysm is ruptured. Presence of focal vasospasm is also indicative, but in the absence of these signs, the larger aneurysm, if it is an ACOM aneurysm, the ACOM aneurysm, and presence of wall enhancement, these are the ones that can give you an indicator that this is aneurysm that is ruptured. Post-operative imaging, we have 2 imaging modalities for evaluation of the arteries after either surgery or coiling. Post-operative procedure clipping, CT angiogram is a better modality. CT angiogram shows you good resolution of the arteries without much of artifacts after clipping, whereas MRI shows a big artifact and you have no visualization of the arteries over here. When it comes to coiling, the coil mass gives you large artifacts on CT, but MR angiogram shows you the blood vessels very well. This is a bilateral MCA bifurcation aneurysm. You can see that the coiled aneurysm is seen very well without any neck or anything. The right side aneurysm is still well seen. Virtually no artifacts you can see on MR angiography with coiled aneurysms. All coils are MR compatible. You can safely go for MR angiography in coiled aneurysms. Can I take on the 5 minutes, sir? I think I'm just about time.
Yeah, you can go ahead.
Yeah. Thank you, sir. Last scenario is a long segment cord lesion. Now, this is quite important because treatment options vary. Before going to evaluation of a long segment cord lesion, we need to look at whether it's really something to worry about or not. We know that artifacts can be produced in MRI. These are so-called truncation artifacts or Gibbs artifacts. These are band-like hyperintensities that are seen within the cervical cord. These are hyperintense. These parallel the cord along its ventral aspect, exactly where the spinal, the central canal is located. But easy way of identifying whether it's there or not is to look at the axial images. On axial, it is not there. So this is a truncation artifact. This is typically seen in the sagittal images on T2 weighted images. This is a prominent central canal. Lesions that are less than 2 millimeters in diameter are usually benign lesions. They don't qualify as syringomyelia, though the terminology varies from center to center. But in general, a lesion that is a short segment lesion in the absence of clinical history and lesion that is less than 2 millimeters in diameter and on imaging does not have any other abnormalities such as a tethered cord or a Chiari malformation or other abnormalities, we can ignore these lesions. And if the patient is symptomatic, we can go for a follow-up study. That's what literature says, though it's divided, opinions are divided in this. When you have a long segment cord lesion that looks pathological, important thing is to identify surgical cases from medical cases. Surgical cases are syringes and cord tumors. Syringes are very well defined. They are hyperintense on T2 weighted images with the signal most often equal to that of CSF on all sequences because the content is more like CSF. The extent is variable. On T1 and T2 weighted images also, they're sharply marginated. Most often you don't have any sort of mural nodules or anything in the center. And you don't have enhancement on post-contrast study. And in the same study, your radiologist can do an extended study to look for the cause, such as a Chiari malformation and so on. Whereas tumors, long segment T2 hyperintense lesions that are heterogeneous, when you have cystic components as well as solid components that are sharply marginated, where the signal intensity is not, in this case, it is actually equal to that of CSF, but most often because of the proteinaceous content, you have some heterogeneity, the signal will not parallel that of CSF. When you have good amount of enhancement on post-contrast study and cord expansion that is focal, when you have a focal lesion that is a short segment and expansion of the cord that is very, very focal, you start thinking in terms of a tumor. Among associations of the syrinx, always extend your study when you have a suspicion of a syrinx and look for other lesions such as tethered cord, a myelomeningocele, or a diastomatomyelia. Sometimes it's very difficult to pick up dorsal dermal sinuses. Doing a MR of this craniovertebral junction to look for Chiari malformation and extending the study to do a CSF flow study to document the CSF flow at that location is very, very important in patients with syringomyelia. Whereas tumors versus non-neoplastic lesions, most often it's very difficult to identify this in a single MR study. Most often the cord neoplasia are single lesions, non-neoplastic lesions can be multiple. Cord lesions in tumors are most often expansile, whereas non-neoplastic lesions, demyelinating lesions can be expansile and other lesions can be non-expansile. The signal intensity is varied in tumors, whereas non-neoplastic lesions are homogeneously hyperintense most often. Enhancement is most often seen in cord tumors, whereas it's very variable in non-neoplastic lesions. Tumor-associated cysts can be there in neoplasia. Non-neoplastic lesions can have syringes. Hemorrhages can be present. If they are present, cord neoplasm is a higher possibility, apart from blood vessel abnormalities in the non-neoplastic lesions. Whereas most non-neoplastic lesions don't have hemorrhages. The rest of the neuroaxis is not involved most often in cord tumors. And only exception being ependymomas that can spread to other locations or cord metastasis, multifocal involvement that can be involved. Otherwise, when you have multifocal involvement, most often it is a non-neoplastic pathology. Advanced imaging modalities have some role. And on follow-up, cord neoplasia are either static or they show growth. And non-neoplastic lesions most often show resolution or they remain static. You should remember that I've said most often many times, and that's indicative of the sort of uncertainty that we all face in evaluating these cord lesions. Going to neoplasia, characteristic appearances, ependymomas are typically central cord lesions. The lesion is inside the center of the cord. We have cord parenchyma that is compressed on either side. On axial T2 images, you can see the thin rim of normal cord all around. Post-contrast study, the tumor shows enhancement. The peripheral cord does not show enhancement. And because they're originating from the central canal region, you have sort of central location of the lesion there. In contrast, in ependymomas, other features that we commonly see are hemorrhages, and tumor-associated cysts are very common with ependymomas. In contrast, astrocytomas are ill-defined lesions. They're infiltrative lesions. They are long segment. They extend beyond. They're not as sharply marginated as these. Tumor-associated cyst hemorrhages are very, very uncommon. Enhancement can be mild. And you really can't differentiate which is the normal cord and which is the tumor on the axial images. DTI is useful in certain cases where we can document the displacement of the tracts, expansion of the cord, the movement of the displacement of the tracts and disruption of the tracts in case of ependema, for example, in this case. And with the cord astrocytoma, there is not much of displacement of the tracts as much as infiltration. We can most often differentiate between the lesions. Spectroscopy is not useful for cord lesions. Beyond neoplastic lesions, when we have lesions, long segment cord lesions, we look at focal lesions versus long segment diffuse lesions. Focal lesions, we always look at cord cavernomas, cord vascular malformations, and cord contusions when we have hemorrhages inside the cord. Hemorrhagic lesions in the cord cavernomas are very, very focal lesions, just like the brain lesions. They're popcorn-like appearance, showing blooming on SWI or grain taco sequence. And obviously, they have cord edema. They show enhancement, moderate enhancement, post-contrast study. Cord AVMs are picked up as hematoma in the cord, hematomylia. Blood vessels inside the cord are most often not seen. It requires a digital subtraction angiography to document these blood vessels inside the cord in true glomus lesions. Cord contusions obviously have other telltale signs, such as the vertebral compression fractures or the bony impingement on the spinal cord we can see in traumatic lesions. Coming to lesions with enhanced and with cord edema, long segment cord edema with a focal lesion, we always look at possibility of infective pathologies such as cord neurocirrhosis. Like in the brain, we have NCC, the Fiesta is the best sequence, BFF is the best sequence to look at it. If you're able to document the mural nodule, that is the best way. Cord tuberculomas show as ring enhancing lesions in the cord also. And of course, differentiation from tumors may be difficult or metastasis may be difficult. When you have lesions that are non-expansile, we have to pay attention to which particular tract or which part of the cord they are involving. Lesions involving the gray matter, typically the ventral gray matter, are usually ischemic or infective in etiology. Infective etiology as in viral myelitis, as in this case, or cord ischemia as in this case. Diffusion imaging can help diagnose acute case of viral myelitis or cord infarcts. Involvement of the posterior columns, typically we all know about the subacute combined degeneration. When you have long segment cord lesions that look demyelinating, again, differentiation between the NMO versus idiopathic transverse myelitis versus ADM versus anti-MOG disease based on the cord imaging picture is very, very difficult. The neuroimaging, rest of the neuroimaging will tell you, depending on the involvement of the optic nerves, depending on the involvement of the brain parenchyma and the characteristic imaging features, there we can come to a diagnosis. Also, though uncommon, we should remember that cord abscesses can look exactly like long segment demyelinating lesions or sometimes cord tumors. They can be heterogeneously hyperintense on T2 weighted images, isointense on T1, and they can show mild to moderate enhancement in post-contrast study. Diffusion weighted imaging, they can show restricted diffusion. I've seen only one case of proven cord abscess, but I couldn't get that image. Sorry, I had to get this from literature. Diffusion imaging is one thing that can help you differentiate between demyelinating lesions and cord infections. Other lesions with leptomeningeal enhancement, always think in terms of arachnoiditis. If you look at it from T2 weighted images point of view, it looks exactly like a demyelinating lesion. Sarcoidosis also looks like a long segment T2 hyperintensity in the cord. But then if you look at it, most of these lesions, either arachnoiditis and sarcoidosis, have a leptomeningeal enhancement on the surface of the cord rather than the typical demyelinating appearance. Last one, spinal neurology fistula. We all know about long segment hyperintensities in the cord and enhancing blood vessels on the surface of the cord. Blood vessels can be picked up on the Fiesta sequence, and that can give us a diagnosis of spinal neurology fistula. In summary, I should say that in this series, I've shown a few cases where there is common puzzles that are there for both radiologists as well as the clinicians. And as you can see, there's no protocol, imaging protocol that can give you all diagnosis with great degree of accuracy. There's no one-size-fits-all protocol for any part of neuroimaging. We need to add imaging sequences, or we need to modify the existing imaging protocols in order to get that information that is required. And attention to small clues always helps. And you should remember that your radiologist is a very important part of your team member. And we are basically nice people. If you ask nicely, we'll do a lot of things for you. And obviously, it helps quite a bit to have a radiologist on your side to do the things to make sure that you get your diagnosis for your patients. And I should also thank my teachers, Professor Mohandas and Dr.K. Krishna Reddy, from whom I've learned quite a bit. And obviously my CNC team, and we discuss, we argue, and most of the things that are present over here are the cases that we've collected over time. These are the doubts that we all have, and how we approach these lesions. And I thank you all for giving a patient listening. Thank you very much.
Thank you, Ravan. Really, it was a wonderful lecture. In fact, in my first year of residency, my boss told me that NMR means no more radiologists. So, but he really made the neuroradiology very simple and very lucid, and I think it was very informative to postgraduates as well as consultants. And I have a few doubts, Dr. Verma, regarding the ring-enhancing lesions. What makes the ring cysticercus ring so thin? Can there be thick rings in cysticercus?
Most often, it's always relative. I should say, as compared to neoplastic and tubercular ring-enhancing lesions versus cysticercus ring-enhancing lesions, NCC has thinner rings. Maybe they're a couple of millimeters in thickness, and it is very, very uniform in outline. Both the outer margin as well as the margin is quite uniform.
Does it depend on the host immunity or something like that?
I'm not really aware of the immunity component, but you do have certain cysticercus cysts with some amount of enhancement beyond the ring. The typical corona sign that's been described by one of my colleague radiologists. It is seen typically in cysticercosis. It's a ill-defined zone of enhancement that is surrounding this cysticercal cyst actually. It's a classic appearance. I think I should have included this. Probably I'll not put this into the presentation in the first one.
And second thing was the shape of the spinal cord tumor. The ependymoma, classically they describe it as a carrot shape. Is this something, a clue you advocate, or you don't believe in that? The ependymoma is typically carrot shaped with some apical cyst.
Yeah. So rather than giving labels, I would say that we should understand the pathophysiology of how the tumor is developing. Ependymomas typically start from the center of the cord, so thereby they displace the cord parenchyma outwards. So the enhancing lesion is a very well-defined long lesion like this that maybe has been described as a carrot. And definitely when you have the lesion in continuity to the central canal, you have distinction of the central canal beyond it. So you have serings that is above and below the tumor, and you have tumor-associated cysts on the apex of the lesion. Those are typical findings that you see in ependymomas. Whereas astrocytomas being infiltrative tumors, the cord itself is infiltrated all through, and this sort of appearance of a well-defined carrot is not seen in astrocytomas.
What about the location-wise astrocytoma, ependymoma, and hemangioplasty? Is something like a clue to the diagnosis?
Again, in interest of time, I've not included this. Maybe 3 years back, APNSA had presented on non-compressive myelopathy. Ependymomas are typically central. Astrocytomas are diffuse. Vertical extent of the lesion, most often ependymomas as well as astrocytomas is seen in the cervical cord, whereas you rarely get astrocytomas in the lower dorsal areas. Most often lesions that are located in the conus chorda region are all myxopapillary ependymomas. Hemangioblastomas are typically seen along the dorsal aspect of the cord. They are subpial lesions, and most often small lesions, you can see that they're abutting the dorsal surface of the cord. And the nodule, the enhancing nodule is located along the posterior surface of the cord. And if your imaging is quite good, you can see a blood vessel reaching that area also. These are quite typical features that you can see in hemangioblastomas.
Yeah, thank you, Ravi. And it's over to Dr. L.T. Kishore.
Ravi, excellent lecture. And we don't expect anything less than this from you. So that was really nice. You mentioned that for every ring enhancing lesion, we should be doing all the sequences, including perfusion. Now, my question is, what do you think is the role of perfusion in differentiating various infective ring lesions? Does it help?
I made a general statement. I should have probably qualified it. I say that we'll be missing out information when you are looking at a ring lesion if you don't do perfusion. It's not that definitely for all cases it is required. It's not the situation. If you have already diffusion weighted image, you have a central area of restricted diffusion. It can be nothing but an abscess. So in that situation, you really don't need to go for perfusion imaging. To be very frank with you, sometimes I don't do contrast also. Leave alone perfusion. Now that we have ASL, it's very easy to do without giving contrast. Also, you can do a perfusion just to make sure that something is done to get some more information. But I really don't think in my practice in the recent past, I've seen a case where diffusion picked up the central restricted diffusion and it has turned something else on follow-up. So I would say, yes, infective lesions. In my clinical practice, I don't think perfusion imaging will help.
Right. I'm putting you in a hypothetical situation. Let's say that you had an MRI and MRA also, and you felt that there is some abnormality which needs further evaluation. So in that situation, when would you ask for CT angio and when would you straight away go for DSA?
If I should probably ask for more information regarding, is it with regards to hematoma or an aneurysm or because it will depend based on what we are looking at, sir.
Non-hemorrhagic.
Okay, stenotic lesions, you mean? Yeah. Arterial stenotic lesions.
Yes.
Arterial stenotic lesions as a diagnostic modality, I don't think DSA is required to make a diagnosis because CT angiography on a 64-slice CT is good enough to pick up all lesions except the lesions near the skull base. That is one area where CT angiography always creates problems. So when it comes to treatment decisions, I advocate CT angiography. DSA comes when we are looking at looking at the lesions at these particular locations where CT angiography does poorly. And second thing, when I'm looking at collaterals, the presence of collaterals or territories, for example, if my middle cerebral artery has got a stenosis and I've got excellent collaterals on the PCA supplying my cortical surface of the brain, then probably my treatment decisions will be different from if there is an incomplete collateralization. So to get the information regarding the dynamics of flow, DSA would be a modality of choice. CT angio, one additional advantage over DSA is that it gives information regarding the calcifications. So when you're looking at, for example, angioplasty or stenting of intracranial blood vessels or, for example, the neck vessels, you need to get information regarding the calcifications also, which may not be given by MR angiogram or DSA.
Yes.
CT angiogram is definitely the modality of choice. So if you go for one imaging modality, I would say yes, CT angiogram is the modality of choice.
Right. I think now we'll ask whether anybody else has got any questions. Are there any questions written in the chat box?
No, sir. No. As of now, there are no questions written in any chat box. So chat box is empty.
Okay. Yeah. So it's already 8:15, and it was a really lucid, nice talk, Ravi. And we actually did not realize that it's already 8:15. So over to the moderator, who can probably close the session. Thank you very much.
Thank you,
Ravi. Thank you.
Thank you, Dr. Ravi Verma, and thank you both the chairpersons, Dr. L.P. Kishore and Vijay Sarathi. Sir, thank you for having a very good session. Nearly, I think, 250 delegates have joined to enjoy this session. Today's, after this one, we are going to have the poster presentations will be there. People who wants to stay tuned, they can look into this poster session. And I think tomorrow we have some more interesting sessions, especially senior faculty will be presenting the cases. Your teachers will be presenting the cases.
Grand
teachers. So I think you should definitely should not miss those sessions. And other things are COVID session and especially NPH from the foreign faculty. Thank you all. Again, once again. People who are presenting their posters, they can join with their judges. Thank you, sir.
All right. Thank you.
Thank you, Sudhir.
Hello. Good evening, everybody. This is as a continuation of the poster session. I think people who are there can present their posters. There are still some posters which are pending. Now we have time. So I invite upon Dr. A. Madhuri from Usmania Medical College to present her poster. Madhuri is there? A. Madhuri? Dr. Madhuri? Dr. Madhuri?
Yeah, good evening, sir.
Good evening.
1 second, sir. I'll do it.
You can share your slides first.
Yeah.
Don't open the phone and also laptop same time. We may get resound also.
Is my poster visible to you, sir?
Yes, it is visible. Maybe you can start presentation.
Okay. My poster for today is an interesting case of hemipalismus. Normally, the diabetic steatopathy is an uncommon and life-threatening manifestation of diabetes mellitus. It has tendency to occur in the elderly female and the people of the Asian descent. The patients usually present with hemichoria, hemipalismus, caused by the non-ketotic hyperglycemia. However, the patients could develop the diabetic steatopathy weeks after the hyperglycemic event, even when the blood sugars were well controlled. Herein, we report a case of delayed onset diabetic steatopathy. A 68-year-old female. She's a known diabetic since 10 years on irregular medications with oral hypoglycemic agents, with the past history of admission for the honk 1 month before. And she presented now with the chief complaints of involuntary movements of the right upper limb and lower limb since the 4 days, with no history of any movement disorders in the past and any family members. Her neurological examination is notable with the hemipalisms on right half of the body with the normal sensory, cranial nerves, bladder, bowel, and cerebellum with a normal sensorium. The relative investigations was done, which revealed the HbA1c of 13% and RBS of 220 milligrams per deciliter. And the MRI brain showed the T1 hyperintensities in the left putamen with the normal diffusion weighted images. And the delayed onset diabetic steatopathy was diagnosed given the history of hyperglycemic event 1 month ago. The patient is treated with the tetrabenzene, 25 mg TID, and the strict hypoglycemic control. And the patient is now improving, sir. The patients with the conclusion is the patients with the prolonged uncontrolled hyperglycemia and striatal hyperintensity on T1 MRI may present as a reversible focal neurological deficit. Early and aggressive sugar control is an important. And this is the MRI of the patients, which was T1 hyper. Actually, this is not so clear, sir. But there is a T1 hyperintensity are noted in the putamen, left putamen. Hello.
Hello.
Sir.
Yeah, Madhuri. Yes, sir. No, I've gone through the case. Actually, why are you telling that it is a long-standing delayed steatopathy? Actually, the patient's complaints are only for the past 4 days only, no?
Yeah, yes, sir.
Then how can you tell it is a delayed steatopathy?
Actually, we have seen many number of cases in the honk or decay. They may present with an acute onset of hemipalismus or hemichoria. But this patient, they have presented with the past history of decay that was admitted 1 month back. Now she has presented, sir, after a 1 month of discharge, she now presented with the hemipalismus, which is of about 4 weeks after the discharge, she has developed this hemipalismus.
No, 4 weeks later she has presented, but
yes,
it is an acute presentation, no?
Acute presentation, not that correlating with this RBS. The RBS was at that time, it was only 220, not the HbA1c. At that time, it was not in acute stress.
Okay, and you had what was the fasting blood sugar and serial blood sugars in the hospital?
Serial blood sugars were in the range of 220 and the fasting was in the range of 170 like that, sir. And the postprandials are in the 200 to 250 range and the fastings were in the range of 150 to 180, sir.
And second question I want to ask you is, what is the mechanism why there will be T1 hyperintensity in an uncontrolled hyperglycemia?
Actually, the exact mechanism of this is not clear, sir. I have gone through many journals. The proposed mechanism is that there is a vasculopathy-induced changes in this putamen or whatever the basal ganglia is involved. There is a delayed onset of this vasculopathy. Vasculopathy-induced ischemic-like events, not entirely like an ischemia. It's an ischemic-like events with the astrocyte gliosis. But the exact mechanism behind it is not clear.
The most common mechanism that is well told is actually astrocytic gliosis. Astrocytic gliosis is actually the most commonly put forward mechanism. The other mechanism, as you told, is yes. But still, I mean, you had any case reports before, like delayed onset diabetic steatopathy?
Yes. There were very many cases that were published in the BMG. There were about three to four cases, and in elsewhere also they were published. They have showed that the most patients who have presented with the delayed striopathy, they are in the range of 1 to 4 weeks after they have discharged and they were treated for the honk. And after they have discharged, they were presented in the 1 to 4 weeks. That is the most common duration. And some patients even they presented 3 months after the discharge.
Can I ask a question?
Yes, sir.
Yes, sir.
If it is a gliosis, how could it be reversible? Generally, gliosis is a permanent, pathology. You said the clinical got reversed with the
gliosis.
But if it is a gliosis, the pathology, gliosis indicates that dead neurons, right?
Yeah, it is under study, sir. Exactly, the pathogenesis is not clear, but most of the patients who they have been strictly controlled sugars with and with these tetrabenzene, they were when they were followed up, the MRIs after 6 months or 1 year, they were absolutely became normal, sir. Exactly, the pathogenesis is not clear, but the MRI was become normal after that, after 6 months to 1 year follow up, and the patients also absolutely normal.
Okay, fine.
Okay. Thank you, Madhuri.
Okay.
Now, may I call upon M. Sai Shravanti from Uspania Medical College. Dr. M. Sai Shravanti. I can see here in the panel. Are you able to hear me? You can slide. Hello? Shravanti, your voice we are not able to hear.
So can you hear me, sir?
Yeah. Now we are able to hear you. Yeah. Welcome. You can present your poster.
Yes, sir. Good evening, sir. I'll be presenting a case of tumor syrinx. This was a 40-year-old gentleman who was an auto driver by occupation. He presented initially with weakness of both upper limbs since 15 years, which was in the form of distal weakness, like difficulty in holding his toothbrush, difficulty in applying paste, difficulty in unbuttoning his shirt, difficulty in mixing food, and difficulty in opening bottle caps. This was present for 5 years, and later it was followed by thinning of both upper limbs since 10 years. And he also had, after another 5 years, he noticed weakness in both lower limbs. This was in the form of difficulty in standing from squatting position and difficulty in climbing stairs. And he also had associated stiffness of both lower limbs. And later, since 5 years, the patient also had decreased perception of pain in both upper and lower limbs. And there were several episodes, around 3 to 4 times, where he sustained burns in his hands, and which was not associated with any pain. And later, since 2 years, the patient also had distal weakness in the form of difficulty in inserting his feet into his slippers. And also he had slippage of slippers without awareness. And also he had a history of twitching in bilateral deltoid muscles since 2 years. And since 1 year, he had the history of dragging of his foot. And since 1 month, the weakness gradually progressed, and now he's unable to walk without support, and he looks down while walking. On examination, in cranial nerves, the patient had Horner syndrome in his right eye, and on motor system examination, there was wasting of thenar and hypothenar eminences in both hands, and the tone was normal in the upper limbs, and it was spastic increased tone, grade 1 spasticity in both limbs, both lower limbs. And on examination of the power, in upper limbs, proximal power was normal. At the wrist, flexion and extension was 3/5, and there was weakness of all small muscles of hand on both sides. In the lower limbs, there was weakness both proximally and distally, and it was more in the right lower limb than in the left lower limb. It was around 2/5 in the right lower limb and 4/5 in left lower limb. And on examination of the reflexes, superficial reflexes, abdominal reflexes were absent all on both sides. The plantar reflex there was extensor response on both sides, and the deep tendon reflexes all were exaggerated. And on examination of the sensations, pain and temperature was decreased below C4 on both sides, whereas joint position sense was decreased only up to the ankle on both sides, and vibration was decreased below C6. So, on MRI, on imaging, MRI spine was done. The MRI showed an intramedullary cystic lesion, which can be seen here from C4 to D1 levels. And there is an associated syrinx above the tumor, which is seen as a hyperintense lesion in the cord at the levels of C2 and C3. And also cystic component can be seen within the tumor. So this is quite a rare case of tumor associated with syrinx. And this tumor is most probably an ependymoma, which can be associated with syringes. And they usually have a good prognosis after section of the tumor. So, and syringes are associated. The conclusion is syringes are associated with intramedullary tumors often enough that if there are any cystic processes in the spinal cord, and intramedullary tumors should be taken into consideration until proven otherwise. So this is most probably an ependymoma associated with syrinx.
How did you manage the patient? What did you do?
Sir, the patient was operated, sir.
No, I am.
Actually, sir can comment on this.
Yeah, Dr. Shravanti.
Yes, sir.
No, I'm very much surprised to see that your tone of the patient is normal in the upper limbs with so much of intramedullary lesion. One.
Sir, at the level of the lesion, he probably had it's from C4 to D1. So below that, he has upper motor neuron spasticity. Probably at the level of lesion, he did not develop spasticity.
Second most important thing is the most common tumor which is associated with the syrinx is what? Hemangioblastoma, right? You never mentioned hemangioblastoma in your poster. Second thing is ependymoma is of course after hemangioblastoma. Ependymoma is a tumor which is likely to have present with the syrinx in 20% of cases. 80% of hemangioblastomas do have syrinx. Of course, rarely astrocytomas. Second thing is, where is the contrast in your image?
I don't have the contrast images, but there was heterogeneous enhancement on contrast, sir.
That you should have put it in the poster, right? More than T2, it's a contrast. Single image should have been put in your this one.
Yes.
See, most often the syringes are associated with the hemangioblastomas. First possibility would be hemangioblastoma in this case rather than ependymoma. Okay. Operative finding may be anything else, but clinically, radiologically, your diagnosis should have been the hemangioblastoma. Okay?
Okay.
What is the histopathology? You told patient was operated, no?
Yes, sir. I mean, patient was recently operated, sir. Not sure about the histopathology findings, sir.
Okay, but presenting histopathology would have added more now. Contrast MRI as told and histopathological pictures would have given more weightage for this. It would have become very good post. Okay, thank you.
Yes, thanks.
May I call upon Naveen Kumar yes from Gandhi Medical College. Dr. Naveen, are you there?
Yes, sir. Can you hear me, sir?
Yeah. You can just screen share.
Just a minute, sir. I'm sharing my screen. Is my poster visible, sir?
Yeah. You can go ahead.
Yeah, good evening. Today's my poster presentation topic is multiple cerebral infarcts, a rare presentation of honeybee sting bite. Introduction. Bees are the insect most likely to cause medical problems as they are able to inflict a venomous sting. Although most stings cause only minor problems like local reactions, others may cause serious problems like rhabdomyolysis, intravascular coagulation, cerebral hemorrhage, acute pulmonary edema, acute renal failure, and even death. The case report is a 53-year-old non-epileptic, normotensive, and non-diabetic female presented with history of being stung by a massive attack of honeybees, followed by swelling and itching of face. And she had one episode of GTCS seizures, for which she was taken to a local hospital where she was treated with anti-epileptics and IV fluids in view of hypotension, and steroids and antihistaminics were given. After 10 hours, she presented at our emergency. On examination, patient was conscious, coherent, with stable vitals, with erythematous papules on the face. CNS examination showed Broca's aphasia, UMN right facial palsy, right-sided hemiparesis, right plantar extensor, and no sensory and cerebellar involvement. Lab data showed normal hemogram, renal and liver functions were normal, coagulation profile was normal, ECG, homocysteine, ANA, and lupus anticoagulants and 2D echo were normal. But on carotid Doppler, we found floating thrombus in the right common carotid artery. And MRI showed multiple T2 and flare hyperintense lesions with diffusion restriction in bilateral frontoparieto-occipital lobes and basal ganglia, suggesting acute infarcts. It was due to query embolus and hypoxia-related infarcts. The patient was treated with antiplatelets, anticoagulants, and anti-epileptic medications. And patient showed gradual improvement. And at the time of discharge, she was able to walk with support with mild facial deviation and slurring of speech. These are the diffusion-weighted MRI images showing the frontoparieto and occipital infarcts bilaterally with the diffusion restrictions and T2 hyperintense lesions. And discussion, the mechanisms responsible for stroke following bee sting, which include hypotension because of anaphylaxis, and phospholipases, hyaluronidase, and thromboxanes, histamine and serotonin release, and inflammatory mediators in the bee venom, which cause cerebral vasoconstriction and leading to ischemic stroke. And it may be due to disseminated intravascular coagulation to phospholipids from damaged endothelium and hemolysis that can cause vessel occlusion. So in our patient, the cause for ischemic stroke, maybe the first possibility is due to toxin-mediated thromboembolism, and the second is due to hypotension.
No. What is the mechanism of stroke in this patient? Mechanism. What is the angio? You did carotid Doppler, intracranial MR angio?
Actually, angio was not done, sir, for this patient.
The only carotid Doppler was done.
Only carotid Doppler was done, which showed a floating thrombus in it.
You are telling the floating thrombus on neck vessel Doppler, but it was only on the right side.
Yes, sir.
We cannot explain the infarcts on the left side, no, with this.
Yes, sir.
So what do you think the mechanism? Is it a large artery disease or a cardioembolic disease?
Cardio, all the other investigation like 2D echo and which came out to be a normal, sir. So, and she was also non-diabetic, and there are no comorbidities. As there is an evidence of thrombus in the right Doppler, the mechanism because of, and there is a clear history of bee sting to the patient, and there are articles showing that there is a stroke following the bee sting. So we consider it as a bee sting strokes.
I accept your contention. I accept your point also. But thing is, the most common mechanism reason after a bee sting is actually disseminated intravascular coagulation and the inflammatory mediators what you have shown.
Yes, sir.
All those mediators and other things like we have been seeing these days also COVID and associated strokes.
Yes, sir.
It will cause actually hypercoagulable state, which will cause actually thrombus.
Yes, sir.
So I accept your argument, but thing is, if there is a floating thrombus, there is underlying floating thrombus cannot happen just like that. No? There should be underlying some plaque also. What were the neck vessel Doppler findings actually? There was a plaque, or there was anything disruption or anything like that. Plaque can be visualized on neck vessel Doppler easily.
Yes, sir.
Was there anything like that?
Plaque was not there, sir. They showed only floating thrombus in
Actually,
Doppler.
the association, whatever you are showing is right. But thing is, this would have been a more better case if you would have actually done MR angio properly, and actually the neck vessel Doppler findings and taken the plaque imaging, whatever MRI neck vessel Doppler pictures which were showing the free floating thrombus.
Okay.
Then how do you definitely tell that it is because of bee sting? Actually, we have to review the neck vessel Doppler and also the angio studies. And if that total clot gets lysed and completely resolved, then we will be very, very sure that it is because of the bee sting. And your coagulation parameters are completely normal. It is a little bit surprising.
Okay.
So, what are the coagulation parameters you have done?
Lupus anticoagulants and PTA and APTT were also found to be normal.
Did you do D-dimer?
No, sir. D-dimer was not.
So D-dimer also is very important thing. So D-dimer is so all the patients with COVID-associated strokes and infection-related strokes, D-dimer will be much more elevated. D-dimer will be thousands.
Yes.
So that is a very important parameter, though PT and APTT are normal. So D-dimer is also a part of prothrombotic panel. You could have actually done for more better illustration. And just to this thing, it could have been press also. No, how do you differentiate press from the infarcts?
There is
the imaging. Can you show your imaging?
Yes, sir.
It could have been press also. No.
The
so
frontal.
Yes.
Frontal diffusion restriction, and there is no evidence of any hypertension in this patient. In spite, she presented with hypotension.
No, hypotension, sepsis, there are many causes of press. What I'm asking is radiologically, what are the points you are quoting me, telling that it is not press, it is
basal ganglion, involvement of basal ganglion.
Right, correct. Involvement of the basal ganglion is there. And whatever you are seeing here is the watershed areas, especially posteriorly. Occipital lobes will be invariably involved because posterior circulation is more amenable for the developing sympathetic storm, what we call, is a reason for the press. No?
Yes.
Okay. Okay, thank you. But whenever you come out with these cases, now I would suggest you preserve all the images.
Okay.
Okay, all the images, MR, and if you document everything properly, now you can actually put it across in a very good journals also, and review all the articles which have been published till date. So then you can actually know what are the risk factors which are actually causing all those things in a more better way. If you present like this, if you present with this, at least poster is okay, but many questions will be asked when you publish in a journal.
Okay.
Good.
Okay, thank you, sir.
Next case, You can stop here.
Yeah.
Next, I would like to invite Dr. Y. Anusha from Star Hospital. Y. Anusha, are you there? Dr. Raghavendra, you are presenting from neurosurgery?
Yes, sir.
Yes. After Anusha, I'll invite you. Dr. Anusha?
Hello? Yes, sir. Can you hear me, sir?
Yeah. Very faintly. You can share your screen and talk a little bit louder.
Yes, sir.
Yeah, little bit loud. You can present.
Yes, sir. Good morning, sir. Good evening, sir. This is a COVID-19 case which was presented with neurological manifestations. Secondary to coagulopathy or endothelial dysfunction is a causative factor for stroke. Case report: a 52-year-old male patient, hypertensive and diabetic, who was admitted in COVID-19 ward. After 3 days of admission, he complained of dysphagia and cough on trying to swallow. On examination, patient had loss of pain and sensation on the right side. MRI showed a left medullary infarct, which explained the reason for the dysphagia. In view of the patient being COVID positive and SARS-CoV virus pathological effects on the vascular endothelium, further angiography was done to rule out any dissection, which showed an intracranial dissection with a dissecting flap extending from the left V4 segment of the vertebral artery into the proximal basilar artery, having an intramural hematoma on the vessel wall imaging, and SWI sequences causing a picard artery infarct in the posterior lateral aspect of the medulla. There was no history of connective tissue disorders or any trauma in this patient. Patient was treated with anticoagulation and was managed conservatively. Discussion: arterial dissection is one of the most common causes of stroke in COVID-19 positive patients. The arterial dissection can be one of the pathological reasons which would explain which could be caused by the inflammatory response, causing endothelial dysfunction resulting from cytokine storm or systemic inflammation. Another mechanism could be the direct SARS-CoV virus invasion of the vascular endothelial cells, where spike proteins bind with the ACE2 receptors, which are expressed in the vascular endothelium, which can result in an increased chance of endothelial injury.
Hello?
Sir?
That's all?
Yes, sir.
How did you manage this patient?
We started.
Did he recover?
Yes, sir.
How did you manage this patient?
We started him on anticoagulation, antiplatelets, and managed him conservatively, sir. We did not, since there was no progression of the symptoms, we did not go for any surgical management.
Okay. No. What did you treat what is the severity of the COVID in this patient?
He was moderately severe patient, sir, since he was having comorbid stage 2, sir.
Was he requiring oxygen, and did you treat him on remdesivir?
Yes, sir. We started him on remdesivir, and patient was having requirement of oxygen, almost 6 liters oxygen, sir.
6 liters of oxygen. And what are the other parameters of the patient, like procoagulant profiles and various inflammatory markers? What were the values? Values, were they abnormal? What are the values which were abnormal?
D-dimer was elevated almost 6,000. It was the value was almost 6,000, sir. IL-6 was 52, sir. CRP and ESR were also elevated almost 150 to 200, sir.
So, okay, there are many case reports. There are many series of patients of COVID and associated related stroke. Do you think it is a causative factor or an association as per your title? Do you think COVID has exacerbated, COVID is a cause of this, or COVID and because stroke is very common, do you think it is just a sheer association?
It could be that COVID-19 has exacerbated the occurrence of dissection in these patients, sir.
So you think it is a COVID has caused the stroke?
COVID has exacerbated the occurrence of dissection in these patients due to the various inflammatory responses in the body, sir.
So are you aware of any literature about the COVID strokes from India?
Yes, sir.
I mean, there are many.
Yes,
Can
sir.
you, what is the difference between the COVID associated stroke and the normal stroke? I mean, the other strokes. What is the difference? Clinical presentation and the investigations.
The inflammatory markers are elevated when it comes to COVID stroke patients, sir.
And what is the literature? What does the literature say about the latency between the COVID onset and also the stroke? You have presented a very beautiful case, but thing is COVID-19 is a very important thing now. So COVID related strokes, there are many COVID related strokes and large series and large groups of patients which have presented big series about these patients. Many countries have presented. I just want to tell you a few things. The mean latency between the COVID onset from the stroke is usually between 9 to 11. Whenever the patient has COVID, there will be initially a hyperinflammatory phase followed by a procoagulant phase. During the prothrombotic phase, actually the strokes are much more commoner. And most of the when they have compared the COVID-related strokes with the non-COVID related strokes, they found the risk factors were same. And most of the COVID patients had very severe COVIDs, and the mortality is very high. And COVID-19 has an independent association with the mortality in these patients. So it would have been much better if you have actually shown all the inflammatory markers and the course of the patients and how the inflammatory markers also changed, and whether you have repeated the CT angio later and whether the dissection has completely resolved. It would have given actually much more better understanding of the disease in this patient. Okay?
Yes, sir.
But it is a good case. Thank you.
Yes, thank you, sir.
May I call upon Dr. Vikram Simha Reddy from K. Nampalli? Vikram, sorry. 1 second, Vikram. I will call Dr. Raghavendra. You can present your poster. Dr.
Good evening,
Raghavendra.
sir.
Sir, Vijay sir, this actually he's a neurosurgeon, sir.
I know.
Yeah. You can share your
evening,
slides.
Sir.
You share your slides.
Sharing, sir. 1 second. Is it fine, sir?
Yeah, yes.
Sir, good evening, sir. Respected senior. So today I'm presenting a cervicomedullary compression by intradural extramedullary tumor by neuroentrexis at the craniovertebral junction. This is a case report, sir. A 36 years female presents to our casualty with a history of severe occipital headache, along with the paresthesias of both the upper limbs and the lower limbs. On evaluation of the patient was neurologically intact. No significant any neurological finding were noted. And we went for the investigations. MRI was done. MRI was showing a round cystic transparent lesion extending from the premedullary system up to the C2 level, sir, causing compression of the cord along with the cervicomedullary junction and pushing the cord to the left side. And on contrast evaluation, there was no significant contrast enhancement was noted. So, in view of the severe cord compression, we explained about the importance of surgery. The patient was taken for the surgery by the surgical plan was done. There was a right far lateral approach I did and the cystic excision of the tumor. We can see as a transparent, glistening, jelly-like cyst noted at the cervicomedullary junction. The cyst was anterolateral, intradural, extramedullary transparent cyst with the yellowish white content was the noted. The cyst was severely compressing the cervicomedullary junction and pushed the cord and its cervicobulbia to the left side of the cord. And the importance of this, we could able to separate the cord cyst from the cord contents easily, and it was well peeled off. In complete total excision was done. The later the histopathological evaluation was carried out. The histopathological evaluation also showed that it was a ciliated columnar epithelium with some mucous globules we can make out in the histopathological slide. And for the confirmation of that, it is the epithelial origin. We have done an IHC, which is suggestive of EMA positive, which we can see on the right side of our screen. Silvery stains were noted. So coming to the discussion of the part of the neuroenteric cyst, the neuroenteric cysts are the congenital disorder which happens according to the notochordal dysraphisms. It is similar to the meningomyelocele. What we find that this dysraphism is mainly due to the abnormal adherence between the endoderm and ectoderm contents. Why I am presenting this case is, as per the literature available for the PubMed search, I found that craniovertebral junction, intradural extramedullary neuroenteric cysts are very rare, and only 15 cases have been reported in the recent literature search. So the importance of this neuroenteric cyst, the neuroenteric cyst is generally easily peelable from the adjacent cord structures and the neuronal structures, but sometimes it may be densely adherent. The importance is also says that if there is any residual cyst wall left in that, the high chances of recurrence has been noted. Even there is some literature says that there is a malignant potential also has been noted. So in conclusions, we like to say that the neuroenteric cyst, which we thought is we didn't thought it as a differential diagnosis. We thought it is an arachnoid cyst or an epidermoid cyst, which can happen, but it was not comparatively correlating with MRI findings, what we classically find in arachnoid cyst or epidermoid find. In view of this clinical causes and abnormal location, the neuroenteric cyst at the cervicomedullary junction, we just wanted to add one more case to the present literature, and the complete excision of the cyst wall is very important. And if any residual ligament is left, there is no the high chances of recurrence along with the malignant potential has been documented. Thank you very much, sir.
Yeah, Raghavendra, it was very well presented case. What clinches the diagnosis is the estimation of gastrin levels in the cyst content. Was it done in this case?
No, sir. I have not done, sir.
The thing is, did you find any osseous abnormalities in front of the cyst?
No, sir. I gone through the literature. As per the literature, as we know that osseous abnormalities are very common in, as we know that the dorsal spine, but even the literature says that any osseous abnormalities are very, very uncommon in craniovertebral junction, sir. We also didn't find any osseous abnormalities.
Maybe if you get a CT, 3D CT, some amount of cleft or something would be there. Then definitely.
Means to be, we didn't anticipate it also, sir. Means to be honest.
Okay, that's well done. Okay, very nice.
Thank you, Dr. Raghavendra.
Thank you very much, sir. Thank you, sir.
Dr. Vikram?
Yes, sir.
Yeah, you can stop sharing, Dr. Raghavendra. Yes.
Yes, sir. Thank you very much, sir. Thank you, sir.
Dr. Vikram, you can share your screen.
Can you see me? See my presentation, sir?
Yes, we can see.
So, sir, good evening, sir. I am Dr. Vikram from Care Hospitals, Nampally. Today, my poster presentation is a corpus callosal lesion in a COVID-19 patient presenting with an encephalopathy. COVID-19 is primarily a respiratory pathogen, and hence neurological complications are missed during the early stages of the pandemic. However, in subsequent observational studies have a high incidence of neurological complications in COVID-19 infections, around 36%. The term cytotoxic lesions of the corpus callosum has been proposed recently as a more precise description for a phenomena which has previously been known by a variety of terms, including transient lesions of the splenium of corpus callosum, mild encephalitis or encephalopathy with a reversible isolated splenium of corpus callosum region, and reversible splenial lesion with reversible splenial lesion syndrome. And so
CLOCC is a rare clinical and radiological syndrome that has been associated with various infectious etiologies. CLOCC is among the recently described neurological association with COVID-19 infection, and a close differential diagnosis for CLOCC is ADAM. Transient lesions of the splenium are only really appreciable on MRI, where they follow three distinct patterns. The first and most common pattern is well circumscribed small oval lesion in the middle of the substance of splenium. The second one is more extensive, well-defined irregular lesions extending throughout the splenium and into the adjacent hemisphere, called as boomerang sign. More extensive extension anteriorly into the body of corpus callosum. So radiological features of ADM vary from small punctate lesions to tumefactive lesions, which have less mass effect than one would expect for their size, distributed in the supratentorial or infratentorial white matter. Involvement of the callosoctal interface in ADM is unusual, but both can present with features of encephalopathy, fever, ataxia, seizures, focal neurological signs. And CLOCC is usually, but not invariably, reversible. So, objective of my poster presentation is to present a case of CLOCC in a patient with acute onset encephalopathy and COVID-19 RT-PCR positive status. Case report. A 39-year-old male, known case of hypothyroidism, got admitted with a history of fever, chills, myalgia, and cough. So he had headache and giddiness, and he was drowsy for 1 day. So because of his drowsiness and increasing headache and giddiness, he was brought to the ER. In the ER, his temperature was around 1 or 2 degrees Fahrenheit. Saturation was 98% humid. Other vitals were normal. His GCS was 14 by 15. His GCS deteriorated further to 11 by 15 on day 2, and LP was done. CSF sample showed almost normal values. All these inflammatory markers, that is CRP, interleukin-6, PCT, D-dimer, ferritin, and LDH were elevated. So at this point of time, MRI was done. We showed restricted diffusion involving entire corpus callosum extending into deep white matter with an ADC reversal. No hyper and hypo intensities were seen on T2 flare or T1. Contrast couldn't be done in this patient. So along with that, he was sent, a COVID-19 RT-PCR swab was sent, which came positive. So meanwhile, he was started on methylprednisolone at 1 gram per day, and he received it for 3 days. Along with it, he received remdesivir, N-acetylcysteine, Clexane, doxycycline, and other supportive medication like vitamin C. He improved symptomatically over time, and he was discharged to home isolation on day 5 in a stable state with a GCS of 15 by 15. And his COVID-19 markers were also, they also came down. A repeat MRI could not be done because of his financial restraint, but patient was doing well in the latest follow-up. These are the MRI images. Diffusion restriction in the extending throughout the entire corpus callosum and extending into the deep white matter also. So, in conclusion, we need to be aware of potential for CLOCC or ADM in acute COVID-19 patients. Unexplained unresponsiveness, weakness, or development of focal central neurological signs could alert clinicians to the possibility. MRI findings are characteristic and helpful in making the diagnosis. Treatment with corticosteroids should be considered in all these patients as these conditions are reversible.
Hello?
Yes, sir.
Yeah. No, contrast MRI was not done?
Not done, sir. At that
told it was not done.
Because he was very irritable to get a DW MRI, a lot of even basic DW was very difficult at that time.
Okay. And other comment I would like to make is,
sir,
that's okay. And a CSF RT-PCR was done?
Sir, CSF RT-PCR was not done, sir, but normal RT-PCR was done, sir.
Normal RT-PCR was done.
Yes, throat swab was done.
Even, yes, similar cases in there also. I mean, initial phases actually, because the all journals were accepting COVID papers easily, some did, some could not do. But the CSF RT-PCR may be positive or may not be positive. If it is positive, the association would have been much more stronger. Though still your hypothesis is right. Actually, repeating an MRI could have been much better. Okay. Okay, good.
Okay.
That's all. No comments from my side.
Thank you.
Next, I would like to call upon Dr. Vishnu Vardhan from Star Hospital. Dr. Vishnu?
Yes, sir.
Artifacts misleading as epileptiform discharges. You can share your slides.
Yes, sir. Sir, good evening, sir. Good evening, one and all. My objective of today's poster presentation is artifacts misleading as epileptiform discharges. Sir, here in the first EEG, which is a bipolar montage, and the corresponding referential montage. Sir, am I audible, sir?
Yeah, you are audible.
Yes, sir. Sir, this is a bipolar montage, sir, and the corresponding referential montage is put, sir. This EEG shows a burst of 30-second artifact, which is lasting for nearly 3 seconds, which is involving more of parasagittal and central regions than the temporal regions. And initially, when we saw this artifact, we thought it could be some epileptiform discharge, because we never thought it would have been linked to a telephone ring in the nearby vicinity. Later, when this was not present throughout the record and it was only a focal disturbance, then later when we retrospectively saw the literature and verified, then we got to know that this was a telephone ring artifact. And misinterpretation of this artifact would have been led to a misdiagnosis of epileptiform discharge. This is the second EEG, sir. This was attached to a patient who was intubated due to post-CPR status. When we were reviewing the EEG of nearly a 24-hour EEG post-CPR status, we found a brief repetitive generalized discharges, sir. This initially we thought of them as bursts. Then we thought of adding an anti-epileptic drug, but these were there throughout the record. And then later we have correlated this to the to and fro motion of the water droplets in the ET tube, sir. And benefit of doubt, we have done a suctioning, and after which for a couple of hours this have completely disappeared. And when they started reappearing, we have noticed that the to and fro motion of the droplets was there in the ET tube. So we have correlated this to the movement of the droplets in the ET tube. So these are ET tube artifacts. And this is a fine last EEG, sir, which shows a symmetrical, fairly generalized rhythmic theta activity, sir. This initially was when like initially as a resident, when I first saw the EEG and I had to report it, I initially suspected SREDA, sir, subclinical rhythmic discharges, because it had an initial onset and abrupt offset. But later, when in the discussion, I later got to know that this was because the laptop charger was connected, and SREDA wouldn't have involved all the leads in a uniform manner from the FP1 to almost the central leads equally. This was a laptop charger active fact. When we have connected, this has come, and almost instantaneously when we have removed the charger, it has disappeared, and when we have reconnected it, it has again appeared. So these were the three interesting cases of artifacts, which would have been thought of as epileptiform discharges and would have started on anti-epileptic drugs. So we felt that maybe knowledge about these artifacts would have prevented us from labeling these patients as epileptiform discharges. That's all, sir. Thank you.
I have some comments to make. See, actually, these are all artifacts we usually see in the EEG room. I mean, okay. See, actually, the first EEG, you told that you mistook it as an epileptiform discharge, but definitely it is not. Definitely it is not. Any epileptiform discharge won't be of so much of high frequency. So this is definitely an artifact. What artifact? Actually, yes, you came to know that it is a telephone ring artifact, but it is definitely an artifact. Seeing this EEG, we don't never think that it is actually an epileptiform discharge. Second discharge, okay. And the third discharge, as you told, actually the serida won't be seen in all the leads. It will be seen mostly in the temporal leads and the posterior leads, so, as you have told. But even this also is not considered, and in a first look, it is definitely not considered actually a epileptiform discharge, at least to people who actually see them regularly. Okay, so what I want to ask is, how can we actually avoid these artifacts? Whatever you're showing is a telephone ring and laptop charger. These are all actually electrostatic and electromagnetic artifacts, no? So ET tube, these are all actually you cannot avoid in a continuous EEG monitor when you are doing an ECG. What precautions will you actually do to actually avoid these artifacts? Can you just tell? What can you do? You cannot actually avoid the moisture, no? You cannot avoid our sisters or we actually carrying phone and ring, no? What we can do actually? You understood my question?
Yes, sir. Yes, I got your question, sir.
So what are the filters used?
Sir, maybe 60 hertz filter, 50 hertz filters are usually electromagnetic artifacts.
50 hertz filter, we call it as 50 hertz filter. What is that filter called?
Notch.
Yes. So what is the low cut filter and high cut filter? Setting at all these things at proper time, and especially in ICUs and all those things with lot of things, you have to switch off notch filter. Yes. Notch filter specifically cuts off all the electromagnetic and electrostatic artifacts.
Yes, sir.
Okay, this is actually good. I mean, you made a good attempt, but it is not so unusual that we don't see regularly. This is actually seen regularly.
Okay.
Good.
Thank you.
Next, last two posters. So may I call upon Dr. G. Shushma. Shushma is there? Shushma from Osmania Medical College. Dr. Sushma? Not Dr. Sharad Chandra from Gandhi Hospital.
Good evening, sir. I'm there, sir.
Yeah. You can share your slides.
Yes, one second. So, is my slide visible, sir?
Yes.
Okay. Good evening, sir. Today, I'd like to present an acute presentation of CNS lupus. There was a 16-year-old girl presented to the emergency department with history of low-grade fever, headache associated with blurred vision, nausea, and vomiting since 5 days, and multiple episodes of convulsion on the day of presentation, which were of GDCS type, followed by unresponsiveness. According to her mother, she was apparently asymptomatic 5 days ago. No history of any sore throat, cough, ear discharge, recent travel, or contact with TB patient, or no drug history. On further inquiry, it was found out that she took a 6-month course of anti-tubercular treatment for cervical lymphadenopathy and was transfused with 2 units of blood at the same time 4 years ago. And there was no past history of any diabetes, hypertension, bronchial asthma, or epilepsy. On examination, the patient was comatose and febrile. There was a mild pallor and GCS was 3. Her BP was high, 180 by 110 mmHg. The pulse rate was 96 per minute and respiratory rate was 12 per minute. Pupils were 3 mm bilaterally, normally reacting to light. Fundoscopy showed normal optic disc, but with subretinal exudates, flame-shaped hemorrhages, and cotton wool spots. Other cranial nerves could not be examined at that time, as she was comatose. She was not moving any limbs to deep painful stimulus, and reflexes were absent, and bilateral plantars were mute. The spine and cranium were normal, and there were no meningeal signs. On initial investigations, hemoglobin was low, RBC was 3.2 ml per CUMM, and PCV was 28%, MCV was normal, and WBC counts were normal. ESR was slightly elevated, 40 mm at first hour. Serum creatinine was and blood urea were mildly elevated. LFT, thyroid function test, and electrolytes were within normal limits. She was negative for HIV and HBsAg. ECG and chest X-ray were within normal limits. Her CT scan showed bilateral diffuse, ill-defined white matter hypodensities in the parieto-occipital area, which we thought in the background of hypertension, we considered it to be possibly due to press. In the CSF analysis, the CSF was clear, the PANDIS was negative, there were no cells, glucose was normal, but the proteins were high at 231 mg per deciliter. With this scenario, we considered the possibility of press or uremic encephalopathy or meningoencephalitis or CNS TB because of history of ATT for cervical lymphadenopathy. So we started our own anti-seizure medications and antihypertensives and broad spectrum antibiotics, after which she recovered after 4 days to full GCS and seizure freedom, without any focal deficits, but with complaints of headache and blurred vision. On further investigation, ultrasound abdomen showed grade 1 fatty liver, bilateral grade 1 renal parenchymal changes, and mild ascites. Urinary total proteins were high, and creatinine clearance rate was borderline. And her MRI showed bilateral asymmetric ill-defined lesions at gray-white matter junction at insular cortex with white matter edema, which was T1 heterogeneous and T2 heterogeneous to hyperintense, and diffusion restriction showed diffusion imaging showed restriction and blooming on GRE with mild peripheral rim enhancement on contrast. And based on MRI findings and CSF analysis, we considered the possibility of vasculitis, and ANA profiling was done, which was 3+, and ribosomal P protein was positive, Rho and SSA came out to be positive. So considering the diagnosis of CNS lupus with background nephritis, we started on IV methylprednisolone and was started on immunotherapy with cyclophosphamide due to financial constraints. Cyclophosphamide was given at dose of 750 mg every 2 weeks for 6 doses, and is and she's on maintenance with hydroxychloroquine, half-yearly cyclophosphamide maintenance therapy. She showed steady improvement in her general condition and was symptom-free by 2 months of therapy. Repeat MRI showed only a small focus of T2 hyperintensity in the white matter. She is currently under regular follow-up at her OPD and at a rheumatologist for the nephritis. So on the right, we can see the initial CT imaging, which is showing parieto-occipital hypodensities, for which we initially thought it could be reversible posterior leukoencephalopathy. But on day 3 of her admission, MRI was showing T1 hypo and T2 hyperintensities, which were a little bit in a different location and which were contrast enhancing. And after treatment with steroids and immunomodulation, the repeat MRI after 2 weeks showed complete disappearance of the lesion, but only a speck of, but for a speck of hyperintensity near the insular cortex. So CNS lupus refers to various psychiatric and neurological manifestations that develop secondary to the involvement of CNS in patients with SLE. It occurs in nearly 75% of cases of SLE, especially during the first year, but it is very rarely a presenting feature, as seen in this case. The commonest findings are cognitive dysfunction, headache, mood disorder, strokes, seizures, polyneuropathy, anxiety, psychosis, and movement disorders. Neuropsychiatric SLE is likely to be initiated by inflammatory, thrombotic, or cardioembolic etiologies, and further exacerbated by antibody, cytokine, and cytotoxin mediators. In studies on pathology of CNS lupus, vasculopathy, infarcts, and hemorrhages are often observed, whereas vasculitis is very rare. There are no specific signs to differentiate between CNS involvement of lupus and rheumatic diseases and CNS infection. The clinical distinction is always vague and remains difficult in certain patients because of overlapping clinical features. Differential diagnoses include toxic leukoencephalopathy caused by the therapeutic agents for the rheumatological condition itself, or hypertensive encephalopathy, and metabolic complications involving the nervous system, such as hydroelectrolytic changes. The clinical presentation does not allow discernment between the primary anxieties of the CNS symptoms are non-specific. Also, MRI and lab findings, including the CSF analysis, are rarely specific. Only a combination of several diagnostic procedures, additional specific serological tests, and if possible, stereotactic brain biopsy may ensure a firm diagnosis. With this presentation, I want to highlight the possibility of CNS manifestations as a presenting feature of SLE, and also the possibility of acute presentation such as encephalitis and importance of early identification and treatment to prevent residual disability.
Hello.
Hello, sir.
Dr. Sharad. No, I have a few comments. No, what is the APLA antibodies you did?
Sir, she came out positive for one second. She came out positive for ribosomal P protein and Rho and SSA, sir.
Yeah, but APLA also you should do. You should do, no? That is actually a protocol also. One.
Hello.
And we've done the whole profile, sir. These were the things which came positive, sir.
And second thing, just I wanted to ask you a question. Why did you not consider ADEM based on the radiology? ADEM.
I saw it.
Yes, sir. But the background of renal dysfunction and hypertension and presence of changes of chronic hypertension in the retina, we directed our investigations towards
actually your point is well taken. Based on the other pictures you took it, but radiologically, whatever you have shown, parieto-occipital lesions, large lesions, that too with a peripheral rim lesion, with DWI, mild hyperintensity and restriction, we should consider ADM as a possibility. Actually, over press is not a possibility based on these radiological images. It's not the first possibility, definitely.
Yes, sir. Press was our consideration before MRI was done, sir. But after we found that there was diffusion restrictions and there is mild change in the location of hyperintensities, we ruled out it could be press, sir. Because by the time MRI was done, it was nearly 5 days after the presentation and her BP was also normal at that time, sir.
What about angio?
Sir, angiogram could not be done, sir, because of the financial restriction.
Thank you. And see, whenever you present such cases, you should come with lot of images. So you should present all the sequences of images, DWI images, ADC images, T1, T2, and flare, because that adds to more color of your, more flair of your presentation. Okay, so those are all very important. Even actually you have showed T2 flare, but you have not, repeat MRI, you have showed flare image, but you have not showed the flare image in the T1, T2 in the preceding scan. So when you show the representative images of both, then that it will give a good catchy picture of what you are actually presenting. So we understood that whatever you have presented is. Other thing, one more question. Which of the antibodies you think are very specific for the CNS lupus?
So it is anti-neuronal antibodies, sir. And next,
even in the anti-neuronal also, there are a lot of antibodies, no? So which antibody you think is more specific to CNS lupus? If this antibody is present in a patient with ANA positivity, that patient may develop CNS lupus, or it is most likely to be positive in CNS lupus. Any idea?
No, sir.
Actually, which you have actually done also. Ribosomal P protein, if it is positive, then it is more specific for the actually CNS lupus.
Okay.
Okay. Thank you. Good case, but representative images could have been much more better.
Okay.
And another presentation next. Can I call upon Dr. Mary from Care Nampalli? Dr. Mary. Dr. Mary. You are able to hear our voice?
Yes, sir.
Yeah.
Can I
see your slides? You can start.
Yes, sir.
So the case I want to present today is a case of septum pellucidum cyst in an adult. So introduction, the cavum septum pellucidum, also known as the fifth ventricle, a potential space between the two leaflets of the septum pellucidum, at least 1 mm apart. It is an anatomical variant, common in newborns, gradually disappearing during infancy. It can, however, persist and is seen in 85% of the neonates and 17% of adults. It is sometimes associated with repetitive head injuries with higher prevalence among schizophrenics. Septum pellucidum cyst is defined as lateral bowing of septum pellucidum leaflets with width greater than 1 centimeter. These cysts are relatively rare, with prevalence of 0.04% among patients undergoing imaging studies. Expanding cysts can cause significant neurological dysfunction. The most common presenting symptoms are intermittent headache and loss of consciousness, possibly due to sudden transient obstruction of the foramen of Monro. Obstruction of interventricular foramen of Monro can also cause papilledema, emesis, increase in head circumference. Impingement on hypothalamo-septal angle can cause neuropsychiatric, autonomic, and visual symptoms such as emotional lability, bizarre behavior, change in mental status, decline in academic performance, sleep disturbance, incontinence, anorexia, abnormal epigastric sensation, hypothermia, and weight loss. Direct pressure effects on visual structures or secondary to hydrocephalus can result in neuro-ophthalmological symptoms such as nystagmus, sixth cranial nerve palsy, impaired visual acuity, visual field defects, papilledema, optic pallor, and retinal hemorrhages. Distortion of vascular structures with deep venous drainage impairment has also been described. The most common treatment indication is headache, commonly not associated with significant hydrocephalus. In patients with headaches and CSP cysts, an intracranial pressure measurement may clarify need for surgery. A 39-year-old male, clinical findings, a 39-year-old male presented with headache of 20 days duration with no symptoms of vomiting, diplopia, blurring of vision, behavioral changes, or disturbances in sleep or appetite. He has history of headache on and off in the last 15 years. He was evaluated with CT brain, which showed a cavum septum pellucidum cyst with a diameter of 22 mm. As he has no signs of raised ICP, he was managed conservatively and he comes for regular follow-ups. Conclusion: symptomatic septum pellucidum cysts are distinctly rare. Symptoms are secondary to narrowing of interventricular foramina and compression of neighboring neuronal structures. For patients with symptoms of hydrocephalus or progressive neurological deterioration, neuroendoscopic fenestration to relieve the pressure effects is an effective therapeutic method. Other surgical techniques are craniotomy and open fenestration of cyst, placement of ventriculoperitoneal or cystoperitoneal shunt, stereotactic fenestration. Spontaneous collapse of cyst has been reported. Conservative treatment with clinical and radiological follow-up is advised in patients without hydrocephalus. These are the images, sir. This is the axial image. The diameter is around 22 mm. This is the coronal image. You can see the cyst here. Thank you, sir. Hello?
Hello?
Yes, sir. I finished.
You are able to hear me?
Yes.
Do you think this cavum septum pellucidum is symptomatic?
Yes, sir, because he was complaining of headache, and headache is the most common symptom, sir. And it is a significant dilatation also. It's more than 1 mm, 1 centimeter is considered significant. His is 22 mm, sir.
What I meant to ask is, you think the patient's headache, how did you manage him? Then it subsided without treating it?
For now, he's on NSAID, sir.
That's what
yes,
NSAID is a symptomatic therapy, no?
Yes, sir. Yes, sir.
No, I don't think the septum cavum pellucidum we see in many patients. Septum cavum, it is an actually incidental finding in many patients.
Yes. Yes.
So very rarely we see. Actually, it is you may have done the CT scan or the MRI for the headache because it is new daily persistent headache. But this cavum septum pellucidum, I don't think it is actually symptomatic in this patient. So in what way it will cause symptoms? By increasing the raised ICP, no?
Yes, sir.
So what are the findings of raised ICP on a CT scan?
Sir, my effacement of sulci.
No. So whatever actually you are actually showing is actually supraganglionic level, very high cortical cuts. I mean, just subjacent to the cortex. I don't think there are any. You should show the complete CT scan. Next CT scan.
Yes.
That is in the coronal cuts.
Coronal cuts.
Sulci are preserved. So I don't think it is actually symptomatic. I will not buy it. One thing. And second thing is, why do they develop?
Actually,
I mean, what is the development of the ventricular system? Do
actually,
you know?
yes, sir. The septum pellucidum starts developing at around 11 to 12 weeks intrauterine life, and by around 3 months postnatal life, it is closed. The two septum come together. When we do the anomalous scan, the septum pellucidum should be present, because if it is absent, it can be associated with other conditions like septo-optic dysplasia, then lissencephaly, schizencephaly, and all. So it is there. It starts at around 11 weeks. Then the potential space is there between the two leaflets. It gradually it starts to recede after birth, and by 3 months, in most of the babies, it disappears. But it can, it can be present in 85% of full-term neonates, and sometimes it can present even into adult lives.
Just I'm asking just to. Just it may not be related to the case. What is colpocephaly? Okay.
I'm not sure.
Okay. So no, actually, I don't think it is actually symptomatic. Such patients won't just respond to NSAIDs like that. Okay.
Actually, we have a very little follow-up, sir. It was only a month ago. So we have put him on follow-up. So the centimeters, the diameter, it's almost 22 mm. That was what has made us to think more about
even otherwise also we see such such pellucidums, whatever CT you have shown. You have done the MRI also?
No, sir. Only CT we have done, sir.
MRI could have been more better now, all sequences at various levels. So we would have actually get to know more, the pressure effects would have been more evident there.
Yes, sir. Yes.
So,
yes.
Thank you.
Thank you so much.
The last presentation is from Dr. G. Shushma. Shushma? Shushma is there? Shushma? Hello? Hello? Srinivas? I think that's all. We don't have anything. Shushma we have, but hello? Okay, then thank you all. We'll end the posters. Thank you.